Good morning, everyone, and welcome to our 2025 SpineFEST. And I'm Michael Failings, and I'm joined by my friend and colleague Albert Yee. We're the co-directors of the University of Toronto Spine Program. So welcome, and we're very honored to have as our Tatter Hall visiting professor. Professor Michael Wang from Miami, and we'll more formally introduce Michael a little bit later this morning. And we have a number of people that are here that we'll wish to thank and to acknowledge. We've got a kind of a few introductory slides, and we often kind of just give a little bit of an overview, and Albert and I will kind of share the kind of the opening remarks. But the University of Toronto Spine program is a collaborative program in the Department of Surgery. We're very grateful for the support from the Department of Surgery and also from kind of two of the core divisions, orthopedics and neurosurgery. But the program is very multidisciplinary in nature. We have a number of non-operative disciplines, we have educators, we have researchers from the various teaching hospitals and from the main campus of the university. So it's very interdisciplinary in nature, which I think is reflective of the specialty of spine surgery. And so, really our vision is focused on innovation and excellence in the delivery of spine care through the integration of clinical expertise, research, teaching, and education. And Albert and I have had the privilege of really serving in a leadership role. And I know for myself, it's been a great source of joy. And Albert and I have enjoyed a great friendship over the last several years, and we're also very grateful for the tremendous support from our program manager, Nadia Jaber, and we've also benefited from a tremendous volunteer support, and we wish also to acknowledge Jane, our current volunteer. We have two of the three people on this slide here this morning, so we'll hear in a few minutes remarks from Professor Carol Swallow, our chair, Department of Surgery, and Peter Ferguson, chair of orthopedic surgery. And Jim Rucka sends his regards. I believe he's currently on a medical mission in the Ukraine. We've got a fantastic faculty, and Michael, you met a few of them last night at an informal a dinner, and the faculty is very interdisciplinary in nature, and it encompasses the various specialties and disciplines in spine surgery at the various teaching hospitals and also the main campus of the University of Toronto. So this slide kind of summarizes, if you will, kind of how the spine program has grown, and the reality is that spine surgery predated the inception of the university program in 2009, but I think the feeling in 2009 was that we needed to evolve and to formalize the University of Toronto program. And to establish this in a multidisciplinary fashion. So this was quite an important decision, and I would say that the University of Toronto Spine Program has become really a model of an interdisciplinary program in the Faculty of Medicine at the University of Toronto. And so, right off the get-go, we sought to establish a framework of collaboration and to be very broad in the scope of collaboration, and we have reached out to the main campus of the university, all the various teaching hospitals, all the various disciplines engaged in spine care, as well as research and education. And there's also been a significant effort to reach out to other communities in the Greater Toronto region, but also to be thinking about how to be networked provincially, nationally, and also internationally. And this will be reflected in some of the comments that Albert will make in a few years. One of the core elements of what we do is related to education, and so we kind of sought to consolidate the fellowship training programs and to maintain the excellence in terms of mentorship with fellowship mentors at the various teaching hospitals, but also then to bring this under the auspices of the umbrella of the university. And so this is, I think, kind of reflective, and Albert will speak about some of the new developments in terms of the recognition of spine fellowship training at the Royal College of Physicians and Surgeons of Canada, which is a major development. SpineFEST, which is our 17th anniversary this year, and this was actually founded by Albert and predates the development of the University of Toronto program, is really kind of our premier academic day, and today we will celebrate the amazing work of many of our trainees, our faculty, and of course this will be centered around Professor Wang's keynote address. One of the elements that we've sought to do is to standardize the fellowship curriculum, and part of this was to develop a surgical case log, and this information was actually quite critical in terms of the ongoing work that has culminated in terms of the recognition of spine fellowship training by the Royal College. Research is a core mission of our university-based program. This is consistent with the spirit of the University of Toronto, and this is I think really kind of been an amazing experience to kind of to see this interdisciplinary research growing through the program. And then increasingly we have sought to try to be strategic in terms of our role as advocates for patient care and to enhance the experience that patients have in our complex healthcare environment. And in a small way, our program has kind of helped to shape that mission as well. So on that note, I'm going to ask Albert to kind of take us through the remaining slides to kind of fill out a little bit of what I've briefly summarized.
Thanks so much, Michael, and good morning, everyone. It's really terrific to see everyone at our 17th annual SpineFEST meeting, and a distinct warm welcome to our key visiting professor, Professor Michael Wang, and it's terrific to see the many faculty, both sort of from the clinical side as well as our scientists across several different faculty areas, our students, residents, fellows, graduate students, and trainees from both the clinical as well as fundamental streams. So it's really a terrific opportunity for us. We've got key folks from Allied Health and the multidisciplinary interprofessional team, and so a warm welcome. As Michael's alluded to, we've strategically over the years been working to really expand our academic calendar of events, and our governance structure is focused around a program council that includes educational and sort of research elements within it. We've taken the opportunity over the years to highlight several of the key hospitals where there's academic activities relating to spine care and related sort of research, and put together a bit of a visiting professor series where different hospitals throughout the course of the year host visiting professors as part of the program. There's been cadaver courses that have been in place for many, many years, even prior to our program, led previously by Dr. Eric Massicott and more recently by Dr. Lewis and Chris Nielsen, that have been exceptionally well received, and we continue to grow those surgical skills opportunities within our program, and certainly we look forward to some of the cutting edge remarks that Dr. Wang will have in terms of proficiency expertise relating to advancements in surgical techniques. Journal clubs throughout the year. We've also implemented a mock oral session for final year graduates in orthopedics and neurosurgery, preparing them for the Royal College exit examinations, or I guess the Canadian equivalent of the board certification process. And many of our alumni fellows take leadership opportunities and lead many of those sort of case discussions on behalf of our trainees, and we're certainly very grateful for that. There's been several long-standing spinal symposium and meetings that have been held within the city, and that's sort of been brought within the umbrella of the program. So, the Tatter Turnbull lectureship that Dr. Tattle and Phalines have led for numerous years. And a variety of international meetings, many thanks to Michael and other connections internationally, have been sort of brought into the city, which has been a great opportunity to highlight some of our activities from an international dissemination perspective. In terms of, I guess, during the pandemic, we didn't stop during that period of time, and we implemented a traumatic spinal cord injury course that's been led by Dr. Sukhvinder Kelsey Ryan, who's at the Toronto Rehab Institute. It was actually a virtual course, and coming out of the pandemic has sort of segued into a bit of a hybrid model. So there's sort of virtual educational models in advance of the in-person meeting, which has really been terrific, I think, for our citywide fellows, and really gaining the current concepts in terms of classification and approaches to care for individuals with acute spinal injury. The last couple of years, our colleagues at the Sick Children's Hospital, so Dr. David LaBelle and the multidisciplinary team, have put on a terrific course in terms of pediatric deformity surgery, and I think increasingly we're recognizing the increasing subspecialization within medicine and surgery, and certainly spine surgery and related care is not immune to those sort of trends. And last year, it was a very landmark year for us within the University Division of Neurosurgery, sort of a 100-year celebration, and we obviously had programming and participation there as well. And as Michael's alluded to, over the last few years, we've been working on, with colleagues around the country, on developing a diploma program for the more formal recognition of fellowship education at the Royal College level. So this will be certainly a first in Canada, and I think we've had within those efforts opportunities to interact with our international colleagues and sort of common areas of educational focus. It's very much a competency-based approach, and builds from some experiences Dr. Peter Ferguson and others have certainly led within the university that has really gone global in terms of competency-based medical education. And within that diploma, basically it will enable fellows that have completed training at an accredited center to receive a DRCSC above and beyond their sort of board orthopedic or neurosurgical certification. And right now, sort of at this time, through a bit of a panel with the Royal College, we have finalized sort of 3 documents relating to this program. They're currently being translated from English into French and should be available within the university AFC offices imminently for programs to sort of apply. And I think we're quite well poised here within the city to apply and to deliver that content. Because it's competency-based, it sort of builds upon residency and sort of takes things from basic competency through proficiency and expertise, and obviously standards of accreditation for various programs. Michael's already acknowledged our many sort of volunteers within the program, so many thanks to Delphine, who was our first volunteer, I guess, a couple years ago, and Jane currently today as well. It's been a terrific opportunity for us to provide some opportunities to have undergraduate students sort of exposed to areas of sort of spine health, and I think Jane will be providing a bit of a more personal performance this evening in celebration of our fellows as part of our celebratory graduation dinner for our citywide fellows. Our fellows come from around the world. We train about 13 to 15 fellows each and every year at our fully affiliated hospitals, and about half of our fellows come from international backgrounds. The diploma program actually will be eligible, irrespective of whether you graduated from a Canadian or foreign-trained medical school, and so that's terrific. And there's both adult and pediatric streams. And just say congratulations again to this year's sort of graduating fellows, and we'll have a bit more of a formal dinner function this evening, and look forward to Dr. Wang's perspectives on pearls and becoming an expert spine surgeon and a career path in spine surgery. Acknowledgement of all the faculty that participated in adjudicating the abstracts that have been selected for formal presentation and awards later on today. So I look forward to the presentations by our students, and so many thanks for all your long-standing support and contributions to our program, and we look forward to hearing about your successes. And many thanks again to Drs. Swallow, Ferguson, Rutka for the university support, very strong support of our program, as well as a variety of industry partners that have been long-standing and more recent supporters of our program educational events. So at this time, I'd like to call upon Dr. Carol Swallow, our R.S. McLaughlin University Chair in the Department of Surgery, for some remarks. Many thanks again, Dr. Swallow, for all your strong support of us.
Thanks, Albert and Michael. So it's really a pleasure to be here this morning and to bring greetings and welcome you all on behalf of the University of Toronto Department of Surgery. We're extremely proud of our spine program and of the 17th annual SpineFEST. And I want to give a lot of credit to Albert and Michael. I'm sure they're going to be applauded by many people, but could we start with a round of applause for our two leaders? I am really in awe of the spine program and how it's developed over the years and become so multifactorial. And in particular, I really value and admire its collaborative nature. And it's really a collective activity that bridges multiple disciplines and multiple departments, and even more importantly to me, multiple institutions. There are a lot of barriers, as some of you may realize, to collaboration across different hospitals, even though they're all part of the University of Toronto. And I think the spine program illustrates that this is possible to do and do very successfully. So that's a credit to everyone here in this room and everyone who's part of the program. I acknowledge the scientists in particular who contribute to this effort and are so important to the success of our clinician scientists. So kudos, hats off, and I'm sure you're going to have a fantastic day. Thank you.
Thank you.
Okay, also thanks Albert and Michael for everything you've done for the last 17 years in putting this group together. So once again, I bring greetings from the Division of Orthopedic Surgery, but I also want to express gratitude as well as sort of some amazement at the accomplishments of this, as Carol alluded to, true multidisciplinary collaborative effort. And it's not just between orthopedics and neurosurgery, but amongst various different departments, which I won't list for fear of missing somebody, as well as clinician, non-clinician scientists, trainees, preceptors, and so on. And you guys are really an exemplar of what a collaborative effort can be if people just put down any divisions and start to work together. And I think there's a couple of examples in the agenda of that dedication and commitment. Number one is the fact there are 27 abstracts listed. Any other division, I can tell you, or subspecialty in orthopedics, if we were to get 10 submissions from across the university, I would be amazed. And the fact you've got 27 submissions within spine surgery is just nothing short of incredible. And the other thing is that when you look back, and Albert showed the picture of what happened during COVID, if you look back on any proceedings over the years, there's always this blip, right, in 2020 and 2021 where nothing happened, everything sort of disappeared, fell off the map, but not this group. This group continued to put something together. They pivoted and continue to have an effective SpineFEST. I also want to shout out Professors Tatter and Hall for their immense contributions over the years in developing multiple generations of spine surgeons. Thank you for that. And also I'd like to welcome Professor Wang. Hopefully you enjoy the proceedings today and continue collaboration between our centers in years to come. So thank you, everybody. Have a good day.
Thank you, Carol and Peter, and in spirit, Jim Rutka, for your kind words and support. I wonder if we could perhaps ask Professor Tatter to come up, and I think we have Professor Hamilton Hall joining us virtually, so we'll see how this hybrid option works here. There he is. There's Ham. Very good. Charles? Welcome, Ham.
As usual, do you want to go first?
You always go first, Charles. I stand behind you, and when you're done, I always say, me too. Only this time I'm on the screen, so I can look even bigger and larger, and you go ahead, and I will finish up by saying, me too.
Is that a scrub suit you're wearing or pajamas?
No, it's actually a dress shirt, a short-sleeve dress shirt. I'm all tidied up for this meeting.
Well, as you can see and hear, Hamilton Hall, I call him Hammy. No one else is allowed to call him Hammy. But we actually studied together for our fellowships, and it was a great study group. Everybody passed in the study group, even Hammy. And he went on to do some remarkable things in developing a better way of treating people with back pain through the Canadian Back Institute. And then he also went on to develop the Canadian Spine Society, and he's continued to nurture that organization. Very remarkable. And equally remarkable is the duo of Albert and Michael, who have maintained the quality of this event and the quality of the spine program at U of T for almost 2 decades now, which is really a remarkable achievement. And certainly my involvement in the spine also goes back several decades when I was first introduced to the spine by Dr. Gordon Murray, who was a very well-intentioned and marvelous surgeon, and I had the opportunity to watch him do one of his operations on the spine, and in those days, general surgeons operated on the spine, believe it or not, and I had the privilege of watching him expose the spine in a patient who could ultimately crutch walk. And perhaps very few people here know what the term crutch walking is, but it is the ability of a quadriplegic to actually walk with crutches. And that was my first indication that these folks can be rehabilitated, although Gordon Murray's ultimate contribution to the rehabilitation was rather small. But many important discoveries have been made over the years. And in terms of our guest today, Dr. Michael Wang, it was quite remarkable to have a firsthand view of the Miami project, which figures very large in my growth and development of a career in spine surgery through Barth Green, who invited me at one time to be an advisor, quote unquote, to the Miami project, which is one of the thrilling opportunities that I had to see spine research flourish as it did at the University of Miami, and the project that the Bonaconti family, who had a quadriplegic member, develop. So I'll really look forward to Michael Wang's talk, and good luck to the program, and thank you very much for having me speak a few words.
And I get to say me too just before Michael takes over. So, Michael, if I could just, before you take over the podium, let me just say that everything Charles said I agree with. And the point I'd like to make is that I started my training in orthopedics, and my first rotation was on neurosurgery at the Western Hospital. Charles was the chief resident. I was the very, very junior attendee. And it was considered very unusual for an orthopedic surgeon to spend time on neurosurgery. In fact, I received some nasty comments from some of my friends and colleagues about why I would waste my time with a neurosurgeon when I was actually an orthopedic surgeon. And I must say that from that moment on, from the time I spent those 6 months with neurosurgery with Charles, it changed the way I approach spine. And I think that your program, combining these two specialties along with many others, has done a great deal to improve spine care and to take it out of the silos and make it something that really does drive us all. So those are my comments, and thank you very much for letting me attend. I will be back in person next year, I hope, and we will just keep going forward. Michael, thank you.
Thank you, Charles and Hamilton. And you know, as I said in the opening remarks, although the program was founded in 2009, in truth, you know, we were really, I think, formalizing and really building on tremendous leadership that had occurred over many years, and we're really grateful for the mentorship of Charles Tatter and Hamilton Hall. So at this stage, it's my privilege and pleasure to introduce our keynote speaker, Professor Michael Wang, who is a professor of neurosurgery at the University of Miami. And to just kind of take a personal note, there's actually a very long-standing friendship and collaboration between Toronto and Miami. And in fact, the current chair of neurosurgery is indeed one of our former trainees, and he has shown tremendous leadership. And as Charles has indicated, you know, there's a long-standing collaborative friendship between the Miami Project to Cure Paralysis and the University of Toronto, going back to Barth Green, more recently to the current chair, Alan Levy, and as well to Dalton Dietrich. But on to Professor Michael Wang. Well, he has an impressive bio. I think most importantly, he's an amazing human being. He's a great person, a lot of fun to be around, extraordinarily modest and humble despite his various accomplishments. So his bio is in the brochure, but I'll just kind of touch on a few points. So Michael was born in Scottsdale, Arizona, which is just an absolutely gorgeous part of the world. Attended Stanford University, where he received his undergraduate and his medical degrees. And I think that experience at Stanford has really kind of informed kind of a lot of his subsequent career, because of course I think Stanford is really one of the hallmark institutions related to bioinnovation, if you will, and I think that spirit of innovation I think has inspired Dr. Wang in his career. After completing his medical degree, he then did residency at USC. And which is really kind of one of the iconic residency programs in the U.S. And I think that was a very special time. There's a lot of very special leadership at USC at that time. And then subsequently did a fellowship at the University of Miami under the mentorship of two individuals that we've mentioned, Barth Green and Alan Levy. Subsequent to that, Michael went back to USC, where he really established really kind of a world-leading a program really kind of focused around bringing innovative ideas and techniques into spine surgery. He's probably best known for a lot of his advances in minimally invasive surgery, but in truth, he's done a lot that really goes beyond that in terms of shaping optimal care pathways, educational programs, and also the spirit of collaboration. After kind of establishing himself at USC, he got lured back to Miami, and where he has been since 2007. I didn't realize it was that long, right? It just seems like yesterday. It's amazing how time flies. And he's really established an amazing program in spinal neurosurgery at the University of Miami. He also is the director of the fellowship program. A number of our Canadian trainees, in fact, have been to Miami. So again, in the spirit of the close collaboration, that we've had. Michael has a number of leadership positions in neurosurgery, you name it. He's been involved with these at the spine section, the AANS, the Society of University Neurosurgeons, just to name a few. So, Professor Wang, we're very honored to have you here, and we look forward to your keynote address on ultra MIS spine surgery.
Thank you, Dr. Yee, Dr. Failings. I want to echo Carol Swallow's and Dr. Ferguson's comments. It's very interesting. I'm getting a little long in the tooth. I'm about 25 years out of training. And for the folks here who grew up and were raised in this great university, it might not occur to you, and it would occur to people who come from the outside, of what a special place this is. And, like I said, I've been privileged to have been visiting professor in over 60 places, all the household names. And I'll say this very openly, this is by any measure, whether it be research, education, clinical productivity, the most formidable spine program I've seen. Michael Failings gave me a nice tour, and we talked last night about this, and it is really very easy to take that for granted. In Miami, we call it the Garden of Eden, that we have a very special spine program. And it's very easy to make the assumption that that's a natural state of affairs, right? But the reality is something that has to be protected, groomed, and nurtured. So I want to start out by just saying so many great friends here. I have been in awe of Dr. Tatter's contribution since I was in medical school. Dr. Failings, of course, is regularly recognized as one of the top cited in the top two researchers, and I'll get to that in a second. I've known Dr. Ramprasad through our work in NASS. He passed off the MIP section to me, so I have great respect for what he's done. Stephen Lewis and I have worked together, and Albert Yee, we don't need to even comment on how much he's contributed. And when you think about, the situation, we're in fractious times now. I did not realize there's something called a 49th parallel. And my wife is from the Canadian border, but I'm a child of the South, so I've never been anywhere cold. And I realized that the contributions from Canada, so many of my good friends in America, Alan Levy, who's my mentor inside of the spine world, and Jim Guess, and now Ann Parr, and of course John Holbert, a very dear friend, really have very strong roots here. And this is what I want to point out. Sometimes punching above your weight is under-recognized. If you look at, in terms of, this is just one of the many ways to assess, for lay people to assess, what's the impact in the world of spine. Here's Canada in terms of country, here's Toronto, and here's Dr. Failings, number 2 in the world, right? And depending on, it could be number 1 or number 2, sometimes it's number 3, but it's in the top 3, right? You see I'm not anywhere near that. You gotta scroll a couple pages down and you'll find me. But this is something you should not take for granted in your training. This is something you should realize that is precious and valuable. And in terms of my personal experience, these are all the fellows that I've trained that are from Canada, with the exception of Eric Belanger, who was sort of like a co-fellow with me. But the crossover, the impact, the cross-pollination is one of the great strengths we've had, certainly in our institution. So, I'll start with this because any one of the professors here can speak for days about various topics of research and hobbies, if you will. My wife calls them hobbies that we do. And I'll just start with this, which is to say, let's talk about spine. It's so expansive. You could talk about pathologies of spine and how you choose to endeavor in research or clinical practice, or however you choose to put your stake in the ground for the young people who are like, I'm going to be an expert in spinal oncology or deformity or something like that. You could also approach it by technique in terms of how you're known, in terms of what your practice of surgery might be, and that's another powerful way to look at this. But the bottom line is, if you're not a spine surgeon, you may not see that there's all this wealth of abundance in terms of things and problems to tackle and how to best tackle them, right? So I'm going to speak just about MIS, and I'm going to try to take you to what I believe is sort of the razor's edge of MIS, because everybody in spine says they're an MIS surgeon now, and I think there's some truth to that, and it's a testament to success, right? So is it technique? Is it technology? Is it approach? Is it a marketing ploy? Is it a philosophy of surgery or a philosophy of care? These all encompass elements of what we would call less intrusion into the natural biological, situation of the patients that we treat, and this is sort of a pictographic depiction of all those different elements of what you might think MIS would be, right? So I'm going to take you on my personal journey, and this was put together by one of my fellows who, this is on the cover of JNS Spine, the history of the covers that were MIS oriented and what it really meant. And if you look back, you go, wow, this really changed. Nobody uses the sextant device anymore, right? So I'll start with this, and this is just a simple example of mindset. So MIS might be a mindset. This is a lady, doctor's wife, who's had this scoliosis, which is marginal, forever, and she had seen multiple surgeons. They all recommended a T10 to pelvis or a T2 to pelvis. She simply had radiculopathy, right? And so all she really needed was something very small, like an endoscopic surgery, to fix that level. And she understood that she had this deformity for the last 50 plus years, and she was very happy, as you can see from the pre and post pain drawings. By the way, Albert, do you use the pain drawings in your clinic? Super powerful, prevents wrong side surgery, wrong site surgery. I can walk in the room and know within a second if someone has probably SI joint pain. This is very powerful for clinical practice. People can scribble and draw as they're waiting the hours and hours to see us, right? So this is a very fun and useful tool. Also demonstrates when people are getting better, right? Now, it's impossible to talk about spine as a field without understanding the context, or like called the Zeitgeist, right? What is the current flavor of Zeitgeist? How do you say it properly? Zeitgeist, I'm sorry. Where are you from? Are you from Austria or Germany? Germany, okay, Zeitgeist, I'm sorry. Again, typical American, right? Like I really can't speak anything but American English. So the environmental context, what are we talking about? So people always talk about this evolution of technique, of thought, of culture, but what people forget about is that in order for there to be evolution, there has to be obsolescence. Something has to sort of give or die to allow something else to sprout and grow. And so when we look at the tree of life of spine surgery and you say, what are the kinds of developments that are happening in terms of this? And I apologize to anybody, maybe Steve, you don't do cortical fixation, do you? No, it's right. It's pretty much extinct, right? But you look at there's ultimate dead ends of this tree of life, right? And I'm not saying that the procedures don't have value. I'm saying that many of the things that I do today, people are going to look back and say, that was so stupid. Why would you do that in 2025? That is so obsolete and unimportant in terms of what happens in the world. But it is a process of development, of a response to the environmental context, which is pressure. Okay, now I'm going to sort of dive into the talk as a typical American, right? So I've given these kinds of talks outside of the U.S., but it strikes me that as Dr. Failings and I have spent a little time together, that there's a lot of similarity actually between certainly Toronto maybe and what happens down south of the 49th parallel. So this is from someone who's sort of well known, who's talking about the trends in fusion techniques and trends in general of what's happening. And the reality is things are getting more complicated. People are doing bigger and more complicated surgeries over time. Why? Because we have the capability, and also because the pathologies are more complicated, right? People are living longer, right? So this is an important trend, but we're up against something very fundamental here. You do have a great business school on this campus, right? So I got my MBA a couple years ago, and I started to delve very deeply in this concept. And this is one of the fundamental concepts that most people in healthcare do not realize. It's called Baumol's cost disease. What it means is that there are only two sectors, in essence for us, that have been costing more with less relative return in value, and that's healthcare and education. Cost of college tuition, right? So everything else, every other environment has had a drive for efficiency, scalability, and efficacy, right? So let's take an example of that, okay? So I know that Moore's law does not apply to medicine directly. It's on computation. But if you look at, and by the way, Moore just died this year, I think, right? But the idea was a doubling in terms of computing power every 2 years. And if you look at, for example, the power of an iPad, right? The iPad's like $100, $200, maybe 115 Canadian, right? So you go to your local store, your Walmart or whatever you buy. What's the Walmart here, Albert? Walmart, that's Walmart. Okay, there you go. You go to the Canadian Walmart and you buy or you order on Amazon the iPad, and you look at the cost of computing power. If you go back just a couple of years, right, you see that the cost of that computing power is enormous. Now, this is what Wall Street, for example, would demand, okay, or the London Exchange or Japan on the Nikkei, right? They're saying, why are we not getting better at what we do? And the answer we would say is we are getting better. But the incremental benefit has been very, very slow and very marginal. So this is what motivates me. I was interviewing Dr. Failings for the Neurosurgery podcast. I asked him, what motivates you to get up and do this great research, which is phenomenal, by the way, on this campus. This is what motivates me for the last 10, 15 years, which is this existential threat to spine surgery. No field of medicine in America is more in the crosshairs than spine surgery, okay? There's zero question. We are the most likely doctor to be killed by a patient in relative per capita terms. Psychiatrists are more likely to be killed as a general aggregate, but there's like 50 times as many of them as us. We're the most likely to be killed by a patient, right? There are a lot of factors of spine surgery that we don't have time to get into that we can talk about. But my concern is that I believe in spine surgery. I will not burn out. I'm not that person. I'm not going to burn out. I'm not going to be that guy that gets older and says, and I really mean this, yeah, we never should have done those things, and like, that was bad. I would say, well, we could be better at it, and at the time, it wasn't optimal because we didn't understand more, but I will not be going back and saying, oh my God, I shouldn't have done this, I shouldn't have done that. And I say this as a man of great faith and resolution, that spine surgery is important. It works in the right patient. Spine problems are the #1 cause of disability, the #2 cause for a visit to a doctor, right? But we have problems. We have optical problems, we have competitors, we have a lot of things going on, and so I worry, and I'm sure that many of the SpineFEST former and future lecturers will tell you about how you need to do 3 rods, and then 4 rods, and then 10 rods, and then thicker rods, and more screws, and more cement, and more, because the only thing they're shielding against is the eventuality of the failure of their surgery, not the failure of the patient, failure of the surgery. And there's nothing wrong with what they're saying. But I would tell you, if you took that to any outsider, whether it be a governmental regulator, whether it be an economist, whether it be a philosopher or a priest, they would question, well, are you guys just getting ever siloed into your little hole of like spine surgery? Why not take this back out and say, look, what you're doing right now may not be optimal. We don't know what it's going to be, right? But let's look at this from a different lens. Let's look at this from an extinction event possibility. Okay, so everybody in this room is probably a little bit invested in spine surgery. What if tomorrow the government made spine surgery unfundable? Well, it's a reality, so I'm going to get to that shortly, okay? And that's my motivation for all of this, right? So I don't want to be that big T-Rex. Let's go back to T-Rex that was killed by, a meteor or the diarrhea or whatever it was. I don't know what it was, but the dinosaurs, the mega fauna of the previous era, hundreds of millions of years ago, are extinct now, essentially, right? So what has survived, right? What has survived are those little small pre-mammalian creatures that could survive that kind of adverse situation. So now we leave the Garden of Eden, and now you're in Manitoba or something like that. You're forced to do surgery, right? I'm sorry, I shouldn't dig on Manitoba, but you get what I'm saying. You get to a more sparse situation where resources are not as, someone's probably from Manitoba, I'm sorry if I offended anybody. But Dr. Failings was right. His instincts are right that I grew up and trained in Palo Alto, and Everett Rogers was from Stanford. The idea of innovation, right? Innovation is a concept, as a survival mechanism. Human innovation is the key. Systems-based process and human innovation is the key to the development of more and more civilized and capable situations for the human condition. So the MIS TLIF is a standard jumping off point, because if you think about it, MIS TLIF is really where you start to see the wide applicability and versatility of MIS surgery, right? So let's start a conversation about minimally invasive TLIF, which is how you fuse the spine and decompress the spine at a couple levels to treat the most common diseases that we see, right? So if you were to say, well, what's the advantage of MIS TLIF over an open TLIF? Still, this is a debate. People debate this still. Like, why do you have to do this MIS, right? So I'm not going to spend a lot of time on this. This is super boring, right? And this is, this is a morning talk. So this is a review by Kevin Foley looking at this, and there's a forest plot here showing that people have less pain if you don't destroy as much muscle. And this should be no surprise to anybody, right? But the fact that people still will not adhere to this as a principle will say, well, maybe there's something else that gives. Maybe this MIC lift we're doing is not good enough. What if we look at earlier normalization of life, right? Time away from work, time away from travel, time away from driving a car. It's very clear, right, that there is an improvement when we do these surgeries with a less destructive, less intrusive type of approach, right? That's pretty much well known. What about infections? We did this research, large databases. Infections are incredibly problematic because they add tremendous cost. They're big variance outliers for spine. Once a spine gets infected, that changes your whole rubric on your economic output. And if the infection rate's 2% versus 6%, that has massive economic repercussions for a clinical practice. And of course, when you don't open as much, people don't have as much of that problem, right? Spinal fluid leakage, same thing, right? This is getting boring, right? We don't have to go through all this data. Again, you see that there's less spinal fluid leakage if you don't expose so much of the dura that you don't need to see, and you can do all of those wonderful things. And this one, this is a very important thing, reductions in narcotic consumption. It's of course less because there's less pain, potentially leading to less opiate addiction, opiate-related deaths, et cetera, et cetera, et cetera, right? So these are all fundamental principles of saying, okay, do we believe that MIS even has any value? I think that's an important question to ask, right? And Dr. Failings brought this up about ERAS, and I think ERAS is a very important principle. And for the people who's taking a new job next year or this year, and all the fellows, you don't have jobs? Are you staying on for another year then? Everybody's staying on for an extra year? No? Okay. Some people are getting new jobs. And are you going to academics or no? Tiffany, was it? Community. Okay, all right. So I would tell you that one of the great privileges of being in a training program is young, creative people. You have access to them, okay? And in 2011, a young doctor came up to me, Karthik Madhavan, and he said, Dr. Wayne, you ever heard of ERAS? I'm like, ERAS, I don't know, right? He goes, no, you need to look at this ERAS. I mean, ERAS is the process by which you apply to residency program, right? There's an application form. He goes, no, it's just look it up, just look it up. And it was overtaking Western Europe in the general surgery world. And I will never forget being at NASS, and we had an auditorium of 1,000 people, and we put on a symposium on ERAS, and I said, anybody in this auditorium know anything about ERAS? And not a single orthopedic or neurosurgeon raised their hand. Nobody knew about ERAS, right? So it gave me an advantage. There's an old saying, right? If you're trying to build a career, you either got to be the smartest, which is really hard, you got to cheat, or you got to be first. Right? So we built ERAS programs, and again, I can go into great detail about what we did, but the idea is fast tracking. Now everybody's talking about ERAS, right? ERAS this, ERAS that, and it's a very important concept in terms of trying to save costs and drive outcomes. And as surgeons, this was another great motivator to me to build. We built one of the first ERAS programs in the world, certainly the first economically successful ERAS program in the world that was published. This shows you what colorectal ERAS developed into out of Denmark. And if you just go Google ERAS or you use PubMed, you'll see there's been tens of thousands of publications now in just a matter of like a decade and a half. This is one of the most important, would you say, Doctor? In general surgery, it's very important, right, as a concept, yeah. It's well established for 20 years. Yes, right. So in spine, like many spine surgeons are still like, what is this, right? And the funny thing is for us, it is actually more important than almost any other field, right? So I'll leave that and then transfer on to what we really want to talk about, which is how we leverage technology, because as surgeons, we like to operate, right? We like to do surgery on people to fix them. So let's start with a basic premise. I talked about MIS TLIF, and the question is, if you take the MIS TLIF developed in 2002 by Kevin Foley and Rick Fessler, it's essentially a tubular TLIF, right? So the question is, does tubular surgery, working through a tubular portal, mean it's MIS? Steve, do you need tubular surgery? Very little. Okay, all right. Decompression, I assume. TLIF? Sometimes, okay. So here's the first simple scientific question. What size tube is being used for TLIF? Anybody have any clue? Let's ask the fellows here. I know Raja knows. And if, Tiffany, I want to pick on you because you're the only one I know your name, right? So what's the average size tube used for MIS TLIF? Yes, exactly. In 22 millimeters, right? Now, there are many people using 28 millimeter tubes to do MIS TLIF. Now, Raj is shaking his head like, that's not MIS, right? So now you understand a fundamental principle why people say, like, there's no need to do MIS. Stephen Lewis would argue, you can't do as good a decompression as surgery, can't get lordosis. What is the purpose of using a 28 millimeter tube, sometimes bilaterally, right? And you add up the incisions and destruction, it's just as bad as an open surgery, right? What size tubes are we using? So simple math, right? You can look at 24 versus 16, and you think about, wow, that's actually quite different in terms of its impact on the patient. And of course, the surgeons will say, well, I need to see better, I need to do this, I need to do that. And the idea is, at least I'm getting you thinking about, well, tube, what do you mean tube? How big is the tube, right? Is it a pipe, okay? Now, traveling the world is important. And when I started to travel a little bit more, probably like 2007, I started traveling the world, I would go to places like mainland China, right? And this is a picture of a meeting in mainland China with 1,000 endoscopic surgeons. Now, if you go to China, these are users, right? They do it every day. If you go to China, every major hospital has 1 or 2 or 3 surgeons. They only do endoscopic surgery. They don't do ACDFs, they don't do deformity, they don't do trauma, they don't do anything but endoscopic surgery. They do about 30, 40 cases a week. Okay, and the Chinese work 7 days a week. And so they're doing so much of the surgery. I'm like, how is it possible they do this? And there's literally like 100 endoscopic surgeons in America. And does this just not work? Like these people are just doing like sham surgeries all day? There's clearly something different. And I said, I gotta go learn one more thing before I get too old to learn anything else, right? So a couple basic principles about endoscopy. I promise I will not be one of those endoscopic surgeons that shows endless videos, right, of how I did it, right? But you start to think about the world differently, looking around angles so you can do more and see more, right? And this is, we've now trained probably about half the endoscopic leaders in the country now that came out of Miami. But this is one of the first, Christoph Hofstadter, he was a fellow in 2012. And this is a textbook, and we started to think more about how we access the spine. Now, are there any brain surgeons here? No, not one brain, yeah? Budding, like spine curious or what? Okay. How many triangles are in the brain? 30, 20, okay. Good thing about spine, we're not quite like brain surgeons. There's one triangle, only need to know one triangle, Camden's triangle. And the reality is not even a triangle, right? It's a prism. And so Lou Tumial and I went deep on this. What is this access to the spine? How do we get to the spine through the space? And it's been misunderstood because it is not a 2-dimensional space. It's a 3-dimensional space. So you have to understand how to access this. Now, the great thing, again, about being not that I was first, but being at the leading edge, is you get to talk a lot about things and make stuff up and classify, and you get invited to nice places like this, right? So always try to be thinking about like, how do I be like on the front end of something, right? So this is just looking at Camden's prism, how you get there. So for the people who are more traditional, right, Camden's triangle is something different. When you do an open surgery, you say, well, the medial border of Camden's triangle is the thecal sac or traversing nerve root. So at L4-5, that'd be the L5 nerve root. So if you pull that out of the way, you've just made the triangle bigger. That's a traditional or open T-lift, right, to put an inner body cage in. So think about that from open surgery. Now, if you go to an MIS type of approach, what happens is you start to be delimited by the amount of facetectomy inferior facet you're removing, right? So you think about the amount of space you need. So you're starting to say, well, I'm going to drill enough bone or osteotomize enough bone to get me a bigger space, and then I'm going to work within that confine, right? But if you move into something like a percutaneous or endoscopic space, you're saying, I'm going to take essentially the native triangle, which is delimited now by the superior articular facet, and say, I'm going to access the disc space through something that's much smaller, right? So again, getting smaller instead of bigger in terms of your understanding of how the spine works, right? And then how do you get there? Multiple routes in, right? Multiple angles, and these angles really start to matter in terms of minimizing root injury, because again, you can't see everything the way you do with an open operation, right? So different kinds of access. So for the balance of this, I'm going to be talking about this type of access, which is essentially used for discography, disc biopsy, and endoscopic fusion, right? So other access ports and ways of getting decompression, for example, right? So that let us build, with this technological development, our Awake Spine Fusion program, right? So when we started this, we were kind of laughed out of the audience, right? Like, how do you do this, right? And people, there are many dimensions of this, and we called it the Awake Fusion program on purpose, to get people's attention, right? It's not marketing, it's not branding, it's a way of getting people to understand, wow, if you can do a fusion without general anesthesia, that is changing, that's moving the needle a bit, right? So this is where we built this program. These were the 6 elements, right? Endoscopic, awake anesthesia, percutaneous fixation, using expiral for analgesia, expandable inner bodies, and we use osteobiologics off-label in order to achieve this, right? So this is this is an early case, right? Spondylolisthesis treated, 65 minutes, 70 cc's of blood loss. The patient can leave the same day. I don't know if surgery centers are big here in Canada. We don't really try to do that business, but the reality is this is how you would build a surgery center fusion business. And so this is the first case I ever did. This is the dean of FAU Business School, so it's not a rat lab. So you can see I'm talking to him, I'm gonna do the surgery, and we're gonna do a fusion, right? We're gonna fuse that segment. He has a spondylolisthesis, and we're gonna do all this with, if you lost a shot glass of blood, it would be too much. And if there's any problems, honestly, you just flip him over and wake him up, and you know, you don't have to extubate him or anything like that. This is a complete paradigm change in terms of fusion surgery. Now, again, think about why we're doing this. There's a lot of reasons to do this stuff, right? One of the reasons is to understand the existential threats, and I'm going to get to that in just a little bit. But first, let me convince you that this actually works. So here we are, there's the dorsal root ganglion right there, or the exiting nerve root, and we're going to remove the disc. Doing a discectomy is not that hard. Standard endoscopic technique would allow you to do that. But we're going to go beyond that. We're going to take the whole disc out, or at least enough to fuse it, and then we're going to put in an interbody spacer, bilateral percutaneous screws. The end result has to look like a traditional surgery. It's not going to be some kind of half-assed, sort of cobbled together thing. It's going to be a legitimate surgery that looks like a real operation, right? So this is the first case I ever did in man, right? So this is another patient. This is an hour after surgery, walking around. You know, she could easily go home. Now, if you've ever done spine surgery, you know that when you do a fusion, you come to the recovery room, the patient either is totally zonked out or tries to take a swing at you, right? And they all say the same thing. They're like, any APPs here? Any nurse practitioners or PAs? No, okay. So you know, we as surgeons tend to hate like seeing our patients post-op because all you're hearing is complaints, right? So the idea is, again, to shift that thinking, and we've published heavily on this, right, to try to prove this. Now, people often focus on this awake part, so they want to say, well, how are you doing that, right? Anesthesiologists are like, well, you know, like, is that really safe? Is that something we ought to do? So we have a whole protocol for this. So I don't want to we could spend an hour talking about sedation protocols, what we do, how we do it, what the methodologies are, how we measure it, how we study it, how we publish on it and do research, right? But the idea here is to change the thinking, at least, because of course you could do this asleep as well, right? And people say, well, why do you even want to do that? Like, that sounds ridiculous. Like, I want to listen to the kind of music I want to listen to in the OR, not have anybody hear it, right? So there's a lot of reasons. One is it's the most sensitive neuromonitoring, right? And that's probably the most important driver because you're basically monitoring for DRG, dorsal root ganglion trauma. So that's the most sensitive, and we've published that as well on how you do that and how you can stimulate and all that. But let me just get into these other elements, right? So here's another example. Here we are getting ready to do surgery on this lady. This is an oral surgeon, and we're gonna fix her spondylolisthesis, right? People now recognize that the effects of anesthesia on the human brain are not trivial. In fact, I think the American Pediatric Association a couple years ago announced that they don't want any children to undergo any anesthesia unless it's absolutely essential. In other words, before people were like, yeah, just put them to sleep, take the tonsils out. The effects on the brain, the effects on cognition are not trivial, especially as you start to treat the very, very old people. I'm not saying anesthesia is not safe, that's not what I'm saying. I'm saying that people realize you take someone through a surgery, 4 hours, prone position, lose blood, that person often will tell you afterwards, I couldn't remember anything for 3 months after surgery, I couldn't go back to work, I couldn't do any of that. This is an 86-year-old with an EF of 11%. Now, I'm guessing that here in Toronto, like most other places, that's a no-fly zone, right? You're not going to operate on this patient, but we're going to operate on this patient. And here you can see that patient has pacer pads on, right? And he has a grade 2 spondylolisthesis, so we're going to correct that. Percutaneous, you know, an hour of surgery or less, right? Very little blood loss without general surgery, right? Fewer physiologic derangements. So I'll never forget when I was a medical student at Stanford, I did an anesthesia rotation, and the attending told me, listen, Mike, you got to remember, it's just like flying a plane. When you take off and land, that's a stress, right? When you're up in the air, it's pretty easy. He says, when you intubate this patient, when I give you the laryngoscope and you're going to intubate this patient, it's like an elephant steps on their chest. I'm like, he goes, yeah, it's very stressful, right? So physiologic derangements, we try to minimize that by letting the homeostatic mechanism of the native human control themselves, whether it be cardiac, right? I mean, I just had a case of this, a case where they hurt the vocal cords on intubation, right? This stuff happens all the time, right? Temperature regulation, this is not trivial, right? Urinary retention, one of the top leaders for people staying in the hospital longer than they probably needed to. We don't use a catheter for this surgery, for example. This is a great, I like to show this picture because this is a lady who had a simple procedure, but they put an arterial line in and it dissected the whole arm. And then we had to cancel the surgery, reschedule 6 months later. Every time she comes to see me, she shows me her arm. She goes, what do you think about this, Dr. Wang? I'm like, I didn't do that, right? Like, so these things are not without cost. Not that you don't need arterial lines. I'm saying there are costs to everything that we do in that operating room, and we try to minimize that, right? Now, there's another perspective on this, which is to say, from a population-based approach, it expands the type of population you treat, right? So it's not just saying, well, I take the same population now, I'm going to do this. You can actually treat different people. People who are sicker, people who have less reserve, people who are more frail, because you subject them to less stress. And it's becoming well understood that spine surgery on people who are in distress, who are of advanced age and multiple comorbidities, is a very common thing. Probably about 2% of the people I'm operating on now have had a transplant, a solid tissue, solid organ transplant in their life. That's a lot of people that are on a lot of, different weird drugs that I don't know the names of, but I certainly would not have operated on them when I was in training. I would have said that person's too sick. And the average age of my clinic in my surgical case is 73. That means that I'm regularly operating on people in their 90s. And that's going to be the future trend in terms of what's going to happen. What about this, right? Maybe the semaglutides treat this problem and we don't have obesity anymore, right? Maybe we don't have that problem, but it certainly is still a problem today, right? So here's an example. This is an executive of one of your sponsors, actually, major executive, who came to me and said, I want to have surgery down in Miami. He's not from Miami. And he's got a BMI of 53, right? And a lot of people say, well, just lose the weight, right? Well, I'll tell you, the only two things that people get shamed for now are weight and smoking, right? So it's easy for us to say, why don't you quit smoking before I operate on you? And I understand the science here. I'm just saying that it's not that easy to just do that to people. And when you do that to people, it actually, I'm not saying don't tell people to quit smoking. I'm saying that when someone cannot quit smoking, you say, well, because you can't quit smoking, you're not going to walk anymore because I'm not going to do your surgery. Well, that's called playing God also, right? That's saying, well, I don't want your statistic on my statistics, so I don't want to take care of you. And people always say, am I a good candidate for surgery? And I say, good candidates for surgery don't need surgery. Right? So the aircraft analogy is a perfect one. People are like, why can't we just be like pilots, like commercial aviation? Well, we thought it was safe, but it's not anymore. But flying was so safe, right? And if you've ever treated, FedEx pilots make like $500,000 a year, Federal Express, as opposed to American Airlines, because FedEx pilots fly no matter the weather. Okay? And so I say it's more like, no. The proper analog is military aviation. You're going to take off on a jet with a bunch of munitions on a very short runway in the middle of the sea and 10-foot seas in the dark. People are going to try to shoot you down. Then you're going to fly back here and land on a similarly small deck of an aircraft carrier. That's the analogy. When we're doing surgery, people are always like, Dr. Wang, the disc is so collapsed. How are we going to get in? I'm like, what, you want to operate on normal discs? You're the criminal surgeon, right? You're the one who does a normal disc. Or the tumor is so big. Oh, no, you operate on the 1 millimeter meningioma, right? What are they saying to us, right? The people who need the surgery are already crippled. Oh, they're deconditioned. Can they wait 6 months? I argue with my colleagues all the time. I'm like, well, just make them wait 6 months. I'm like, the people I operate on cannot walk from here to Carroll. Or I don't operate on them. As a general rule, it's like, if you can't say, I can't live with this, you don't get a surgery, right? So think about what that means in terms of what you're going to do. Once again, here you see lateral position, not intubated, he's getting a surgery. Pain drawing, super powerful, right? You get to see a lot about the patient's recovery phase and what they're really feeling. So if you're not convinced, think about special cases, because you think about like what you bring to the party as a surgeon. There's lots of surgeons who say, I want the patients to fit my surgery. Okay, I have this tool, this widget, as they always say. People say widget now. I have a tool, and if you don't conform to the need for my tool, you don't need to see me. That's very standard practice. I say, well, no, hold on a second. I'm a handyman with a whole tool belt, okay? And you tell me the problem, and I'm going to see if I can fix it for you. I'm not promising anything, but I'm going to see if I can fix it. Here's a lady, came from the Midwestern US, right? Has lumbar stenosis, okay? Now, the patient's being seen, doctor does a surgery, right? Very famous spine surgeon. If I told you the name, you'd know that name. You'd be, oh my God, that's the person. Did a very standard conservative approach, lumbar laminectomy, no fusion, no instrumentation. But unfortunately, during surgery, there was an unintended durotomy. Not a big surprise, it happens everywhere, right? The only problem is she went on to develop, after that, low pressure and then a subdural hematoma. Was blind and hemiplegic in the ICU for about 2 months, and then, as many people do or want to do, became too debilitated to live in the Midwest, so she moved to Miami, right? It's nicer, the weather's warm, as long as there's no hurricanes. We have a lot of your Montreal folk that come for the winter, right? So, so she comes to me and she sees me, and now she's got iatrogenic instability from the decompression, right? So here's a lady who had a durotomy from a posterior approach and now had a subdural. She's actually gotten better. She can walk. She's still blind in the one eye. She's weak on the one side. What do you do with this lady? Somebody want to open her back again, right? Somebody want to go like anterior, like XLIF, or, what are you going to do? Well, here's what we're going to do. We're going to do awake fusion. We don't even see that area. We're not going to get a durotomy. We're not even near it, right? And she goes home, right? This is the kind of power you could have with, and it's not best for everybody. It gives you another arrow in your quiver, okay? Give you another example of a case, and these are quite common. This is a lady came in very obese. Her BMI was like 48 or so, and she really could not walk like literally 10, 15 feet. These people often come like, they're almost, and it's weird, you're in America, like why is this happening in America? Because spine pathology is everywhere, right? And she's like, Dr. Wayne, can you fix me? I'm like, oh, good news, you came to me, I'm gonna do MIST lift, standard MIST lift, like a tubular type of approach or Taylor approach, because we need to really decompress you. So we decompress her, do the hemilaminotomy, and this is, by the way, what she looks like standing. This is pre-op. And during the completion of the discectomy, this had never happened to me before, although I heard of it. The chief resident reached in with the pituitary rongeur, pulls the rongeur, and a boom, big gush of blood comes out. I'm like, oh no, I've never seen this. So I put the foam down, stop it, and it stops bleeding. I'm like, oh good, it's probably just, like a little venous thing. You know how surgeons are, we're like, oh yeah, I think, let's see, what do we do, right? So then we're like, okay, we wait about 10 minutes. We're like, sounds like things are okay. Hemodynamically stable, hematocrit stable, the belly. We crawl under the bed, look at the belly. That doesn't look like there's any blood there. So then the chief, I'm like, okay, go ahead and put the shavers in. So we've already done the decompression, and they put the shaver in, distracting the disc space, okay? And the patient flatlines, like, just like that, within 3 seconds, right? Now, this is why you need a good team. The CRNA says to me, you have a pulmonary embolism. You have an air embolism. And he was right. Immediately, they worked it up. Like, don't worry about it. Dr. Wayne got it taken care of right over here. Immediately resuscitate her, totally fine, right? He goes, fill the wound with water. Okay, so what had happened is the vein had been punctured, and it kind of sealed off. Then when we distracted, it sucked air from our discectomy site into the vein. Boom, like a big air embolism. Lady actually, they extubated her. We closed her, we extubated her, right? And then we sent her to ICU and all that, and I talked to the family, and she was okay. But then she was even worse because we had done a hemilaminotomy. We had destabilized an unstable spine. And the son's like, Dr. Wayne, aren't you gonna fix her now? I'm like, I don't know. So I thought about it a lot, right? So that's the blood coming out, right? So, yeah, so this whole concept, right, it never happened to me, right? So what do you do now, right? Oh, sorry, BMI is 37. So do it more carefully? Like, what are we gonna do, right? I mean, I really don't know what to do here. So here we go, and we're gonna do the surgery endoscopically underwater. So if we get an embolism of something, at least it's going to be saline. And she did great. She did actually great from this surgery. I would love to have fixed more. I think Stephen Lewis looking like horrifically like, oh my God, you need to do more. But actually does great. Okay, she eventually loses a ton of weight. She's actually one of my favorite patients now. So having that arrow in your quiver is powerful even if you don't use it every day. So what are the outcomes? You're like, well, okay, that sounds great. What do you do with this stuff? Well, you got to have proper surgical technique. You can't say this is a way to skip steps. You got to prepare the end plate, you got to fuse the patient, you got to distract them, you got to lift them. Indirect decompression is very powerful. You can see in this patient, you can see how selective we are. We're in Miami, people are very sick. We're very selective in how we do our surgeries, and here you see the effect on the symptomatic level, which is really at the L3-4, L4-5 level, however you choose to call it. Just from indirect decompression, stabilization, and through Wolff's Law, the reconstitution of the spine, and she does really well from this, right? So what does it look like in terms of case series? The key is the indications. In spine, if your indications are bad, your outcomes are gonna be bad. Our indications are good, so our outcomes are good regardless of what surgery we do, right? And this is coming out in Journal of Neurosurgery shortly. The idea is if you treat the ideal patient, that's a spondylolisthesis patient. A degenerative spondylolisthesis is the best kind of case to treat. We do have complications. As I said before, the major factor in this is the dorsal root ganglion. If we could eliminate that problem altogether, this would be almost like a perfect surgery. But when you're working in that channel, the dorsal root ganglion is not the nerve root. It is not like, you can retract the traversing root all day long, but if you touch or push on the DRG, some of those patients are gonna have dysesthetic pain, and it can be a real problem, right? So you have to be careful about that. Now, Maybe you say, well, look, I'm not convinced. This is not the way to go. I don't know if that's the way to do it. So this is a slide I put together in 2002 when I was a young attending, and I was very concerned about this cost of surgery. I would talk to people, like, surgery's so costly. And I don't necessarily mean economically. I mean societally, psychologically, physically, and whatnot. Now, I tell my patients that every year I'm going to create a couple divorces, okay? People are going to get divorced on the back end of my surgery. And people are like, what are you talking about? I'm like, well, you know, surgery, you know, like I do about 700 plus surgeries a year. And so like every year, a couple of my patients are going to get divorced, largely as an impetus of the surgical event, okay? You're like, what are you talking about? It's because the stressor of the surgery and the recovery is enough that it stretches and sometimes tears the fabric that unites two people. Now, curiously, it's a pretty low rate. It's probably 0.5% or 0.25%. Do you know the surgery most likely to prompt a divorce? Does anybody know? It's well proven. Your chair may question whether this is true or not, but I have it on good word that this is the case. Anybody know? Anyone take a guess? Trainees? No? Bariatric surgery. Bariatric surgery, because usually it's two people that have developed a relationship and they have a stability in that, and you disrupt it. One person loses 150 pounds, suddenly the whole relationship, whether it's around eating or other elements socially, is very, very different now. It's a very, very big shock to their relationship, right? So you think about, what is your effect on society? Well, there's good and bad, right? There's a lot of effect. It's not just doing a surgery or a case, right? You're affecting the population, right? So I was saying, well, how do I get that to change? And so this is a slide from 2002, and then I started talking about, wow, you know, I'm getting better at MIS, so we need to bend that cost curve down. We need to make this something that is more palatable, not to do any unindicated surgery, not to do more surgery per se, but to get people to be not so afraid of surgery. Because every single case I've ever done, I guarantee you, every patient I ever touched, they were afraid of surgery, and somebody told them not to have the surgery. Somebody in their sphere of surrounding them told them, don't do it. Just don't do it. And what do you think happens the first time that person experiences pain or difficulty or a non-union or an infection or some untoward complication, even if it's small? They reflect immediately back to that individual, go, I should have listened to so-and-so. And this is what makes us unique as spine surgeons. We are the only field of medicine like this. They do not say this about brain surgeons. They do not say this about hip surgeons, right? If you have a hip surgery, then you need another hip surgery. The question is, did the first surgery cause a second one? No. They say you got two bad hips. In spine surgery, when you do one surgery and then you need another surgery, what do they say? It's a domino effect. Think of the optical challenge there that we face, right? It is an impossible task, one that is fraught with burnout and self-doubt, right? Even if you're the perfect surgeon in terms of indications in psychology. So I said, we're going to bend this cost curve. And that's from 2012. Now let me show you a slide from 2023. This is an important slide. This is done by John Yoon, who's at UPenn. He's one of my former fellows, looking at activity tracking and very granular data. We talk about the fingerprinting of surgical recovery. And so what you can see here is 400 days before surgery, 400 days after surgery, you know, patients declining and then gets back up after surgery, right? This shows you what the real impact is on mobility for a patient. The red curve is an endoscopic fusion. The blue curve is a minimally invasive decompression. Now, in the wrong hands, and this happens in America, this is a very dangerous slide. This is like giving a bazooka to a child, right? You're saying, okay, I'm going to make a fusion surgery look like a non-fusion surgery in terms of what the patient feels. That is very powerful and compelling, but again, fraught with the risk that it will entertain unnecessary, unindicated, or otherwise, you know, irresponsible surgical treatment. So that's not what we're advocating. Narcotic usage, we've measured this. You can see the difference. And of course, we know about the crisis. Do we have this in Canada too, Albert? Is this, yeah, it's a thing, right? The narcotic crisis. Now, cost data. We were talking last night about, Dr. Failings, you were saying about the granularity of your cost data, right? In America, it is impossible to get cost data. The only other person I know who's published real cost data of their own is Sig Bervin at UCSF. And when he published his data, he got in big trouble for it. I was able to get cost data on my cases because as the CFO was leaving the hospital, I asked him, and he really liked me. He said, you know, Mike, I really shouldn't, but I'm going to give it to you. Because why do they not want us to have cost data? Well, because the insurance companies in America are in battle with the hospitals. Hospitals want to maximize profit, so do insurance companies. If they know your cost of business, then the insurance companies will simply reduce remuneration to your cost, plus 2%. Very dangerous, right? It's a race to the bottom. So you got to be very careful about this, right? So here you can see the two kinds of spine fusion, right? This is all me, right? If you look at the difference of the awake fusion versus the standard MIST lift, we're saving 16%. Now, in the business world, that's big. 16% cost savings means that we are highly, highly, highly profitable. And even at this rate, the DRG, the diagnosis-related group for Medicare patient, forget about commercial insurance, on a spinal fusion is $34,000. Now that means that even on a standard MIST lift, I have $10,000 of profitability on every case I do on average. That means on a awake T-lift, I'm killing it. That's why when Lorene comes down to Miami, she's gonna see somehow things just happen to be, they work for me, right? This is understanding the economics of what administration cares about, right? Now, it is very important to understand what this really means because we were afraid of bundling, and bundling would have been at the 25,000 mark, which means about half of the US surgeons would be out of business. They're basically, they're cost centers now. They're not profit centers, they're pure cost centers in terms of what they do, right? This is time, and I know it probably doesn't matter as much in Canada. This is a standard, if you will, MIST lift versus awake T-lift. OR in the room 7:25, prep starts 7:49 versus 7:32. I've saved 17 minutes because the patient's not intubated. The patient comes in, rolls themselves over, right? And then procedures start 8 o'clock versus 7:38. And this is 2 actual cases, just randomly selected. That's because we don't need a Bovie pad, we don't need light handles, we don't do any of that stuff, right? So now we're at 22 minutes ahead. The surgical procedure finishing here at 10:56 versus 8:30. That's 126 minutes ahead. Then you got to wake the patient up, get them out. I've saved 151 minutes on the first case of the day. So typically I will have finished my first surgery before anybody else in the hospital has started their first. So this is very powerful from a productivity standpoint. And what can you do with 151 minutes? If you do 100 cases a year, that's 15,000 minutes, that's 251 hours, that's 10.5 24-hour days. So now people are like, well, how do you do all this? How can you travel to Toronto on a Monday and then still do the surgery? Because we are super efficient, right? So what if you're not convinced? I'm so happy to see all the COVID paraphernalia and discussion because in America, people have forgotten about it. They want to forget. It's like a bad nightmare, right? So COVID is so important because a lot of things happened that people said would never happen in healthcare. Mayo Clinic, right? Cutting surgeon salaries. That never happens, right? What is going on in this world, right? With the COVID, right? This is something that should be a wake-up call. And I think for a lot of specialties, they never really came back to work, like in neurology in Miami, like they're all doing telehealth still, right? So people have forgotten this, but I consider it like a test, right? It's like and I don't want to make light of the COVID pandemic. It's a very serious thing, right? These are the slides from the actual first White House briefing on opening up, right? So this is April of 2020, right? So here we go. And whatever you think of the United States, right? You'll never hear another American president talk about surgery to the nation. I guarantee you're not going to hear him talk about it. It's not important enough. Here they're saying you can resume if clinically appropriate in an outpatient basis. What does that mean? That means if you do outpatient surgery, you're in business. If you don't do outpatient surgery, you're out of business. Now, if you're just collecting a salary and you don't care where the money comes from, that's fine, right? But eventually, you're going to be let go. Eventually, you will die. Your field will die, right? So you got to find alternative ways to deal with things, right? So many issues, right? People afraid, the economy, we still don't know the impact. You know, our national debt is massive now. The push for single payer in America might have been spurred by this. You know, the people are like, well, I have the best privately insured patients. I'm like, really? Because you're going to compete against me next, right? Go ahead and try, right? So all these things happen. It's downward pressure. And then, you know, the administrators are like, when are you going to get back to work, right? So what do you do in this environment? So I'll show you why it really matters. I started with what is MIS? What really is MIS surgery, right? What is that, right? Now the differences matter, right? They're asking you these questions. So let me show you a case. This is a British lady, lives in Miami. She had seen me in February of 2020, and at the time I had a little more time too, so I don't really look at the electronic medical record, and I get this message that I'm gonna kill myself. Okay, and I'm like, oh, geez, that's kind of serious, right? So I actually called her up, and I don't typically do this. And I talked to this lady, and she's crying on the phone. I'm like, what's going on, ma'am? She's like, you know, you saw me in February, and I was okay. The injections were kind of working, and, you know, but now I've got the 3 little kids at home. I can't even walk to the bathroom. My husband's trying to go to work. I'm crippled, and she's young. She's a young lady, like in her 50s, young for me. And I said, well, they're saying we can't do surgery. Like, Dr. Wang, whatever you need to do. So I call up the CEO of the hospital. I'm like, listen, I need to do this surgery. And she's like, I don't know. I'm like, I'm going to do this surgery. We're going to send her home. Do you remember the time when the anesthesiologist would have the youngest person, like the CRNA, intubate while everybody stood outside, and then you'd wait for like 15 minutes outside? Like, is it safe to go in or not, right? Think about that time. Think about how serious that is, that any ripple effect onto our system destroys our operations. I said, look, we're just going to do this, put the nasal cannula on, flip her over. She's going to wear an N95 mask if you want. I really don't care, right? So we do the surgery. It was like 32 minutes of surgery, right? Because I'm going to do this one by myself, no fellows. Goes home the same day, okay? After that surgery, 2 days later, I get a call from the CFO. The CFO calls me up. He goes, I'm like, oh God, I'm in trouble. I know, Mike Wang's in trouble again. And he calls me up and goes, hey, you got a minute? I'm like, yeah, you're in a private place? Yeah. He goes, listen, what did you do 2 days ago? I'm like, well, I did this surgery. He goes, do more. And the next thing you know, every other hospital that shut and opened and shut and opened, shut and opened, we got all their patients. And now it's like thousands of people waiting to see us, right? There are a lot of things going on in this world to understand, right? What to do. There's a lot of ways this surgery doesn't work out. Here's a fracture, right? I don't want to make it all rosy, right? This is the fourth case I ever did. Fractured the end plate. Not good, right? Understanding how you treat equipment, right? So infections, right? So we had a problem, right, where we had infections like this, right? Look at that. Because we had to process that and go to central sterile and figure out they're not actually treating the equipment right. So when you have a new program, the hard part is understanding that if you're at the front of this, that you've got to be very cognizant of what's happening and sensitive to the outcome and look at like a troubleshooting process when things aren't going well, right? This is all early days, right? Trying to treat these people, worrying about the DRG accessing. This is a big donor, right? Accessing that site, right? Getting through there, understanding the geometry. It's no longer just like an open surgery. You have to understand the risk involved in rupturing vessels and getting there, right? And understanding all these elements of what you're doing with surgery. Sometimes people do need a formal decompression, right? Sometimes people need a hemilaminotomy. So we've essentially divided the TLIF into two parts. This is accessing the DRG around the facet joint. The facet morphology is the most important part of understanding access. It's not the disc, it's not the pedicles, it's that facet morphology that will delimit your access through Cambin's triangle to do it safely, right? So getting a DRG, irritation, injury, whatnot, right? So the most critical thing to understand here is the dorsal root ganglion and getting around the facet and understanding that geometry and how you do it. And this is very important. This is telling. A lot of folks are going to design products and whatnot, and all the young surgeons always come to any big company and say, oh, I'm going to access through this approach. Right here, this posterolateral corridor. It's the only approach you cannot take to the lumbar spine. This is actually from Luis Pimenta, who invented the XLIF. And when he started the XLIF project, he tried to do it this way in Brazil, and everybody was hurt. This is from our textbook on lateral surgery. He writes the history, and he actually put this diagram. This is his diagram. This is the one route you do not want to take into the spine. So you've got to understand the sensitivity of that hard posterolateral, because everybody does this. They start with endoscopic. They try to creep lateral, 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 because it's so appealing to get to the canal and the disc, and then they get a DRG injury, and then they stop. Right? So just be aware of that DRG, right? So what's next? Lots of exciting things. Robotic surgery, right? We replaced the awake part with the robot, right? And then you get these elements so you can do surgery in a standardized fashion if robotics ever really truly takes off for spine surgery, right? The great thing about the robot is there's no anthropomorphic constraints, right? It doesn't have a 7.5 size hand. It can be tiny, it can be huge. Force levers are different, vector controls are different. Robots have capabilities that we don't have because we're biologic creatures, right? And then, sorry, that video's not gonna run. And then using the robot for other purposes like endoscopic surgery, right? This is what we're doing in a process of trying to figure out how do you standardize, robotics with endoscopy. This is a big part of the future. We know it's coming. These are all exciting projects to do studies on. Augmented reality. We have basically every toy in the world in Miami because we're such a huge spine center, just like you guys, and doing augmented reality so people don't like to use radiation, using this sort of as a concept to better understand, or even as a teaching tool. Augmented reality is very powerful in terms of what its capabilities will be. But the next stages are truly going to be in Stephen Lewis's realm, which is in the deformity world, right? So the MIS-DEF algorithm, which is part of the ISSG, you guys have all heard about it. Praveen Mumanini led this charge of understanding how we classify deformities and how some are accessible to MIS surgery and some aren't, and how we do that. This is the MIS-DEF2, which incorporates some of the things we've developed in Miami, including the MIS-PSO and other types of approaches that are really intended to sort of mitigate the negative effects of major deformity surgery, right? So again, thinking about that first case I showed you of that doctor's wife where we did an endoscopic surgery for deformity, it also gets you to think about things differently. For example, like, does this person really need to have like a T10 to pelvis, right? Can you do something less? Can you get more leverage, for example, through an anterior column resection? I purposely neglected to talk at all about lateral surgery because I know many of your other SpineFest speakers either have spoken about it or they will speak about it because it's so driven by industry and surgeon value, I'll call it that, surgeon value. But I don't need to talk about it because everybody else talking about MIS is going to focus on lateral surgery, even though we do a lot of it as well. So anterior column resection, dividing the ALL, getting across, dividing the annulus, getting a lift, a tremendous lift through each single level, and then potentially getting around the crest and doing all of these things that are very cool and exciting. Again, people talk for hours and hours about how they do lateral or anterolateral surgery. Raj, you do a lot of this here, right? So it's very exciting. And just to show you how we try to do, for example, shorter construct by sectioning the ALL. Sorry, I'm just for the interest of time. Shorter constructs for deformity correction to try to get something a little bit more palatable for the older patient, right? So that's something we're very excited about, but we want to take this into a new realm, which is an endoscopic type of approach, which is ALL resectioning or sectioning from the endoscope. And we've already gone into this idea, which is how do we take the ALL down with the endoscope? How do we get that? And you can see some pictures of taking that with the Kerrison. And what if you could do that without general anesthesia? What if you could do it in stage surgery? So in other words, you see a 96-year-old person who has a major deformity and you're like either no surgery for you or you got to bite the bullet and take some huge whack. What if you could stage this over a couple different small surgeries and modularize the procedure where you can actually make each bite of the apple more palatable rather than trying to shove it down someone's throat? This is really where we're trying to go with the MIS and ultra MIS types of approaches, modularizing our implants, getting them done in that way. This is where we've gone so far, 3-level awake T-lift. You can see these are, Steve would laugh at these types of deformities saying that's so small, it's not important, but this is the stepping stone. Trying to get to the bigger and bigger stuff, sagittal rebalancing through this approach, adding lordosis. This is a very important fundamental principle down at L4-5, L5-S1. Getting that done, even with the short segment surgeries, is absolutely important. The data all shows that. MIS is not intended to compromise that. MIS should meet all the standards of an open operation to get what you need to out of the operation. So in summary, the MIS revolution, 2 decades of this, but it's still continuing. There's really still a gross inadequacy in what we do daily today. I mean, I know we're going to look back and say, wow, those ideas, they were flawed. We didn't have the technology we needed, but I see in this room a lot of people that are probably going to take the next step, and they're going to be the ones maybe operating on me someday, right, when I have a back problem. And that's what this is intended to be. It's really a journey, and to think about it from the perspective of what if you were the patient? What if it were your mother? How would you best manage this? What would you really say to that person? That's the principle and the guiding principle and the true north that should motivate all of us in this room. So thank you very much for taking me to Toronto. It's been an amazing trip. Dr. Failings, Dr. Yee, congratulations on SpineFest 17 years.
Well, that was truly a tour de force and a lot for us to think about. So we have a few minutes for questions, if there are any kind of questions that we see. Dr. Lewis. Dr. Lewis.
Do you have a shield or something I can put here?
Thanks a lot, and that's incredible work. And I think the biggest problem we have is how to bring this to a system that really is limited on budget. The cost of the anterior cages, the cost of bringing the robot in, the cost. Our biggest metric that we're looking at is what is your cost per case, and how can you keep it down? And how do you see us bringing it into our environment where we can advance technology to such a way with the latest and the greatest, but still maintain our cost per case at a kind of a margin that would be acceptable for administration?
Yeah, that's a great question, and it's a problem for everybody in America too. But I think the reality is that if you look at it from the proper perspective, right? If you look at it programmatically, then what you can see is that there's tremendous cost savings potential, right? But of course, if you just silo the microscope and just look at, well, what's the cost of acquiring this or doing that? And that's what the administrators do to you, right? They divide and conquer, right? Sorry if there are any administrators here. But that's what they do. They say, well, I want to know what this piece is going to cost, right? As opposed to looking at it from a programmatic standpoint. And I would say that may be one of the powers of being here in Canada, is that you have that ability to speak directly and from a high level to administration. And I would posit that if you formed a business plan, I think it would be fairly straightforward in terms of objective, at least. The details, of course, are always difficult. Yeah.
Dr. LaRouche?
Thank you very much for a fascinating talk. One of the things that really stood out is that your ability to adopt new techniques or to change halfway through your career. Do you have any advice for us that are already established in our careers saying, listen, we want to dabble with endoscopy, we want to dabble with an MIST lift? What are the steps you'd recommend for us to be able to kind of get competent and safe in these techniques despite, being a few years out from fellowship?
Yeah, that's a great question. I'll approach it from this concept of fear and love, right? People always ask you, like, would you rather be feared or loved, right? And I would tell you that I'm always from a position of fear, which is that, spine surgeons are in many ways, I don't know if it's true in Canada, but in America, they're like apex predators, right? So apex predators, it sounds great to be an apex predator, right? Because you're like the bald eagle, or you're like the bear, or the lion, or crocodile, whatever, you're an apex predator. But actually, if you look at the ecosystem, any biological ecosystem, the apex predator is most vulnerable to fluctuations in environment, right? And so it's very easy to get comfortable as a spine surgeon and say, well, look, I've developed my techniques. I don't want to change because I'm afraid that if I do, it's going to hurt my outcomes or whatever. Or it's just onerous from a cognitive burden, right? But the reality is if you approach it from a position of fear, which is that, as I've said, like, we have to get better. If you just talk to people who are not spine surgeons in the outer industry, they say, why? Okay, I'll give you an example. Sorry, I don't want to take too much time with this. I have endeavored to be the best spine provider I can be for the last 25 years. I've committed 100% of my energy to it. I don't have hobbies. Like, I'm 100% committed to this, 1,000% maybe. And if you ask me what I've done when I started to now in my abilities, productivity, or safety, or efficiency, or efficacy, any of those metrics on the matrix, maybe I've doubled, maybe I've tripled or quadrupled, but then people would say, 25 years, you should be like 10x. Like, why are you not better than you are? And the answer is that, the fear should drive you, I guess. I don't want to be negative on it, but I think that there's a real risk that tomorrow we wake up and someone says, look, we're not going to pay for spine surgery anymore, right? I think that's a big motivator.
All right, and Dr. Ramprasad.
It's a great talk, Mike. Just conscious of time, but glad to see you're still passionate about economic analyses. As you know, we both presented this stuff when nobody didn't want to hear about it 20 years ago. The question I have is a challenge of value alignment. So patient value, surgeon value, hospital value, payer value. And you spoke to it quickly, but when your CFO says, do more, that doesn't happen here, or in many places, and in some places in the US as well. So it's critical about that alignment. And as you said, there's so much data that MIS does well, or does better, at least in the short term, et cetera. You've published it, I have. It's just, we've been waving that flag for over 20 years. So the pointed question I have for you is, how much have we really moved the needle in change from the surgeon perspective for MIS adoption in spine surgery? In Canada, it's small. It's all going in the direction, but it's slow.
I would say, like most natural systems, it always is the same. It starts slow, then all of a sudden, right? Like, you look at anything that's happened in the world. In retrospect, it's easy to say iPhone's going to take off, but there was a lot of slow starts, and then it took off, right? And I really believe that this is coming. I don't know exactly how it's going to arrive in Canada, but pressure is going to push it. And we've been luxuriously living this amazing life without any pressure, right? We have for the last 40 years in America and Canada. And I think the pressure is coming. I mean, I hate to always be the doomsayer, but there's no other way it could happen, right? It just can't sustain. So amazing work you've done over the years, so keep up the fight, right?
You too.
Okay, so on that note, Michael, thank you so much. Great. Okay, well, that was an amazing tour de force. So just before our coffee break, we're going to kind of hear from our trainees. And a few years ago, we adopted this elevator pitch approach to sort of a mini talk. So I wonder if we could perhaps have the trainees come up, and I think the first speaker is Chris Lozano.
Hi everyone, my name is Chris. I'm a PGY4 neurosurgery resident, and I'm presenting my project on laminoplasty compared to laminectomy and fusion for degenerative cervical myelopathy cost-utility analysis. So we're all familiar with these two procedures, which are commonly used for cervical myelopathy, where we decompress the cervical spinal cord, but they have advantages and disadvantages, and one of the main differences between them is actually the cost associated with laminoplasty generally being less costly. So we wanted to compare these formally with a cost-utility analysis. So we designed a Markov model cost-utility analysis where we took quality-adjusted life years associated from 3 different prospective trials where patients were propensity score matched to each other. And then we took costs from a recent meta-analysis, and then we put these into a model, and using something called Monte Carlo microsimulation, we basically ran the model 1,000 times, which allowed us to incorporate different probabilities for each of the parameters. And after we ran the model 1,000 times, we found that there was no clear advantage of one procedure over another in terms of the cost effectiveness, and therefore, when choosing between these two procedures, we should really be focusing on the proper indications for surgery, patient factors, and not judge this based on a perceived economic superiority. Thank you very much.
Thank you, Chris. The next speaker is Miran Ruentan.
Hi everyone, I'm a second-year master's student at Dr. Tatter's lab. And so I'm going to talk about roflumilast, which is a drug that has been approved by the FDA for treating chronic obstructive pulmonary disease. And it acts by inhibiting enzymes that will hydrolyze cyclic adenosine monophosphate, or cyclic AMP. Now, cyclic AMP is involved in pathways that can reduce inflammation, promote neuroprotection, and activation of the endogenous stem cells. However, after spinal cord injury, there's a significant reduction in cyclic AMP levels. And so there has been a recent interest in using roflumilast to regulate cyclic AMP after SCI. And studies in models of thoracic SCI have found that roflumilast can reduce inflammation and promote functional recovery. However, we are interested in testing this drug in a more clinically relevant model of cervical SCI, which is a more severe and more common injury type. And our preliminary data has found that roflumilast can increase the proliferation of these endogenous ependymal and SPCs, induce neuroprotection, and also facilitate functional recovery. However, these differences at this point are not statistically significant, and more work is required. But these preliminary data are promising, suggesting that roflumilast can potentially help to improve SCI outcomes. Thank you.
Thank you. And the next speaker is Dawit Gulta.
Good morning. My name is Dawit. I'm from Sunnybrook Research Institute. Sorry. Vertebral compression fracture are serious complications affecting 14% of patients receiving spinal SBRT, causing pain, disability, and treatment delays. Clinicians usually use the spinal instability neoplastic score scenes to assess fracture risk by evaluating 6 factors: tumor location, mechanical pain, bone lesion type, spinal alignment, vertebral collapse, and posterolateral involvement. However, science relies on subjective interpretation, creating variability in risk assessment. Our study introduces a machine learning approach for more objective prediction. We quantified science components using CT imaging. We analyzed 300 SBRT patients with 18% risk rate, fracture rate, and trained 6 machine learning models. So the random forest model demonstrated superior performance, improving balance accuracy by 36% over traditional scenes. This machine learning approach transforms spinal oncology by automating scenes quantifications and integrating objective imaging biomarkers with clinical data. Thank you.
Thank you. The next speaker is Masa Moklezabadia.
Hi, my name is Masa and I'm a PhD student in the Focus Ultrasound Lab at Sunnybrook, and my research focuses on treating spinal cord gliomas using antivascular therapy in a preclinical rat model. So historically, one way to eliminate tumors has been to cut off their blood supply, starting with methods as simple as gluing vessels, and more recently evolving to more non-invasive approaches such as mechanically ablating the tumor vasculature with focus ultrasound and microbubbles and actually their strong cavitational forces. This method has shown a strong promise in a lot of non-CNS tumors, but its role in treating spinal cord tumors is largely unexplored. So in our study, we treated rats with spinal cord tumors with increasing ultrasound pressures, and what we found was striking. The healthy tissue surrounding the tumor showed progressive damage with increasing pressure, from red blood cell extravasation to full hemorrhage and even spinal cord tissue disintegration, while the tumor tissue remained largely unaffected. We believe this happened because of the lower vascularity of F9E glioma tumors, and also the fact that they co-opt vessels, and co-opted vessels are usually stronger than angiogenic vessels. What we learned from this study is that we have to adopt more precise targeting strategies when we are designing anti-tumor strategies with focus ultrasound in order to spare the important healthy spinal cord tissue. Thank you.
Thank you. The next speaker is Jessica Castano.
So I'm a master's student at York University doing my research at Sunnybrook Research Institute. Today I'll be presenting my work on the characterization of osteosarcopenia in patients undergoing stereotactic body radiotherapy, or SBRT. Osteosarcopenia is this condition that, where patients experience combined loss of bone and muscle, and has been linked to higher risk of fractures, reduced mobility, and worse survival in cancer patients. In the context of SBRT, where vertebral compression fractures occur in an average of 14% of cases, assessing bone and muscle health may help us improve treatment planning. So we conducted a retrospective study, and we analyzed 143 SBRT patients using an automated imaging pipeline that segments the psoas muscle and vertebral bodies, and we extracted musculoskeletal imaging biomarkers. We found that osteoporosis was present on 58% of patients, 45% were had sarcopenia, and 31% were osteosarcopenic. Patients with fractures had lower psoas and vertebral bone density, and we also found that osteosarcopenia and sarcopenia were significantly associated with reduced survival. Thank you.
Thank you. The next speaker is Josh Plenner.
Morning. Lumbar spinal stenosis is the leading cause of disability. Oh, should I wait for... Oh, there we go. Lumbar spinal stenosis is a leading cause of disability among older adults, significantly impact one's walking capacity. Within surgical settings, expectations of recovery have shown to influence patient-reported outcomes following spinal stenosis surgery. However, the relationship between patient expectations and treatment outcomes in a non-surgical setting have not been assessed. A secondary analysis of a comprehensive rehabilitation program within a randomized controlled trial was conducted, and the impact of baseline patient expectations in individuals expecting to recover soon versus not recover soon were compared to evaluate the change in self-paced walk test scores from baseline to 6 months. 37 participants completed the tests at baseline and 6 months, and it showed that those who expect to recover soon walked on average 653 meters further than those with low recovery expectations, after adjusting for the relevant confounders. Overall, the results show that baseline patient recovery expectation is associated with improved walking distance at 6 months in patients with spinal stenosis receiving a comprehensive rehabilitation program. Future research should examine this relationship further. As well, because patient expectations are modifiable, interventions aimed at improving recovery outlook, particularly in patients with low expectations, may lead to better clinical outcomes. Thank you.
Thank you. The next speaker is Karim Abomad.
So debate exists regarding the management of pediatric high-grade spondylolisthesis. Proponents of in-situ fusion state lower complication rates, whilst those of reduction in fusion quote better sagittal alignment, lower post-operative pseudoarthrosis rates, and better pelvic orientation. We looked at patients who were fixed in situ with a modified Jackson technique, and we looked at their pre- and post-operative radiographic alignment. We identified 20 patients who, with an average age of 13.6, who were managed with a modified Jackson technique. 9 of these patients presented with a vertical sacrum that was defined as a sacral slope of less than 35 degrees. All of the patients who presented with a vertical sacrum showed correction of their pelvic retroversion without any formal reduction, and this correction was dynamic and improved over time, with an average of 15 degrees increase in sacral slope over 2 years. There was no complications, no pseudoarthrosis noted at 2 years. So in summary, patients with high-grade spondylolisthesis with a vertical sacrum fixed in situ did not show any worsening of their pelvic parameters and showed a gradual correction over time.
Thank you. And the final speaker for this morning's abstract session is Chloe Codieu.
Thank you. So it was previously suggested that degeneration of the spine began in the disc and then led to facet arthrosis. However, we hypothesized that the relationship between the lumbar loading axis and the innate pelvic parameters may be a mechanical driver that led to different degenerative patterns that didn't necessarily follow this disc to facet pattern. And so our objective was to assess if there was a difference in PI between patients who had a disc herniation versus patients who had lumbar stenosis. And so I'm going to just highlight 2 key findings from our comparison between these 2 surgical groups. So one, patients with lumbar stenosis were found to be very unlikely to have had a prior discectomy or isolated disc issue. And 2, the pelvic incidence was significantly lower in patients with disc herniation versus patients with stenosis. And you could see that when we compared both overall and when we stratified between men and women. And so ultimately, the main takeaway is that the load-bearing axis in the lumbar spine is likely influenced by innate pelvic parameters, which may play an important role in how patients develop different degenerative patterns. For example, patients with a low PI may have a more anterior load-bearing axis, which may place more stress on the disc, whereas patients with a higher PI may have more of a posterior axis, placing more stress on the facets. Further information is and research is needed.
Thank you. So just a round of applause for all of the abstract presenters. Excellent work. Thank you. So we will take a short, 10-minute stretch and coffee break. There's coffee and refreshments outside. And then we'll reconvene at 10:30. And Dr. Steve Lewis will be chairing the next session which will be a discussion of MIS versus open approaches for various spine pathologies. Not to interrupt this amazing discussion, but I think if we can take our seats and we'll get started with the next session. Of course, all we need is our chair. Where's Steve? Where's Professor Lewis? Yeah. That's what I'm worried about. Okay, so the next session is on MIS versus open. This will be chaired by Dr. Stephen Lewis, but I guess I'll be pinch hitting here for a minute or two. And so I think this should be quite interesting, kind of vis-a-vis our keynote address, this morning, and how do we balance, the different surgical strategies between MIS and open. And so the first speaker will be Dr. Chris Whithew, who will discuss incorporating MIS techniques into the surgical management of spinal metastases.
All right. Good morning, everyone. I don't know if this will be so much of a debate. Dr. Ramprasad and I are both MIS surgeons, but I think what we'll really be covering is kind of two spectrums of surgery for spinal oncology. So I'll focus on spine mets and the role of minimally invasive surgery in managing spine mets, and then Dr. Ramprasad will focus on primary spinal tumors. So I think that we're all familiar with the role of surgical management in spinal metastases. I mean, this was well established by Patchell in this 2005 paper that we're all quite familiar with, showing the role of spinal column stabilization and neurologic decompression. But I think where we have to spend some time and deal with the nuance is the fact that what we're surgically treating is really a systemic condition, and the reality is what we're trying to do here is control a local pathology that's part of a larger systemic condition in a patient that in many times is quite unwell. And realistically, what we're doing for spinal mets patients is palliation. So if you look at the AO spine study, median survival was 7.5 months, 30-day mortality was almost 10%, and a 1-year mortality of 62% in patients who have spine mets from any primary pathology. And then notably in this paper, they showed a wound complication rate of 10%, which I'll get into in a bit more detail in this as we go on through this talk. A little bit more of an updated paper from the Sloan Kettering group. Again, it's a more modern series, but median survival 8.5 months, 30-day mortality 5.5, 90-day mortality 25%. So I think we have to take into consideration the patient population that we're operating on here when we start thinking about the surgical techniques that we're going to employ. So at the end of the day, minimally invasive surgery is really set to accomplish what traditional open surgery does, but with a less invasive approach and less tissue disruption. So this has been well established across the literature through many treatment of many spinal pathologies, but there's decreased blood loss, reduced short-term complications, particularly wound healing issues and infection-related complications, and then reduced post-operative pain and length of stay. And I think at the end of the day, it's these two things that really matter the most. And in the spine, in the patients with metastatic cancer and mets to the spine, these are really important. So what we want. Oh, hi, Steve. Welcome.
Awesome, Chris.
So what we're looking to do is get early control of a local process that's part of a systemic condition. So what that means is getting them on quickly to radiation therapy. And we're also looking to get early systemic control over a systemic process, so getting them onto chemotherapy or immunotherapy. And then with surgery, we're also looking at improving quality of life at end of life. And as I alluded to over the last few stages, the last few slides, they aren't that far from end of life in many cases. So we're trying to do the best we can and palliate these patients the best we can near end of life and give them pain control and give them quality of life. So I use the GNOMES framework extensively for making my decisions around surgery. And I think you're all familiar with this, but it's basically broken down into 4 categories. So degree of neurologic compression, the radiosensitivity of the tumor, the mechanical stability or lack thereof of the spinal column, and then the systemic condition of the patient, so whether they can tolerate surgery or not. And so this tells us, in effect, when to operate, but it doesn't give us a lot of decision-making around the nuances of the type of surgery to do. Now, the Sloan Kettering group has gone a bit further, and they've come up with a bit of a decision-making algorithm of when you can incorporate minimally invasive techniques into the spine METS population. And I do use this at times, but what I'll talk about a little bit later in the talk is where I've started to modify this a bit for my case population. And if you look at the Sloan Kettering group and they published this algorithm, they did present a modest-sized single case series, effectively showing that minimally invasive surgery for spine METS results in a decrease in pain and an improvement in activity and quality of life, which I think doesn't surprise anyone here. So just to illustrate this, I'll give a few case examples, but I'll start with this one. Here's a 60-year-old female. She presented with quite severe thoracic mechanical back pain, some element of left radiating thoracic radiculopathy. She really couldn't get out of bed because of the pain. And so this was a new presentation. We got a biopsy that showed a lung adenocarcinoma. She had Bilski grade 2 spinal cord compression, so she qualified as a high-grade spinal cord compression. And she had a spinal instability score of 13, and we don't need to go through all of this, but basically the gist of it is she had, in effect, 3 indications for surgical intervention: high-grade spinal cord compression, a relatively radioresistant primary tumor involving the spine, and then spinal instability resulting in pain. But then the challenge comes around the 4th category, her systemic condition, and I think this is the most challenging category consistently in patients with spine METS, and it's a question of can she tolerate surgery or not. And in her, I think it highlights some of the challenges we face. So this is coronal view of her CT chest abdo-pelvis, and you can see this very large pericardial effusion. She had a pleural effusion, and she was quite unwell by the time she presented. So in a case like this, this is where I think there's a role to think about the nuances of surgery and what we might do. So I mean, one option is certainly kind of a traditional midline open, 2 levels above, 2 levels below, aggressive separation. But what we did here was something quite a bit smaller. So I just did a unilateral approach, a facetectomy on the involved side, and then went down the pedicle, did a ventral tumor separation, and then just did 1 level above, 1 level below with percutaneous augmented screws, which has basically become my standard for management of these types of tumors now. You can see you end up with a small series of incisions in the back instead of a large midline open incision. She spent 3 days in hospital after this, but mostly because they had to wean her pericardial drain. She was discharged home, and then she got SBRT within 2 weeks of surgery. So when I think about these, I think that's the kind of outcome that I'm looking for in this patient population: home, relief of the pain, and then quickly on to radiation therapy. And you can see here's her post-op scan and her post-op x-ray. So we've taken, basically with a unilateral approach, we've been able to basically get bilateral decompression, a good ventral separation. This is all done through 22 millimeter tube. And actually she's done very well, and I'm not gonna take credit for this, but basically she hasn't, up to 18-month follow-up, hadn't had any local recurrence, and was well maintained on an immunotherapy targeted to the molecular profile of her lung cancer. So here's another one. This is a little bit different. So this is a MET in the lumbar spine, where She's a 72-year-old female. She had quite significant mechanical low back pain and then a very bad L4 radiculopathy. And she was really having trouble ambulating. It sort of turned out at another hospital, she had a kyphoplasty for what they thought was an osteoporotic fragility fracture, which then turned out, you can see on the MRI, particularly the axial cut on the right lower side, a significant MET. And if you look at her L4-5 neural foramen, it's filled with tumor, and that's sort of the result or the cause of her significant radiating leg pain. So what we did here is something fairly similar. So a minimally invasive tube down on the left-hand side to take off the facet, take down a bit of the pedicle, and then free up that nerve root and take out a reasonable amount of the tumor, and then just get her on to radiation treatment. And this is very effective for pain resolution. And this is one of the sort of keystones of the Sloan-Kettering's group decision-making algorithm is a unilateral approach for painful radiculopathy. You can see here on the MRI, you can now see the left neural foramen, that L4 nerve root is free. Just did a hemilaminotomy and then a unilateral facetectomy to accomplish that. And then I take down a little bit of the pedicle just to free everything up and get the tumor out. But so that's become another kind of common approach for patients with lumbar radic from a metastatic tumor. Now then, I've also kind of more recently started to push a little bit beyond the standard algorithm which is mostly focused on unilateral decompression. This is an example of an 80-year-old male, new diagnosis of large colonic mass with extensive metastases, so presumed colorectal primary. Had again a Bilski grade 2 spinal cord compression at T11, and then this is where collaboration with the radiation oncology group is very important, and we certainly have a very strong rad-onc program here at the U of T, so I think I feel quite fortunate for that. So they were looking to give him stereotactic radiation because of the relative radio-resistant nature of the tumor, but they wanted a separation surgery ahead of time. So what the Sloan-Kettering group sort of describes is if you need a decompression, their suggestion is to do a mini open decompression, which I think is very reasonable. You can do a mini open with one level above, one level below screw construct. But I've started to push things a bit to actually use the 22 millimeter tube to get this bilateral ventral separation just through a tube. But it kind of requires a more lateral approach, which is what I've been spending a fair bit of time working on. So I almost follow the contour of the rib down to the transverse process and then go from an outside to in approach. And then, I spent a lot of time as a fellow learning the over-the-top approach, but now I'm kind of working on an under-the-bottom approach, I suppose, for lack of a better term. And so I'll show you his post-op MRI. So you can see we start quite lateral, and you can take down the whole pedicle. So on the left side, the pedicle is gone. And then what I found is you could find a nice plane between the PLL and the ventral dura and really actually just evacuate that tumor into the surgical cavity, because as you remove some of the tumor, it sort of falls into place. And this was immediate post-op. This wasn't even after radiation. This is just what we can get with that. So I have some videos. I only had 10 minutes, so I don't have time to show them, but if anyone's interested, we can chat more. Here's his full post-op. So you can see a nice ventral separation. Then it's just a one level above, one level below percutaneous construct. Here's one more. Unfortunate 42-year-old male with lung adenocarcinoma, Bilski grade 2 again, and a request for separation. So we did a similar approach to this. Basically, a more lateral start point for the MIS tube. Get in front of the cord, bring the tumor towards you, and then a one level above, one level below construct. Generally, I cement to augment these. There's a little bit of evidence behind it. Certainly, there's biomechanical evidence for pull-out strength, but I feel a bit better putting some cement when I'm just doing one above, one below. But I've been doing that for about 5 years now, and the results are good. So basically, to summarize, I think a lot of this comes down to enabling technology. Certainly, SBRT is probably the most important. These patients need, the goal here is to separate and then give them, focused high-dose radiation. And if they weren't getting SBRT consistently as they do here in Toronto, these tumors would come back too quickly. But with SBRT, it makes this quite feasible. And then I use everything I do is percutaneous screws. I use intraoperative navigation for this. I find it quite helpful. Cement augmentation, as I alluded to earlier, and then minimally invasive retractors. So I basically use a 22 millimeter tubular retractor to get these out. And I think that does help a lot with these short-term mitigation of short-term complications. So I think at the end of the day, when we're thinking about METs to the spine, we want local control to get them onto radiation quickly, and we want rapid initiation of systemic control or resumption of systemic control, but we're not trying to cure them. So the less invasive a surgery we can do, the better it is. So, you know, overall, you reduce pain, hospital length of stay, certainly minimize wound-related complications that will delay radiation and will delay chemotherapy, and then improve or at least maintain quality of life at end of life. So that's it. Thank you very much.
We should sit up here. So we'll do our questions later, and I'm sorry for not being able to introduce you. Chris was one of our key MIS excellent neurosurgeon at St. Michael's, and really leading our endoscopic, our minimally invasive in the city, so thank you very much. And another leader, one of our pioneers in minimally invasive in our city, Raj Ramprasad, and talked to us about different approaches to larger primary tumors.
Okay, if we can get the slides up. Did I just forward with this? Perfect, thanks. Some disclosure, non-relevant to this talk. I'm going to be a little more manic than Chris and talk really fast so I can get through the 10 minutes. So we'll go from there, but this is the only non-evidence-based talk I have because there is not much evidence, so it's very much show and tell, like Chris's, but just want to differentiate the little MIS and then the big MIS. They're both MIS, but one is minimally invasive and the other is maximally invasive. And you kind of have an extreme here of some of the things we do. And in parallel to my MIS trajectory, Mike, I also developed the big M trajectory, which is primary tumors. And I don't actually do a whole lot in between. So it's either a small hole or a really big hole, and everything else gets sent to somebody else. So that's kind of my practice. So the short answer to the question, is there a role for MIS surgery in primary spine tumors? The short answer is yes, but it's limited. So when we're talking biopsy, interventional procedures, et cetera, yes, there's absolutely really ultra MIS procedures because they're purely percutaneous, radiofrequency ablation of benign bone tumors, things like that. So there's absolutely literature on that, and I won't focus on that because it's really interventional procedures, and certainly it's there. There are hybrid techniques like Chris has shown that we use for certain primary tumors, but we have to be careful when we apply it. So this is an example of an osteoid osteoma. You can use different trafines, et cetera. So if you can find a corridor to an osteoid osteoma, osteoblastoma, and you're preserving anatomy, this will fill back in. This patient was done as day surgery. They're 5 years out now. That bone has filled back in. They didn't need instrumentation, et cetera. So another example of an osteoblastoma. So if you can access it posterior, posterolateral, and it's not amenable to radiofrequency ablation, then you can do day surgery for some of these benign bone tumors. This is an example of benign neurogenic tumor. So instead of doing a thoracotomy for this, we did a MIS posterior keyhole, found the root, separated the tumor from the dura, clipped it, and then basically our VAT surgeons were doing this in the prone position. So you can actually deliver the tumor, free it up from the chest wall, and basically do this. They have a chest tube in for a day, so they go home the next day, so it's a short stay. It's not day surgery, but you can see there, again, technology helps us with these hybrid approaches versus a thoracotomy with all its antecedent risk. So there are definitely hybrid techniques that can be done for this type of tumor. And Eric at our center deals with the intradural tumors with an MIS approach. So again, similar to Chris's talk, using a keyhole approach with a 22 millimeter tubular retractor, fixed or expandable, you can do intradural tumors that are isolated and minimize that morbidity and have a nice soft tissue envelope. So there's definitely MIS approaches to primary tumors depending on the actual tumor. But when we talk about malignant spine tumors, such as what's shown on the right, that's a whole different beast in the sense of how do we approach those? So we need a high index of suspicion. The younger the person with an isolated lesion, the more likely that is to be a primary tumor and the features that suggest that it's malignant. It can occur at any age, so even if somebody has a remote history of of a primary elsewhere, if they have an isolated lesion, you still have to think, is this actually a primary tumor? Because if you treat it as a MET, it ends up being a sarcoma, you have a completely different outcome for that patient. So it's really staging, local, systemic, et cetera. You all know this, so I won't spend too much time on it. We apply something that was built for appendicular skeleton to the spine, and it's been validated by the AO Spine Group, that tumor forum, that, you know, this is applicable to the spine. And basically, the benign tumors are the ones where you can often apply MIS techniques. Biopsy is pretty much mandatory for any isolated spine lesion unless the imaging is truly pathognomonic, like an osteoblastoma or a blastoma, but otherwise, it's something bad until you prove otherwise histologically. MIS approaches obviously can be used for biopsies, but these tumors, if it's primary and malignant, this is a team sport. This is not something you do on your own, and they always like being at the junctions. So the worst places on the planet to get to, you need your colleagues who can get you to these areas safely. So craniocervical junction, cervical-thoracic junction, lumbar-sacral junction, you need vascular surgeons, you need paraspinal, retroperitoneal surgeons, general surgeons, oncologists. Technically, surgically, so it's not just a surgeon on the tumor board, it's multiple surgeons in the different areas, because these tumors often affect multiple organ systems or areas. So they're big surgeries, and you can't do this with a tube. so the actual definitive resection of most malignant primary tumors are not done with an MIS technique, because you have to be able to deliver a wide margin. So it's always about the margin. So intralesional surgery for benign tumors, marginal surgery for benign aggressive, or some low-grade sarcomas, such as a grade 1 chondrosarc, but otherwise it tends to be, you need a wide normal rim margin. And basically the research shows if you do a oncologically sound operation, the survival rate's better, the recurrence rate is better, a variety of things. So the question is, well, how feasible is that? Some of these things are in terrible places, as I showed you, but it's having the right team. So this is a paper we put out not too long ago on the feasibility of en-bloc resections with negative margins, and essentially we can achieve it in the majority of patients, basically 75% of the time. But these are highly specialized teams that do this all the time, and this is from the AO Tumor Forum. There's about 300 patients in this series. So it is feasible, but again, you need to do a lot of work. Image guidance really helps us with achieving negative margins and appropriate access, does reduce the resection size. So this is something we heavily use for planning as well as execution of the surgery. As I said, multiple teams. So you got lung, you got chest wall, you got the spine, you have to reconstruct. There are different stages, so these things really help us. The biggest thing is when you see somebody at neurology, you're tempted to jump in there and do something that's intralesional, but in fact, you're doing the worst thing for that patient by not pausing. You can do temporary stabilization, you can do decompressive biopsies. There's different ways you can apply MIS techniques to stage that patient, get them over that first symptomatic challenge, and then work out what you need to do after that. So by doing it percutaneously, you're reducing the contamination of primary tumor into a surgical field, and it avoids a lot of problems. So this is a case that was exactly the opposite of what to do. Young person, neurology, ended up having, the thing is the short-term gain potentially precludes a curative operation. They had surgery, good surgery, well decompressed, but this ended up being a Ewing's. And you can see on the right, Ewing's post-neo-adjunctive treatment almost disappeared. So had we known this was a Ewing's to begin with appropriate biopsy, this person would not have to have this. We skeletonize the soft tissue, take out the contaminated field, strip the dura, you name it. We're doing it to try to get a curative intent operation for this young person. Unfortunately, from 2008 to now, is still disease-free. Now that's partly because of the chemo and the adjunctive treatment, and partly because of the surgery. So these things are surgically dependent. Boryani is a grandfather, I guess, of many of this, and we all has written some amazing articles, anatomical diagrams. If we can move this video to the 2-minute mark, that's the only video I have, but it just shows you really have to release everything, you have multiple exposures, and then you really have to rotate the tumors away from the cord. So it's all about the margin. You can skeletonize the dura, but the success of the operation and the safety of the operation from a neurological spine perspective really comes down to you need to make this thing mobile in 3 dimensions and then rotate it out. So this is why the maximally invasive part of this becomes necessary, because you can't get a negative margin unless you can work around and develop a space to deliver that tumor safely from the cord. When it's in the lumbar spine, we have a little more room because you can manipulate the thecal sac. But in the cord level, you have a very different operation. This is an example of a chordoma presented, had a biopsy, and then while we're working them up, they actually presented with cauda equina symptoms. We did a limited laminectomy with an MIS approach just to minimize tissue, but we didn't touch the tumor because we already knew what it was, planned an appropriate operation, and then did a big en bloc resection of this. This person is now 19 years. He's almost on his 20th anniversary from this procedure. So staying out of the tumor when it matters really matters from a survival perspective. So you have to plan, and then execute. So I'm a visual person, so I literally draw out my operation almost on all of these because it just enforces what I need to do. And then, as I said, you gotta deliver what you drew, but it takes time, multiple stages, etc. So I'm not sure how we're on time, but 2 more quick things, but this is just more extreme, so I'll go through real quick. So sometimes this gets really complex, and the tendency is, well, we can't do anything. So this is one where you bring in multiple teams, multiple stages. You need ENT, neurovascular surgery. We bypassed the vert from the first stage. So enable us to take both verts after a bypass, and then did the anterior stage, resected this en bloc, and this person, I lost him after 10 years, but at 8 years, this is the imaging. I don't know if he's still alive, to be honest, so I can't say that he's disease-free because but these are tremendous operations, and just because I knew Dr. Swallow may be here, this is a case her and I did together, where it's a massive retroperitoneal sarcoma. So a lot of the work I do is from peripheral paraspinal tissue that invades the spine, is involved in the vascular structures. Fortunately, it responded well to knee adjunctive treatment, and then we did this massive operation. So this incision is courtesy of Dr. Swallow. I can't take credit for it. So this is an abdominal T incision, but it allows you to do this with vascular reconstruction. So it's a Gore-Tex bypass of the aorta came with it, the kidney, etc. So there's lots you can do, but you need the right people. So you could be great at what you do, but if everybody else is not great at what they do, this is going to be a problem. That's why it's a team sport. You need everybody to be at their peak with regards to access, with regards to the other things that can happen, and these are big surgeries with big consequences. Thank you.
Thanks a lot, Raj. That's great presentations from both, and very impressive work.
So tube that, Chris.
Any questions from the audience? So, Chris, where do you think endoscopic will have maybe take you the next step on some of your decompressions, and maybe you don't have to fuse on some of these separations?
Yeah, I think it is possible. I think the challenge is most of the time we also want stabilization with these meds. A lot of these patients present with a higher SIN score, pain. So but I do think there could be a role for endoscopic separation. But I think we'll probably, in most cases, though not all, end up with percutaneous screws to stabilize that segment. Oh, that's good. Yeah, thank you.
And Raj, how? I mean, the case is very impressive, very big thing. How do you maybe go over some of your decision-making on how you pick the right patient that's going to do well in these major reconstructions?
Yeah, no, it's a great thing. Just to add to Chris's question, something Mike showed, you can use VATS or endoscopic for releases, so you don't necessarily have to flip the patient for some of the primaries that you can deliver from the back. You can do that anterior release with less, so it's kind of a hybrid approach. But yeah, I mean, it really comes down to, obviously, most patients are young and healthy, so we typically don't have the medical comorbidity piece of it. Our lung patients who have a lung lesion, you do these as well, these apical tumors, pancreas tumors, et cetera, that invade the spine, those are probably our most highly morbid patients. And often the patient makes the decision for you when you tell them this is a umpteen-hour, 2-stage, each stage is over 12 hours operation, you're gonna need a year to recover, you're 100% complication rate, I just can't tell you which one and how serious they're gonna be, you might be in the ICU for 3 months. That conversation is very blunt. And a lot of times the older patients will make that decision for you. And I always say, hey, it's very okay to say no to this because this is huge, but it's the only chance you have of longer term survival. The younger patients, it's typically an easier conversation, and it's really a matter of, is it technically feasible? It's the multidisciplinary rounds. Sometimes we have ones, oh yeah, we can take that out, but I'm like, well, you're gonna resect their whole brachial plexus and they're gonna have a flail arm. Is that going to be really beneficial to that patient unless they want a 4-quarter amputation as part of it? So it gets layers and layers and layers.
Dr. Swallow?
Also about decision-making algorithm for Chris. I don't think I saw in there, how does multiple metastases, in extraspinal locations, but then also within the spine, how does that play into it?
Yeah, so I think that speaks to that systemic condition in an individual patient, and I think that's really challenging. And so, I mean, I'm fortunate to have good collaborations, as Dr. Rampersad was alluding to. We put these patients on our multidisciplinary tumor boards and try to get a sense of, well, what's the molecular profile of the primary, what's expected survival, and we try our best, and sometimes we're right, and sometimes we're not, but that is really, that's why that's why when I'm thinking about this, I'm providing a local treatment for a systemic pathology, and I'll try and do the smallest local treatment that we can to minimize the morbidity and get them onto their systemic treatment, because we're not curing anything, it's just palliation.
The most important is actually if you can keep them ambulatory, because if they're non-ambulatory, they don't get chemo. And that's really, the surgery is stabilization, but it's whether they can go through the adjuvants. And probably the number one outcome is whether they're ambulatory after surgery. And then just as a break, whoever's on call, please call critical for me, okay? Okay, thanks. Is there any, we're going to switch over to trauma, so thanks a lot, guys. Those were awesome talks. Really appreciate it. And we'll have Jeremy and Henry coming up for taking us to the trauma side on role for MIS. So Jeremy works at Sunnybrook, which is our main trauma center, and has a tremendous amount of experience. He's a homegrown resident of ours that's gone on to really great things, and it's great I can't wait to listen to your talk.
Thank you so much. So for all the fellows and all the residents here, whenever you get asked to do a debate, there's a really important point here. It may not be your practice, it may not be what you do, but it's usually because there's a little bit of controversy in what the right answer is, and you're there to kind of guide people through some of the challenges. So I figured I'd do my best and basically say, this is MIS versus open, and do you have any questions? Really, I think the argument for why MIS applies to surgery has 3 big benefits I'd like to discuss. And I want you to think about all 3 of them carefully because they may be counterintuitive to some of your practice. So number 1, in the setting of a polytrauma patient, we're not talking about the geriatric C2 fracture that comes in with just a spine. Often when we have these patients, they're sick, they have multiple different areas that need to be addressed surgically, and one of the limiting factors is how much blood can they afford to lose and how long can they afford to be in your OR. So the trend towards both spinal cord injury and Non-spinal cord injury, unstable fracture is for early fixation. If we delay these patients, they don't do as well, they get more complications, they get DVTs, they get PEs, all these things are bad. So we want to get in and get out as quickly as possible. And if you can convince your anesthesiologist that you can do so with minimal to no blood loss, they're much more likely to say, yep, we can add this part onto the case. The second thing is that speed matters. You don't want your patient to get cold, you don't want them to be coagulopathic on the table, and MIS trauma surgery allows you benefit in terms of being quicker on and off the table. And if you look at the data, most of the gains comes from not having to open a wound and not having to close a large wound. And then finally, as opposed to everything that Dr. Lewis has ever taught you, we're not looking for fusion in trauma. In fact, there's good evidence that fusion doesn't add anything in trauma. So you're not looking for that decortication, you're not looking for that interbody component, you're not looking for that bone graft. Therefore, it allows you to get away from the classic techniques that we learned in degen and focus on something else in trauma surgery. So let me go walk you through all three of those points. So there's a really good paper, it's 2015, so it's a little bit dated, but it's still valid, which is a meta-analysis of the current strategies at the time. And they went through and looked at all the different points one after the other. And in this paper, what I want you to point out is this is the expected blood loss on the right as a pooled analysis for MIS surgery, and it clearly favors MIS surgery across the board. I tell people that it's really hard to get a whole bunch of neurosurgeons to agree on anything. It's probably more applicable for spine trauma, but this is important as well. And if you look in 2018, the Congress of Neurological Surgeons in the US put out guidelines for the management of trauma patients. And the one thing which is really interesting is there's probably about 25 different considerations they put into this guidelines, and the majority of them, I think 20 of the 25, have what's called insufficient evidence for recommendation. There are two things that receive strong recommendations. The first one is that percutaneous stabilization has a grade B recommendation, saying it's just as effective in terms of outcomes as doing open surgery. So I would argue that when we look at why it's effective, they clearly argued that blood loss was one of the major advantages during MIS surgery. The second thing that matters is speed. So if you look at the same paper from the Global Spine Journal in 2015, there's definitely a trend towards speed being an important factor in terms of getting patients on off the table in percutaneous surgery. So I've had a chance to learn a lot from Dr. Ahn. In fact, during my fellowship, I was actually at Sunnybrook, but what people don't know is I probably spent a third of my time with Henry, and I'd go and spend all my evenings and weekends with him, and I had a lot of good mentorship. But Dr. On has a nickname sometimes with the big cases, which becomes Dr. On and on and on. So speed matters, and you want to get out your cases very, very quickly. The third thing I tell people is that as opposed to everything else we've learned in degen, fusion doesn't matter. And the way to think of this is that if you think of most AO, A-type injuries, or B-type injuries, or even C-type injuries, it is rare to get a purely ligamentous injury. Most of the time, we're dealing with a crushed vertebra, we're dealing with a pedicle fracture or a spinous process fracture. And if you put your orthopedic hat on, and if I can get that fracture to heal, the implants add very little component to this in the long term. Versus when we're dealing with a scoliosis surgery or dealing with kyphosis, where the importance of changing the alignment in a permanent stasis is really based on on the ability for us to obtain a fusion. So when we look at the outcomes, which is probably the only grade A recommendation from the CNS guidelines in 2018, is that fusion is not required in order to achieve long-term beneficial outcomes in the setting of trauma patients. So this is one of the things that you have to break your habits and really think about this from a different perspective. So my last point, and really this is my advice to the fellows, is that when you are being tasked with organizing, you want to have every advantage possible when it comes to winning a debate. So this is a conference with Dr. On and I saying, hey, this is the debate, any preferences? And he says, no preferences. So before you respond to the text, spend 2 seconds to Google your visiting professor, their PubMed work, what they're known for, and what they've published in the past advocating for MIS treatment of lumbar fusions. And that's when you respond saying, how about I do the MIS side and you do the other one? Thank you very much.
Thanks a lot, Jeremy. And I know, I think trauma follow-up is a week, isn't it? Like long-term? Long-term is 2 weeks, isn't it?
2 weeks is long.
So that's why I'm sure your fusion results really don't matter. If you can get those guys to come back, that would be a miracle. So. Okay, well, I'm really proud to, usually the only time I see Henry on is at Scotiabank Arena, because that's the last 2 times I bumped into him. And it's really nice to see him and talk about both open and MIS with a big trauma experience. Thanks a lot.
Okay, thank you, Steve. As Jeremy indicated, this isn't necessarily my true beliefs, but I'm here to argue about open approaches for spine trauma. This is the overview, and I'm going to discuss very specific indications for open surgery and some of the disadvantages for MIS and the possibility of combining the two techniques, and when I specifically choose MIS over open. So MIS spine publications have generated a tremendous amount of volume over the past 2 decades, and there's been an exponential increase. But in the world of spine trauma, there is a specific role for open operations still. And these are some of the indications that I feel where the cases work best using an open approach. When there's significant neurologic compromise, need for significant and accurate reduction of a fracture dislocation, and need for biological fusion. Yes, there is still cases where you do need biologic fusion in spine trauma, or if you have a highly mobile and unstable spine, that makes MIS difficult. So going over the first point, neurologic injury, patients with severe spinal cord injury or severe cauda compression from various spinal injuries, it becomes very difficult to visualize and remove bone fragments using an MIS approach. MIS, you don't get the same level of control over removal of these compressive structures. Second indication for open spine surgery, if there's a need for a significant and accurate reduction of translated facet joints. So basically these are for the AO type C injuries. These are best managed with direct visualization during the reduction. MIS techniques where you don't see as well makes it much riskier and often can lead to just in situ stabilization of the injury without any true reduction. So this is an example of an AO type C injury. You can see it's a fracture dislocation through the lower thoracic spine. This is a high energy Asia A spinal cord injury. This is the severe compression at the level of the injury with the dotted blue lines. This is the MRI scan showing the severe cord compression and the spinal cord damage that has resulted from this car accident. This is an open spine operation. You can see the damage to all of the ligaments circled in green. And I would argue that you need that open approach to actually get this reduced properly. These are Schantz pin-like screws that are in, and basically the reduction maneuver involves pulling up on the north end of the patient's injury and pushing down on the south side of the patient's injury. So, and this is a video showing what kind of maneuver is needed to straighten out this patient's back. Using an MIS technique, you probably wouldn't be able to achieve that level of reduction. And this is what it looks like afterwards. But you do need that open approach to get this kind of reduction here for this high energy injury pattern. This is another example of a AO type C rotational fracture dislocation. Again, you need that direct visualization to reduce these facets. And you need that direct visualization to see when those facets have realigned. So using an MIS technique, this kind of maneuvering may be very difficult. And the third indication is for when you need biologic fixation. And again, there's tremendous difficulty achieving fusion when performing MIS. You need that open bone surface area to apply your bone graft and your biologics. And again, this is more for complex cases with ligamentous 3-column injuries, AO type C fractures, And situations where you end up doing a wide decompression or a transpedicular decompression to open up the canal, you're left with very little bone dorsally, and you need some sort of fusion to hold everything together. So this is an example of MIS, and yes, I do MIS surgery, but this type of case for standard stable burst fracture, there's no room to put any graft through any of those small keyholes. Eventually, without removal, the screws will break or the rod will break over time. So, and lastly, another indication for open spine surgery is the highly unstable mobile spine. And again, this goes back to these complex cases. A lot of our MIS percutaneous screws are now placed in with navigation, with intraoperative scanning. But when the spine is highly mobile, the pedicle will actually move under the pressure of the pedicle awl. And the position that the spine ends up in may not be the same position that the spine was scanned in. And this risks a lot of misplaced pedicle screws, especially when the pedicles are very narrow at L1. Open cases, you're actually able to directly see the pedicle, look at the landmarks, and guarantee that the tips are in the accurate spot. And lastly, when you do open surgery, you don't need all of these adjunctive imaging techniques necessarily, or if you're not using 3D imaging equipment, you're using fluoro for these MIS cases, and so you don't need all of this additional equipment. If you don't have 3D equipment and using fluoroscopy, there is a significant amount of radiation exposure that does occur to the hands and eyes of a surgeon. And this is a good paper by Bindel that looked at sextant cases done with fluoroscopy, and you actually exceed your annual exposure limit after about 190 cases. So overall, disadvantages of MIS, it's not the perfect solution for everything. You're unable to treat complex spine cases, you can't visualize the injury itself, and it certainly isn't a great choice for patients who have significant neurologic injuries and need an accurate reduction and require fusion. But when is MIS techniques well suited? Well, there are certain key cases at a level 1 trauma center where I look at using MIS techniques. One is lumbosacral pelvic dissociations, vertical shear injuries of the pelvis in the setting of a Morale-Lavalley degloving injury to the pelvic region, in addition to stable bursts, which are relatively minor amounts of trauma compared to most of the other work we do, and basic thoracolumbar flexion distraction injuries through the pedicle. So this is an example of lumbosacral pelvic trauma in a young patient who had significant blood loss and required a trauma laparotomy. And you can see that I've put in those AIS pins, external fixator from the front after the general surgeons did their trauma lap, went to the ICU, and then we brought them back when they're resuscitated to fix their lumbosacral pelvic dissociation. That's a Jackson table with weights hanging on the leg to pull the leg back into place and hold the pelvis in a reduced position. And then I think this is a good role for MIS surgery because there's a significant amount of degloving around that region of the body. We use an intraoperative Zeem machine to get intraoperative imaging of the pelvis and spine. And we then place all these screws percutaneously using the navigation system. And a lot of this, and the screws include S2AI screws, and this is all done percutaneously here. I'll just go quickly through that. And these are big 10 5x100s that are going in to stabilize the pelvis. And the rod is inserted percutaneously. And again, this is through a zone of degloving, so you want to minimize tissue exposure here. And then the other thing that we do to supplement all this is SI screws going from the side of the pelvis. And these are 8.5x90s going across to fix this vertically unstable pelvis. So I think this is a good reason to do MIS in a level 1 trauma center is the lumbosacral pelvic dissociations that come in. But there's also opportunities to do hybrid techniques where you do open and MIS together, and you can use the percutaneous screws to supplement an anterior approach. And certainly this is another example of a polytrauma patient who fell from a high height, has other injuries that were fixed, and has an L5 severe burst fracture. As you can see here, it's completely crushed in this young patient with bilateral foot drop. And so the management for this was to go from the front through and to do an anterior corpectomy. So it's an open approach, and basically we took out the vertebrae, rebuilt it with a expandable V-lift cage and a kick-out plate from the front, and then filled with some other material. And then we noticed on post-op scan there was still some bone fragments there, so we did a staged posterior approach again with, and this is the percutaneous part. We went in percutaneously and put in our pedicle screws, and at the same time did a little MIS decompression from the midline. And again, so this is an example where you can combine both open and MIS. And that's the post-op with all the bone fragments out. So in summary, the open techniques for spine trauma, in my mind, is still the gold standard despite all of this new development in MIS surgery. And there will be an ongoing role for this in the future. Okay.
Thanks a lot. We'll open up for some questions. In the meantime, one of the things I find for a kind of a burst fracture, when I reduce the kyphosis, I find the distal superior facet migrates up into the foramen. Do you guys have that issue, or? Because you get a bit of shortening, so the superior facet from, let's say it's an L1, so the L2 superior facet I find abuts on the L1 pedicle. Is it something, I usually chop it off open. I'm just wondering if that's an issue that you guys encounter.
One of the advantages sometimes is if you have an index screw at the level of the fracture, it allows you to dial down that fracture. So I'm a big believer in putting a short index screw at the level of the burst, both to restore lordosis, but also to control where that, that intervening fragment is aligned. Because I think you're right, sometimes you put them prone, and I see that there's gaps open at the bottom of the fracture versus the top of the fracture, and the pedicle can go one way or the other, and you don't control it unless you put a third screw into the construct.
Yeah, I've always been doing an index screw also. And then a lot of the stable bursts I've been doing just basically ligamentotaxis, MIS, and then taking the screws out once the fracture's healed.
Dr. Camp?
Hi, great talks, and for the previous speakers. So Jeremy or Henry, in this debate between open versus MIS, I feel like both boxes are boxing against shadows, because the MIS surgeons will quote literature from a decade ago how bad open surgery was, but open surgery is advanced, with ERAS techniques and, getting patients up and about and out of hospital. The benefit of MIS is becoming smaller and smaller and smaller. In the same way, open surgeons will argue about how difficult MIS surgery is and how long it takes to set up, and MIS has improved. Can you just comment on that?
Yeah, I'm happy to go first. One of the things that's changed in trauma is also the speed at which we are being asked to intervene, or we're suggested to intervene. So we published a study a couple years ago looking at, if you look at the hip attack study, for example, everybody said if you wait more than 24 hours with your hip fracture to get fixation, your mortality goes up. So we looked at saying, well, if someone's on full spine roll precautions, isn't that the same thing? And the answer is, yes, it is. So what's happened now is that, yes, techniques have changed, but I think what's happened now is more and more priorities are changing. So we're just, we haven't published this yet, but we're looking at concomitant chest injuries with spinal injuries. And turns out you have a window of about 24 hours to get someone fixed, so they can sit them up in the ICU and get their chest physio started. And if you wait and you delay, you may not be cleared to go back to the OR for weeks. So I think that what's happening now is, and don't get me wrong, I think we have a very similar practice, is that you have to use the tools available to you to get there quickly, safely in a very acutely ill patient. And sometimes MIS has certain advantage. I think what's happening more and more is a lot of these hybrid constructs where you might perk your screws, you might do a focal decompression on one level because of the neurology or the reduction, but you're trying to do so in a much sicker patient earlier on than you would otherwise.
Yeah, And I completely agree with that. Like in terms of the benefits of MIS, I think it has to be very specific case by case. And it's for me, it's another tool that can be used. And certainly in some cases where you think MIS would be a great option, especially when they're morbidly obese, I actually find that sometimes very difficult with the multi-level injuries and passing the rod and making sure that the rod reduces nicely. I don't know, there's different factors can add additional time when you think that it should be a shorter procedure. So, but whatever tools available to get the patient to the OR quickly.
Dr. Wang, do you have a trauma center at your place? And, tell me what your experience is.
I mean, I neglected to talk about it, but it really came in handy when we were in Haiti after the earthquake. So after the earthquake, 2010, we went down there. Anytime they opened somebody even a little bit, they got an amputation or whatever. I mean, it was really horrific there. And, we were able to bring cutaneous fixation into Haiti and fix lots of people with very low rates of problems, whereas people would get shipped to the USS Comfort, one of the naval ships, and they would have a surgery of any sort, and they'd come back and they'd get infected within 2 days. And so it really had a big advantage there. And then I think if you think about disaster preparation, I don't know if you have much in Toronto, right? You don't get earthquakes or anything here, do you? No, you probably don't get stuff like that. Yeah, but in the environments we're talking about with Pakistan, right, or China and parts of the U.S., like have earthquakes, on the back end of Haiti, we actually built a program. U.S. government was very interested about how to handle mass casualty crisis, natural disasters. So it has an ability to do, the idea of like maybe doing perk screws in ICU, right? Like you're saying about ICU. That was the goal, is that you just take someone with a fracture, you put it on like a Lizaroff, and you take care of them that way and then stabilize them. Hopefully we get to that some point. I think there's not a lot of economic drive to do that, but when disasters happen, it can be very effective.
Okay. Thanks a lot, guys. So I'll pivot to more to deformity. And, what's new is, I think one of the things that we always look and see what the good news about spine surgery is you can always do it better. And I think that's the thing we're always looking for. And so I've been trained on the big open, and I see Mike, and we hang out a lot, and all of these committees we share, and he's MIS, getting better. And then, I find I like to do these major deformities, and Mike, is there a way of doing this through a scope? I was just wondering if you can put a couple of endoscopes in and straight, because I haven't learned a better way. But I can tell you, when I have a case like this, barely anybody comes. But I see you leading the way on a more minor procedure. And if you come to my room and I have a list like this, osteotomy major, it's like nobody comes. I barely get one fellow. I have a list, SI joint, navigator fusion, and the crowd goes wild. Every fellow comes to my room. And I'm exaggerating, because I usually get one Bobby coming, at least to my big case, but not with the same raucous and enthusiasm that I got for my navigated SI joint. So the question is, do we actually need to fuse this joint? And so this is a case, 5 years later, we work hard. I got him as a revision, and I got him all kind of fused, high fives everywhere, and he comes back 5 years later with a broken rod. And where's the broken rod? So we look and see a CT, and everything's solidly fused, and except for his SI joint, which really the trend was not to fuse the SI joint. We just put the screws in across the ilium, protect the sacrum from breaking, and it really helps getting the fusion at 5-1. It helps everything fuse, but we actually never fused that joint, and I fused all the other joints, but I never fused that one. And then I'm part of the AO Knowledge Form Deformity, and Dave Pauly here, he's saying, you gotta fuse that SI joint, and I thought he was crazy, because I've been learned, really that it wasn't necessary. And then you get all these articles, if you fuse someone to the lumbar spine, their SI joints hurt, and they have more and more SI joint pain, and maybe that pain is high. And then, they look and see what is the prevalence of SI joint pain in general. Well, as patients, just with back pain, it may be up to 30%, and if you add a fusion, maybe it's up to 45%. And at the end of the day, you look at all this thing, this SI joint degeneration after spine fusion, and everybody has all these rates, average 38% up to 24%. And the question is it real, and how bad it is, and how important it is? And so we looked, Dave put a thing together in terms of, and he showed that 22% of long fusions to the pelvis were going to have some sort of spinal fixation failure. But actually, like I said, I just don't see that. You know, it's really not that big a problem. But he included pseudoarthrosis, rod fracture, sacral fracture, set screw dislodgement, iliac screw failure, iliac screw loosening. So lots of different problems. So 8 different problems to come up with 22%. But at the end of the day, when someone has butt pain, you have no freaking clue where it's from. You know, it could be, I've heard piriformis syndrome, SI sacral. I mean, there's a list of 15 I could put, and probably someone could put another 15 if you really needed to. But so how do we even diagnose someone who has SI joint pain? Well, we have all these maneuvers that physical exam maneuvers, I think are kind of useless, but we do them for fun because they're part of our studies. And so if they have 3 or more, they have an 85% chance of having a positive predictive value of having a good answer with a diagnostic SI joint injection. And I usually skip the physical and go to the diagnostic injections. And you can do them either with fluoro or CT guided. And I think that is really one of the things. And then Dave did a study looking at, does actually SI joint injections help you decide who needs a fusion? And basically he said if you got a 50% improvement in your pain with an SI joint injection, then you'll have a good result with a SI joint fusion at that point. So that's roughly where the literature is, and if you make the overly stringent at 75%, perhaps you're making people not need it. So the question is, so what are our fusion approaches? And we know for our long fusions to the sacrum, we're always going to go to the pelvis. The question is, should we fuse the SI joint at the same time? And so there's really 3 ways of attacking the SI joint. You can do a sacroiliac, you can do straight intra-articular, and then there's the iliosacral versions where you can go from lateral or from posterolateral. I don't like the posterolateral. I usually do a posterolateral, not a lateral. So these are just the different techniques. And Dave Pauly was part of this company that made these fenestrated screws that actually fuse as you put your S2AI, you get a fusion across the joint at the same time as putting the screw. So what I find is that I don't like the lateral approach because the superior gluteal nerve and vessels run in that gluteus medius and maximus plane. And so I like to stay a little bit above that notch so that I get a more posterolateral and I avoid injuring those structures. And that's kind of what it looks like here. You can, I'm going backwards. And you can see the anatomy, and you can see the nerve coming through the notch and then up between over the media. So I try to make sure I stay high with a posterolateral approach if I'm going to do that. This is Dave doing, unfortunately with all our percutaneous, no one took pictures of our cases, so I don't have any of me, but I got at least Dave Pauly's pictures of what it kind of looks like to do that. So, and this is the teardrop we look at. I always try to put my S2AI right at the bottom of that teardrop so that we have room to put a second iliac if we want to. And this is kind of what it looks like. You put your bottom screw right at the bottom. This is from Dave with his special screw. You can see you put it right at the bottom, and then you have room to put a iliac or another S2 iliac on top of it if you want. And this is kind of what it looks like for one of his cases that he did. Now here's our case that I had a crowd in the OR. So we did, this patient came like this. We did an osteotomy. We straightened out, did a fusion right to his sacrum and pelvis, put the cages in, got everything fused except his SI joint, and he complained of pain. And so we did the percutaneous SI joint fusion with a raucous crowd, as I taught before, and everybody enjoyed. We put the tracker, all percutaneous. For some reason, he still ended up staying one night, and went home the next day with 3 little incisions, one for the tracker, one for each screw, and 3 assistants. Each one got to do something. So. And so just a different case. So this is a case that had a disc replacement surgery, and then I had to fuse him from the back, and I didn't fuse his SI joint. I had to come back and add an SI joint fusion for him as well. So, you know, these are a patient, I would say that these fusions, even at, you do a solid fusion, the patient comes with back pain, and this particular patient said he had a magical relief with his injection, and we did the fusion. He was very happy, of course, until I had to add up higher on him, which is part of the problems that we have with surgery. It's a never-ending thing. You can always fuse higher. So right now, I've actually incorporated primary SI joint fusions into my current practice, and so this is a case that we did, fortunately, on Friday, so I had pictures for you guys. So this is a picture of the iliac wing, so you can see the iliac wing and the sacrum. There's an S2 AI screw and a sacral screw, and then you can see we clean out the whole SI joint, clean it out, cauterize it, curette it, and then I take a piece of the iliac wing, which is right north of it, and we get a nice piece of bone, and then we jam it into the SI joint. It gives you a really nice press fit. You can see it's kind of it being impacted into the joint, and that's kind of what it looks like. We have the O-arm spin just to show you. You can see how nice that piece of bone fills in the whole SI joint. So you get a really solid piece of bone right away, the cheap way, so that I don't have to use up our whole budget to fuse the SI joint. So that's kind of what it'll look like post-op. So I have the trauma follow-up of 1 day, and with a good result so far. So in theory, in summary, the SI joint is real, pain is real, especially after long fusions. Stabilization without fusion, probably not enough in some patients. I'm not sure that all of them need it. And I think the primary SI joint fusion has become part of my current practice in primary fusions that extend to the pelvis. Thanks. Okay, we'll introduce Mark Camp, who's at SICK. He's a pediatric orthopedic surgeon who trained in all of pediatric orthopedic and CP and has transitioned over to being a full-time spine surgeon. So welcome, Mark. Can't wait to hear yourself.
Thank you very much. I appreciate the invitation, Steve. I realize it's probably punishment because I can't handle more than 20 minutes of MIS talk, and I guess I've reached my limit. Anyway, here are my disclosures. I'm a maximally invasive surgeon. Most of my practice is big open surgery, T2 to pelvis or similar. So, this spinal deformity surgery is a bit like Super Mario Brothers. Now, it might be an evidence of a lonely childhood, but I like to think it's more of a pursuit for mastery. Now, you can do spine deformity surgeon like this player on the left. You can see that they lollygagging through the level, making lots of unnecessary steps, errors. You'll watch them die pretty soon. Or you can rather be like the player on the right, where there's no extra movements. They are dominating from start to finish, and they're on the tee box before noon or shortly after noon. And, that's what I try and aim to be. Watch them finish now. Boom, 5,000 points. Okay. I'm not advocating rushing. What I'm trying to advocate is really minimizing your unnecessary steps so you can pursue other activities that are important, whether that's in the operating room. So when you're Raj Rampasad, you maximize your time with screw insertion, but then you've got extra time when you're trying to take that tumor off the dura safely, so you don't have to feel pressured or rushed, right? And so that's what my strategy has been. And ultimately, I don't think this talk is going to, reflect everyone's practice, but hopefully you'll be able to take away one or two of my points to make you reconsider your workflow, regardless of whether or not you're an MIS surgeon or an open surgeon like Steve and myself. You'll see lots of surgeons or hear lots of surgeons who stand on the podium boasting about how they do 2 scoli surgeries a day. But most of those surgeons have many high-efficiency workflows that rely on factors outside of their control. They might have a second operating room to switch into so they don't have to wait for a changeover. They have a secondary staff surgeon who assists with placing pedicle screws on the convexity. They might have a plastic surgeon who closes for them so they can start their second case. Or they might have very small waiting lists so all their cases are marginally meet the threshold for surgery. Obviously, all of us can do those cases quickly too. So I'd rather focus on what is in my control.
Friday night, I was just going through the film.
And we'll just hear from the GOAT
I knew
first.
Kansas City's defense better than they knew themselves. I knew their body movements, the way their linebackers moved, the way their safeties moved, Tyron Matthew, Nick Sorensen, Shavarius Ward. I knew everything they were doing. I got out there on the field. I looked up as I was walking line of scrimmage, and said, okay, they're blitzing. And then I was dealing with it right away. I walked up, I said, okay, they're gonna bail to cover 2. Ball snap, cover 2. I knew I had the answers to the test. That's where I was great. That's where my magic superpower was. It wasn't how fast I could run. It was how fast I could diagnose what they were doing.
So that's Tom Brady. If you don't know who that is, ask your husband or wife. Anyway, preparation beats improvisation every day of the week. And so just like Tom, when I walk to the operating room, I want to know exactly what the defense is doing, okay? In this case here, something that you're going to take away from this talk. You guys need to break away from the shackles of radiology. I see so many neurosurgeons and orthopedic surgeons looking at CT scans upside down, right? We operate with the patients prone, and so you need to flip your CT scans over so you don't have to do mental gymnastics in your head. Anyway, that's another tip for free. So here you can see that my left L5 pedicle screw is going to be a problem. The iliac wing is going to block it. So I've got a couple of options. Right away, I'm going to bail and osteotomize that iliac crest straight away rather than struggling to get that screw in. Here you can see my rotation at my apex is going to be awful. That rib is going to block my entry to a safe pedicle screw, so I can either bail, and in this case I'm going to bail straight away to a sublaminar tape, so I take that misplaced screw out of the equation. And then here at L1, my screw is just far too small, the pedicle is far too small to accept a reasonable screw. In-out in is not an option because it's not going to get me great purchase, so I'm just going to skip it. I distribute that surgical plan to my operating team so that everyone's playing from the same playbook, and that's given about a week beforehand. And I make time, usually while the patient's getting put asleep, I plan for the next week's case, so it's done in a week in advance. Instrument strategy, there's a huge amount of time wasted between transfer of surgical instruments. So when you're doing a big case where you've got multiple repeated steps, I use an instrument once and then hopefully never again. And ultimately, I'd like to have a really nice cushion like they have at Sky Zone with the trampoline park. I just throw the instrument over my left shoulder and never have to use it again. So I ask for the ultrasonic scalpel. I cut out all the facets. Then I ask for the rongeur, remove all that bone. Then I take the burr out all the articular processes, all the facets, cartilage off the facets, gel foam all the facets, and then I can move on to screw insertion so that my screw insertion is not being interrupted by constant instrument transfers. And this minimizes handoffs, decreases frustration, and ultimately my scrub nurses are much happier. In my OR, there are 30 steps to putting in a pedicle screw. They might be shorter or more or less in others. But any step that's going to be repeated multiple times, that's a great bang for your buck, and so you can get compound gains. With my pre-op planning, I no longer have to measure screws because the CT scan is so accurate. So right there, I save 5 steps. Tapping is also completely unnecessary, except in the apex. You have to tap 250 pedicles before you get the benefit of feeling a breach above that which you could feel with just a pedicle probe itself. So there I'm down to 21 steps. And this strategy works. You can see over the last 5 years since I started using navigation, my time per screw has dropped dramatically. And what I like most of all in this graph is you can see when my partner joins the navigation team, you can see that he got to benefit and piggyback off my work earlier, and very quickly he's reached the same optimization. And this is not me putting in concavity and the fellow putting in convexity. This is usually fellow putting in concavity, resident putting in convexity. So it's a fantastic, it's reproducible across many different practices, academic and community. Rod reduction can be a massive time sink. And so as the number of levels increase, the difficulty of reducing the rod increases exponentially, and usually it's just a bun fight against mechanical resistance. And so I use navigation not for accuracy, because I think navigation against freehand pedicle screw inserters has never been shown to be more accurate, at least in scoliosis. But I use it to execute my plan. The challenge is not putting in a pedicle screw. Any monkey can do that. But it's putting in the pedicle screw so that your tulips all line up, so your rod reduces very easily and you don't have that frustrating 45 minutes to an hour trying to get that rod reduced at the end. So, you can see, take a look at this screw plan that I've got here, and you can see that putting in that convex rod at the, once you put in your concave rod, you're going to have real trouble inserting that rod without at least getting 1 or 2 screw pullouts, right? Now you can use polyaxial screws, but that's doing deformity surgery with training wheels. If you want to execute like a boss and feel like Peyton Manning in Super Bowl 46, you want to have all your tulips lined up perfectly, right? And I get to have this feeling every single time I put that rod in, because my rod just lines up beautifully with my tulips. The reduction is so quick and easy, and I can get on with my day. I could watch this clip for hours. Maybe we'll go on
Except
repeat.
it's not Peyton, it's his brother. So.
Yeah, Eli Manning. Yeah, Manning to Manningham.
It's Eli.
Yeah, Eli Manning.
Okay. I said Peyton, but.
Did I? Okay, sorry, Eli Manning. Apologies. Steve, always. Okay, future directions. ACL surgeons have long ago delegated graft preparation to their surgical assistants, since about 2005. And the idea that we're still cutting, bending, and contouring rods is ludicrous. And we shouldn't have to, we should strive for the same efficiencies without having to pay the exorbitant fees that Medtronic asks us, right? I think it's like $2,500 a rod. That's outrageous. But the maths isn't difficult, and I'm sure that's going to be coming soon. So take-home messages: focus on what's within your control, invest in preoperative planning, standardize repeatable steps, use technology for efficiency, not just accuracy. And with the relentless pursuit of perfection, you can see the difference between Formula One and over the last 30 years. Blink and you've missed that pit stop. Those two pit stop teams, they still have the same desire, and that's to make sure that their driver is absolutely perfectly safe. So this doesn't mean that we're compromising on patient care or patient safety. It's just a relentless pursuit of perfection. Okay, thank you.
We'll open up for some questions. Jeremy?
Can I ask about your SI joint fusion? So, both in terms of treating it at the initial onset versus your revisions, have you been collecting data looking at pain outcomes at like the 3 months or 6 months if you initially fuse? Because I do a lot of S2AI screws, and there's a concept that people fuse with S2AIs. They never fuse, and I see halos on every one of them in the long term for trauma. So I'm very interested in your strategy about fusing it right from the onset and what that leads to in patient-reported outcomes or radiographic outcomes at whatever time point.
Yeah. So I mean, I've had, when we look at our outcomes, our patients have, usually we start 6, 7 out of 10 for back pain, and after we're 2 to 3. And I've had a bunch of patients with just persistent low back pain. Everything looks fine. Solidly fused, rod's even not broken, but they're still hurting down there. So we do SI joint fusions. And I'd say there's been a number of patients that I've had to take them back and I've been double up their rods and fusing their SI joints, or I've been doing the percutaneous ones at add-ons. And I can tell you they said, why didn't you do this earlier? And they were so happy. Like a few of them, I had one lady who was paraplegic, and she couldn't walk. She was in a chair, back pain all the time. We just doubled up her rods and fused her SI joint, and it was like night and day for her.
So for your future fellows for next year, could we get a retrospective cohort study looking at your previous practice to now?
Yes, well, we've switched to dual rods too.
Yeah.
So I think that makes a difference too, but we're doing the primary SI fusion. So I need a few more cases. I'm trying to get Chris to do them too, so hopefully we'll have some numbers. But I think anecdotally my low back pain rate is lower, and so we'll see. Maybe, because we looked at our data long term. At 1 year, you get the same data at 2 years and at 5 years. So I could probably get our 1 year pain for some of these scores. Maybe we're getting them down even lower. So as long as I didn't damage a nerve or something, but the back pain scores we'll look at. So.
Thank you, Dr. Lewis, for your talk. What about joint fusion, SI joint fusion for primary back pain? What are your thoughts about that and long-term outcomes?
Yeah, so I think the SI joint has gotten a lot of publicity over the last 5 years, and the amount of articles that have gone from SI joint is like, they blame, they used to have piriformis syndrome to blame everything on, and now they've moved it to SI joint. So I think now that, a lot of the injecting SI joints is very common, getting a really more accurate diagnosis, I think there's been a big trend moving to these percutaneous procedures for it. And there's been a lot of work showing that even a short lumbar fusion loads up the SI joint 2 to 3 times more than normal. So I do think I've had a number where I've just done the SI joint. Like, you know, you look at their backs, they have a little bit of degeneration, but really not much else. And we inject their SI joint because their pain's out to the side, and then they say they feel great. And so I've had a few of these where we've done these fusions, and they've been quite happy.
Is there any concern about adjacent vertebral disease in these more younger people, like S1, L5, S1, following fusion of the SI? Is there any data on that?
So Dave Polly's looked at SI joint fusions in long constructs, and there was, I think, a much higher rate of hip replacement than patients without. Not sure what, like his rate of hip replacement, I think they're going to publish it very soon, but their hip replacement rate was higher. So it does load the hips more. You know, the spine we blame, there's so many levels to blame on, so, but the hip replacements was something that was a bit more interesting that I think most people are working on.
Thank you.
This is a comment, not a question, that's prompted by Dr. Camp's sort of basic thesis that we should focus on what's in our zone of control. So for the surgeons in the room, I would just like to encourage people to think about or consider increasing their zone of control. So Dr. Wang spoke about this in his talk, how influential we can be. And I'm not suggesting that you do this because you do a lot of other stuff, but for people as they become more senior and more mature and have the opportunity to sort of reflect on where can I have the greatest impact, I think sometimes sort of zoning out to the bigger picture and what could I influence if I was prepared and could speak in a sophisticated manner to a larger audience. I just want to come back to your point about what you can achieve. So not to take anything from you.
No problem. Yeah, my zone of control gets big. I get pushback all the time because I'm now controlling where the implants are kept in the hospital. So my plan now includes where a nurse. So if the nurse is brand new, I don't have to wait in the case to ask them to go and find a screw that's not in the caddy. They know exactly where to go. It's almost down to the map detail. We get down to steri-strips, the number of steri-strips needed that I need, and where those steri-strips are located. And where they're located if the original box is empty, where you can get a new box.
Right. Raj?
This is for Mark, and thanks for a great talk and also fixing my daughter's tibia. Greatly appreciated that. So he does more than spine. But so as you nicely pointed out, efficiency is multiple things. It's not just one thing. You can't just add navigation and all of a sudden, or have somebody bend your rod. It's multiple things. And you just partially answered my question. How much have you integrated the nursing team, the supportive team, even anesthesia, into your quest to be more efficient? Because they're often outside of your circle of control.
It is a challenge because they are incentivized differently to how we are. When my day is done, I'm incentivized because when my day is done, I can go and spend time with my kids, right? When their day is done, they just get assigned to another operating room. And so that has been a challenge. We've tried, I take them, if I finish it by 1, I get permission from my hospital to allow me to take my nursing team out to Nando's. That's my favorite restaurant. Nice. Big plug. But it's a challenge because the administration is very anti that. Like, why are my spine nurses able to go for lunch, but every other nurse has to go to another room? Difficult. I don't have an answer. Really. But Kareem and I go to lunch once a week. I've even got the points.
He's working on his zone of control at home now, and he'll update you very soon for the next year for SpineFEST. So.
Still a cage in the basement.
Okay, well, thanks a lot for all the speakers and interesting session, and I think we're going to move on to the... We'll move on to the elevator pitches, and we're going to start, I guess, who's it, Ali Elva? He's going to speak to us today about the impact of neck pain on functional quality of life outcomes in cervical myelopathy. Number 17, if anybody's following.
Perfect. Right, so one of the things we focus in Dr. Feely's lab is understanding outcomes and drivers of outcomes of patients with traumatic and non-traumatic spinal cord injury. So in this study, we wanted to study the impact of neck pain on quality of life among patients undergoing surgery for cervical myelopathy. Neck pain is present in 80% of the patients who present with DCM and has been identified as an important top recovery priority following surgical intervention. So we utilize a combined data set of 1,047 patients that has been discussed previously from 3 clinical trials, and we studied the impact of neck pain at baseline and also at follow-up quality of life using SF36, which is a known metric for documenting quality of life. We found that not only patients with neck pain have poor quality of life at baseline, but they're also unable to achieve the amount of recovery in terms of quality of life after 1 year after surgery compared to patients who present without neck pain. Thank you very much.
Okay, Dr. Gia, enhancing spinal cord regeneration through neural stem cell transplantation combined with rehabilitation.
Hi. We focused on the neural stem cell transplantation combined with the rehab activity on the recovery after the spinal cord injury. Actually, we use annual rats with a clip conversion model. These rats are divided into 5 groups: the stem group, the sham group, injury group, the stem cell group, a rehab group, and the rehab plus the stem cell group. And the stem cell are transplanted after 2 weeks post-surgery. And for the rehab, the rehab was conducted both daytime and nighttime. These rats are required to retrieve their palate by the forearm, and this is continuous and voluntary motor training. And for the food intake, the first result, the food intake, there's no difference in these 2 groups. This is a good result because this shows the consistent rehab engagement in these 2 groups. And for the next thing is for the food intake of the nighttime significantly increased after 2 weeks post-cell transplantation. This reflects the 5-moment recovery of the stress of the forearm. And the midterm result of the grip strength test, the 3 experiment group are significantly greater than compared to the injury group. And for the rehab plus the stem cell group, the grip strength data are also greater compared to the stem cell only group. In the incline place data, there's no significant difference compared to these different groups. Additionally, the MPC plus the stem group, rehab group also showed the good positive trend of the gait and the forearm use. This will suggest that combining the neural stem cell transplantation with the rehab activity will enhance motor system recovery. And we will monitor them during the follow-up. Thank you.
Thanks. Dr. Lisa, present on role of somatosensory evoked potentials in enhancing intraoperative neuromonitoring for spinal cord deformity surgery, results from a prospective multi-center study.
All right. Good afternoon, everybody. As you know, neurological deficits are not uncommon in spine deformity. For that reason, we use intraoperative neuromonitoring to decrease these deficits. The aim of this study was to identify the circumstances of SSCP detection during deformity surgery and to identify the SSCP sensitivity in neurological deficits. It was a prospective observational study in 20 international centers. And we used only single nerve for the monitoring. Out of actually more than 546 cases of deformity spine surgery were included. Out of these cases, only 16 cases actually had intraoperative neuromonitoring alerts by alerting the SSCP. And out of these 16 cases, only 4 actually had neurological deficits post-operatively. On the other hand, 13 cases of these 546 cases had neurological new sensory deficits post-operatively. However, only 2 had intraoperative neuromonitoring alert. So in conclusion, the current protocol with single nerve coverage of SSCP did not contribute to improved safety in complex spinal deformity surgery. Further studies are warranted to improve this. Thank you very much.
Gurjovan Sahi to present on the spinal invasiveness score can better quantify surgical waitlist across Canada.
Great. Excellent. Hello, everyone. My name is Gurjovan Sahi. I'm a third-year medical student here at University of Toronto. Presenting my study here on spinal invasiveness score and how it can improve waitlist management for spine surgery in Canada. So spine surgery waitlists are inherently flawed. Unlike joint replacements where every patient gets the same procedure, spine surgeries vary widely in complexity. A discectomy might take under 2 hours. A scoliosis correction can take over 6, yet both can be entered into the same queue. This creates a mismatch. Patients needing simpler surgeries often wait just weeks, while complex cases can wait over 1.5 years. And that's where the spinal invasiveness score comes in. It's a validated tool that assigns points based on 6 surgical elements, like decompression, fusion, and instrumentation, both anterior and posterior. So for example, using the score in L4 to L5 TLIF, we'd get 1 point for posterior decompression, 2 points for posterior fusion, 2 points for posterior instrumentation, so it would have an overall score of 5. So SIS allows surgical bookings to be converted into a standardized system for triage, throughput tracking, and hospital level planning. And to assess the feasibility of this, we surveyed 21 spine surgeons and hospital administrators using a case scenario comparing the current system, which is just a simple count, to an SIS-based model. And so in this scenario, we assigned 3 hospitals to different SIS thresholds based on their complexity, ranging from low complexity day surgeries to high complexity tertiary care. And this setup reflects how resources can be better aligned with case complexity. So 81% of the participants prefer the SIS-based model. They cited improved triage, fair resource use, and more efficient scheduling. Concerns included capturing non-anatomic complexity, so BMI, revision status, and integrating into existing systems. So in short, SIS is a simple, scalable tool with strong support. It can make surgical waitlists more fair, transparent, and efficient across Canada. Thank you so much.
Dr. Abbas on the timing of thromboprophylaxis in acute spinal cord injury patients at TKIP study.
All right, so thank you for the introduction, Dr. Lewis. We know that the timing of thromboprophylaxis in these acute spinal cord injury patients is extremely important. You want to try and prevent things like a DVT or a PE postoperatively. So generally, a lot of the guidelines come from very small studies, and there's not actually very good large database studies looking at analyzing what the optimal timing is for these patients. So our goal was to try and figure out what's the optimal time with respect to giving these patients thromboprophylaxis. So what we did was we did a large database study on the TQIP database looking at patients from 2015 until 2022. And we looked at adults who had acute spinal cord injuries and had received surgery within 5 days. And what we did was we did a propensity, a splines regression analysis to try and figure out at what point do they actually have an increased rate of complications. And then we subsequently divided the patients into early versus late DVT prophylaxis. And then afterwards we looked at complication rates as well as return to OR and death. And so in terms of our analysis, we found that at around 4 to 8 hours is a time where the complications rate starts to increase when you delay DVT prophylaxis more than that. And specifically, we found that the rates of VTE went up to about 15% in patients who had DVT prophylaxis after 4 to 8 hours, but that wasn't statistically significant. So we're going to look into that further. And then the other rates were also quite longer for the delayed group. So in conclusion, there is evidence for early DVT prophylaxis post-spinal cord injury surgery. There is a possible role for less than 24 hours, which we'll look at in further analysis. And then this also supports further prospective studies. Thank you.
Dr. Lazarus to discuss the direct surgical repair and management of spontaneous CSF leaks, a 6-year retrospective Canadian cohort study.
Thank you very much. Just like to point out one of those SI perk screws were mine, and I'm very proud of that from Dr. Lewis's talk. So so CSF leaks spontaneous that are very rare, about 3.8 per 100,000 cases, and there's various ways to anatomically classify them. The most common one is this one with a type 1 of ventral tear, type 2 proximal nerve sleeve, type 3 a CSF venous fistula, type 4 is a distal nerve root sleeve. Top corner there you can see our protocol for managing these patients, and generally they're managed by non-targeted epidural blood patches. If that fails, they can go on to a digital subtraction myelogram, and then depends on where the leak is, and ongoing symptomatology depends on how we manage the patient. So we had a 40 patient sample over a 6-year period. Most common presenting symptoms were headaches, and then the most common type of leak was a type 1, usually from a calcified disc in the thoracic region. Depending on the type of leak and where it is, depending on our intervention. So we used to do sort of more laminectomies and instrumented fusion, but have moved away from that and doing sort of laminoplasties with many plates and screws. Type 1 is generally treated with a transdural approach, and type 3 with an MIS clipping of the fistula. So our results overall, about 82% resolved or improved their overall symptoms, and there was a resolution of the SLEC, which is a spinal longitudinal epidural collection, and only 2 patients experienced transient neurological deficits. So I hope this does work. So just a video showing the repair of a type 1 leak. So transdural, open up the dorsal dura, take down the dentate ligaments, take down the arachnoid, can mobilize the spinal cord to the side gently, find the ventral leak, burr down any osteophyte, put some fat there if you need to, repair the ventral dura, sew up the dorsal dura, and then plate the bone back with small plates and screws. So in the correct patients that are thoroughly worked up, surgery is an option which has good results. Thank you very much.
Dr. Long presenting on elevated preoperative A1Cs and associated with perioperative glucose dysregulation in spine surgery patients.
Okay, hello everyone. As we know, there's a link between impaired perioperative glucose control with surgical site infections and all-cause complications in spine surgery patients. Despite this, A1C levels are not routinely checked at our institution, and so the purpose of the study was to evaluate the proportion of patients with undiagnosed diabetes and assess the relationship between A1C and perioperative hyperglycemia. This was a prospective study looking at patients from June 2022 to May 2024 with the pre-op A1C level. Ultimately, we found a 10.5% prevalence of abnormal pre-op hemoglobin A1C levels in patients without a prior diagnosis of prediabetes or diabetes. Higher hemoglobin A1C levels are associated with hyperglycemia, and there's a moderate correlation between the two, with HbA1c explaining 32% of glucose variance. So therefore, we recommend that A1C levels should be measured routinely for patients undergoing elective spine surgery, and that post-op glucose control could be a target of intervention to reduce post-operative complications. Thank you.
Thanks. And our last talk for now would be Dr. Kajuf on the association between rod and fusion mass fractures in adult spinal deformity, retrospective cohort study.
So generally when we see fractured rods, we often think of a pseudoarthrosis, but when we reviewed, we saw that wasn't always the case. And so the purpose of this project was to determine if a fracture through the fusion mass itself was an identifiable cause or association with fractured rods. And so we reviewed many deformity cases to identify cases of fractured rods, and then we reviewed their imaging and CT scans to identify whether they had a fusion mass fracture versus a pseudoarthrosis. And you can see some of the differences we identified between these two in this chart. Notably, in the fusion mass group, we saw around 86% of these cases had a disc height of greater than 10 millimeters at the fracture site, which was starkly different than the pseudoarthrosis group. We also saw 100% of these cases did not have an inner body cage at that level. And we also saw that generally there was a lower mean HU measured with the fusion mass group in comparison to the pseudoarthrosis group. And so really the two main takeaways from this project is one, fusion mass fractures were a distinct entity from pseudoarthrosis. And the patients who typically had fusion mass fracture classically had a phenotype of low bone mineral density and a large disc without an inner body cage, which suggests there may be anterior motion occurring despite the solid posterior fusion. And thus considering anterior support or multi-rod constructs may help prevent this. Thank you.
Thanks for all our speakers, great presentations, and thanks for staying on time.
Thanks. Great morning session. Lunch is outside, and we'll reconvene at 1 p.m.
Perhaps we'll gradually get seated so we can get started, just to keep on time. And this is going to be the afternoon session highlighting research trainee presentations. The first speaker is Dr. Carlo Pedro, who's originally from the Philippines, clinical research fellow, completing his PhD through the surgeon scientist training program, and he's going to inform us on how to make sense of data. Thank you.
Good afternoon, and thank you very much for this invitation to talk today. I'm Carlo, and I'm a PhD student in Institute of Medical Science, and I work in Dr. Fenning's laboratory, and I'm also a clinical fellow. So today my topic is really trying to describe what we're doing in the clinical laboratory and teaching you some ways, some innovative ways to analyze clinical data and make make sense of what we have. At the center of our clinical work is really using traditional as well as machine learning techniques to analyze clinical data. And the real motivation of this is really phenotyping and addressing the clinical heterogeneity of our patient population. We've been working in multidisciplinary fashion with some of the experts in this field, mostly our methodologists and statisticians. And as an introduction, I thought of sharing this very interesting fact. Dr. Wang talked about evolution of MIS this morning, but there's also evolution in surgical research. Believe it or not, in 1996, Dr. Horton, who's still the editor-in-chief in Lancet nowadays, called surgical research as a comic opera in 1996. Mostly because researchers during this time were based on case series. There's really no RCTs during this time, and quite interestingly, they don't know what endpoint to select. And it's very interesting that we have editorials nowadays pivoting on this issue, and they've been calling now the surgical research as epic symphony from comic opera, because we have big data to support there's big data explosion and the use of machine learning techniques. So I don't know if you know this, but spine surgery is one of the fields that really creates large, big data, and it is estimated that a surgeon in 35 years practice would be able to generate around 40,000 data points. And we've seen this in increasing number of big data spine registries. And here in this graph, you can see that over years, we have seen large number of big data spine surgery. And one of these is here in Canada, the Canadian Spine Outcome Research CSOR Network Group. So this big data requires us to have more powerful analytical techniques, and one of these is machine learning algorithms. There's such a limit that we can analyze, and so I think these techniques sort of serve as a complementary methods in analyzing clinical data. So we've been analyzing a cohort of DCM patients. This is a combination of 3 trials that's led by Dr. Fennings over the years. And what this enabled us to is accumulate a large number of DCM patients. Right now, we have a total of 1,047 patients. These are uniformly diagnosed with DCM. And I don't need to go into details, but you know the importance of DCM. And one of the inherent characteristics is the inherent heterogeneity in the clinical presentation as well as outcomes. So it's very important to make sense of this large amount of data that we have and characterizing more phenotypically and giving us a more granular idea. So just to give you a sense, this is the data that we have when I started my PhD work. It's really a vast amount of data, information. And so really the question is, how do we make sense of this? There's really large amount of data, and with the heterogeneity and their outcomes, how can we use this data in order to give us a better idea of disease classification? So just by looking at symptoms, for example, this is not a comprehensive list, but this is how DCM patients present. And you can see that it's very heterogeneous, very protean, and even the initial symptoms, you see that neck pain is a very important characteristic, but this is not reflected in the MGOA. And so we thought of using some machine learning techniques. K-means is an example of analyzing one-dimensional data, and you can see from this figure how a seemingly unstructured random data points can actually present with with the use of k-means clustering, we're able to identify unique subgroups of patients. So in k-means clustering, this is just basically a technique, a basic 3 steps. First is to assign data point, create a centroid, and reorganize the clusters until you form 3 subgroups of patients. Quite inherent in the limitation is that every time you run this algorithm, you get different solutions each time. So we use an innovative solution to get rid of this arbitrariness. And one of the solutions that we use is to complement this with a latent profile analysis. So here you can see that there's, the k-means gives us clusters of patients, but the LPA also gives us rigorous assessment of which number is the best or optimal number of clusters. And here you can see that 4 group is indeed the optimal number of clusters. So we are able to, for the first time, identify a pain phenotype, which has never been described in the DCM literature. Another way is through consensus clustering. So one way to circumvent the arbitrariness is doing consensus clustering. It's also a machine learning technique. Basically, it does multiple runs of k-means, and it ends up with a consensus solution. It's more commonly applied in genetic research, but for the first time, we're able to use this in clinical research. We applied this actually in the data from a sub-study group from the CSORN using patients with degenerative lumbar spondylolisthesis. And here we have identified 4 clusters of patients with DLS. So that is one-dimensional data, but oftentimes we also have 2-dimensional data where, as you can see from these blocks, what we have done is just cluster the columns, but we know that each row also represent unique patient groups. So to give this in a more practical way, I created a table here. As you can see, University of Toronto Spine Program has been international. We have a lot of fellows. If we want to do a study, say, cluster research interests, we can cluster through columns, but we know also that we have neurosurgery fellows and orthopedics fellows. So one other clustering technique is called bi-clustering technique, where we're able to cluster not only columns, but also the rows. So I will not go through the mathematics or statistics of this, but it basically reorganizes the matrix until you form 3 groups, as you can see from this picture. So the way we apply this in our data is use a concept of frailty, which has been well described in the literature in spine. So this can be done in R. The bi-clustering techniques give you these beautiful visualizations, and here you can see that we are able to parse out 4 clusters using clustering the columns and rows. So you can make sense of this data, give labels to your clusters based on the features that you have deemed considered important. Lastly is, I think the more powerful technique is if you have a data that you collect over time, and so you have longitudinal data that gives you a 3-dimensional data. There are tri-clustering techniques, but I think the most simple way to analyze longitudinal data is through trajectory analysis. We have described this previously using spinal cord injury patients, but using multidimensional sort of features, we cannot use the traditional GBTM or group-based trajectory modeling. What we need are more advanced techniques, and this is a study in process, and we have explored the use of group-based multi-trajectory modeling. There's also latent class mixture modeling and Bayesian cluster consensus clustering. So these are still in the process of analysis, but we're finding that group-based trajectory modeling, which we have seen previously published, is actually the most rigid, unflexible methodology, and there are more flexible methods such as Bayesian consensus clustering. So in summary, this talk just basically summarizes that there are many techniques that we can use depending on the dimensionality of your data. You can use k-means for 1 dimension, by clustering for 2 dimension, or trajectory analysis for 3-dimensional. I think one of the field of spine that has reaped the benefits of this analysis is in deformity surgery. Dr. Wang is one of the authors in this paper, and the third one, where they use k-means clustering, for example, to determine sort of groups of deformity patients, because in deformity, we don't only deal with demographics, but we have a lot of measurements. And so this year by year, we see published papers using clustering techniques to really make sense of the data that we have. For example, here in adult deformity, they describe 3 groups of coronal, hyperthoracic kyphosis, and severely sagittal imbalance. They did this also for cervical deformity, and as I mentioned, they've also performed this in patients with degenerative lumbar spondylolisthesis. So in summary, there are different techniques that can help us make sense of our data depending on the dimensionality. We can work in collaboration with you to apply these techniques, but I think the important thing is we're able to identify sort of unique phenotypes of DCM patients with these techniques, and future works would benefit from externally validating this with other data sets, discovering endotypes by incorporating genetic data, and of course, looking forward to the future where we can integrate this in actual clinical practice using computer predictor models. Thank you very much.
Questions from the audience? So thanks so much, Carlo. I guess the one question I had, and as we have new techniques and methodologies to look at our patients and the development of different cluster groups, you talked about external validation and other data sets, but what about, I guess, the validation to what may be relevant and meaningful, I guess, from a clinical care perspective? And so, for example, somebody with myelopathy who has no neck pain and somebody else who's got a lot of neck pain, I may treat differently. And so could you maybe highlight a little bit about maybe some next steps or what might need it to be taken in context of interpretation for its clinical applicability?
That's very interesting. Actually, in our paper where we published these clustering techniques, we're able to regress, meaning find an association, for example, in terms of surgical approach. And we've seen that pain phenotypes actually get benefit from anterior approach surgery more than posterior surgery. So these techniques, I think these are the next steps, sort of identifying the association with the best surgical therapy and sort of rehab therapy. So, I mean, those are the next steps for this analysis. So.
And any cautions that you would give to us as we sort of embark in this sort of new phase of techniques to sort of automate our lives and our clinical care practices? Or
well, the idea is really to help us do our clinical decision making easier by integrating multiple. We cannot do this just by just without using machine learning techniques. What this has actually what made this clearly is with doing these things, I mean, it has helped us sort of integrate multidimensional, which has never been described in DCM. For example, the pain phenotype, and we know for now that neck pain is very important quality, which has never been described in DCM. So,
okay, thank you, Dr. Lewis.
We have a saying you should stop asking questions when you got the answer you want to hear. And so, how do you know when you should stop asking questions with your thing? Because you cluster till you got what you want and then stop, or is it possible that if you keep going, you're going to have a different answer?
Yeah, no. So I think these are all sort of first steps, exploratory analysis. For example, in the DLS study that we performed, these are sort of this provided us the groups, and now the next step is really looking at if these groups are certainly different in terms of surgical approach. So for sure, you cannot redo this with another data set and you'll get another sort of clusters. The idea is use this as your starting point and move forward using all this data that you have analyzed. Because for sure, it could be easily be a phishing, like data phishing, like you're phishing significance or phishing groups that you wanted. But the ultimate goal is to really see that these groups are different and they have different outcomes, and you can use this to sort of use in your clinical decision making. So, thank you.
Okay, thank you. So our next speaker is going to be Dr. Declan Ross, who's a orthopedic resident in the surgeon scientist training program, and he'll be speaking on the natural progression of musculoskeletal image-based biomarkers in metastatic prostate cancer. Thank you, Declan.
Awesome. Thanks, Dr. Yi. So as Dr. Yi mentioned, we're going to talk about natural progression of the musculoskeletal imaging-based biomarkers in prostate cancer. I'll explain why prostate cancer in a minute. First, about osteosarcopenia. It combines osteoporosis and sarcopenia into one entity. They're commonly studied in isolation, but they're also very common in older populations. In fact, in the cohort over 65 years old, about 21% of the patient population. It's associated with increased risks of admission, falls, and fractures, as well as mortality. So it's a very important issue for older patients. Prostate cancer itself affects 1 in 8 men. 1 in 30 men will die from prostate cancer. And the hallmark of their treatment is really androgen deprivation therapy. So really shutting off that testosterone pathway, which we know is very important for bone and muscle health in men. Also, the cancer itself is incredibly commonly metastatic to bone. So a little more about prostate cancer and why looking at the progression of biomarkers in this patient is helpful. They live a long time in general. So from diagnosis, most of the patients are non-metastatic at diagnosis. Will live 91% of them live 5 years. That number is lower once they become metastatic. About 40% will live 5 years once they're metastatic. And these patients get a lot of cancer surveillance imaging, at least one time point per year, some of them as frequent as 6 weeks, depending on the treatment profile they're getting. And again, osteoporosis and sarcopenia incredibly common in this cohort. So the knowledge gap we're trying to address is that there's little understanding of osteosarcopenia, especially in this group. There's little standardization of a 3D sarcopenia assessment, which I'll touch on a little bit in a second. And without really understanding what osteosarcopenia is, how it behaves over time, how can we prevent it and intervene to help prevent the severe adverse effects of it. So a little bit about how we assess bone and muscle health in general, as well as how we're doing it in this project. In general, assessing osteosarcopenia, for osteoporosis, it's clinical standards, DEXA scans. There are pros and cons to DEXAs, but CT is also highly effective, is probably better, and gives you a better understanding of what's actually going on. Sarcopenia, you can use DEXA. It's very rarely used in Canada to actually get a lean body mass in these patients. But the clinical assessments are generally how it's done for sarcopenia. So your timed up and go, your walk tests, your sit to stand. And these are really labor intensive in clinic, so it can take a lot of time, a lot of human resources to actually get this information. So we're not commonly getting this information in patients. So using CT itself to assess osteosarcopenia, like I mentioned with bone, you can assess the metastatic disease of these patients. It's probably more accurate to diagnose osteoporosis. There's a couple papers to suggest that recently. And then for sarcopenia, there's a few different assessment techniques, such as psoas muscle index and skeletal muscle index, which are all tied to the patient's height. So for our study, we did a retrospective study of metastatic prostate cancer patients that were considered for systemic cancer treatments, in general chemotherapy, between 2009 and 2021 at Sunnybrook. We identified 1,100 patients, and we captured their clinical data from the electronic health record. We also captured 3D imaging biomarkers using an image analysis pipeline. A little busy slide, but this is just saying the 1,100 patients we had. We ended up with 865 patients with 5,061 CT scans. 181 patients had no imaging, and following running of our image analysis pipeline and review, we removed about 54 more patients, which brought us down to that 865 patients. Our actual criteria for this study, we needed patients to have multiple time points for assessment of bone and muscle health. Common reasons to not have 2 time points for bone health was metastatic involvement. And the second inclusion criteria was that we needed height available to actually do a sarcopenia assessment. So if height's not available, we can't quantify whether somebody is sarcopenic or not. After applying this, we had 437 patients with 3,600 CT scans. A little bit about the image analysis pipeline. It essentially can take a CT that involves the lumbar spine. It detects and segments the vertebral bodies, and the total segmenter is a image analysis and segmentation tool that detects and segments the iliopsoas, and then we crop it to a region of interest. Specifically, the L2, L3 is the upper border, and the L4, L5 disc space is the lower border. So what we're actually measuring, like I mentioned, the psoas muscle is cropped in that region. This is to do a consistent area of measure over time. So a patient, independent of their positioning, will have a consistent measure scan over scan. And then for the bone in L1 to L5, we're eroding the cortical shell to really give us an understanding of that trabecular bone density in the vertebral bodies. The actual biomarkers we're capturing is the bone mineral density in Hounsfield units of L1 to L5, as well as the psoas muscle volume in centimeters cubed, and psoas muscle density in that region of interest, again with Hounsfield units. So how we defined osteosarcopenia is a bit different than some of the other studies. Osteoporosis is easier because there's a standard definition that's been proposed from a couple of systematic reviews that suggests 135 Hounsfield units as a density threshold. Sarcopenia, we took the 2D psoas muscle index, and Jessica, who presented earlier, she was able to establish that the 30, from a 2D to 3D threshold, a 30 on a volumetric psoas muscle index, so taking the 2D psoas muscle index, applying it in 3D, and that was the threshold that we came up with for sarcopenia. In terms of the demographics of our study, we broke it down into 4 groups: no osteoporosis or sarcopenia, whether they're osteoporotic, sarcopenic, or if they're osteosarcopenic at their first time point. This is a busy slide on the demographics, but there's really only 3 important things that were different between the 2 groups, or different 4 groups. Age at diagnosis, the osteosarcopenic patients were older at their time of diagnosis. Their age at mortality was higher. And if you look at the Gleason risk group, these patients had lower risk cancer in general. A little bit about bone density by classification. Applying that 135 Hounsfield unit threshold, we see that every group is having a massive drop in their bone density over time, anywhere from 15 to 19%. The osteosarcopenic group is a lower drop. That is also probably because they're further along in their disease, they have less to lose. But on a year-by-year basis, they're losing 2 to 3% of their bone density per year, and this goes well above the expected norms in this age cohort of about 1%. In terms of muscle density, which is a measure of sarcopenia, these patients again are losing almost 4% of their muscle density a year in that region of interest, significant across all the different groups, with no group really losing more or less. The osteoporotic group was a little bit lower at negative 3.2% per year, but if you look at how much they're losing over 4 to 5 years, it's 15 to 20% of their total psoas muscle density, suggesting a significant amount of fatty infiltration in these patients. In terms of their corrected psoas volume, so this is standardizing the measures to be consistent with the actual psoas volume. These patients are losing about 4% of their psoas volume a year, again, vastly higher than the 1% you would expect. And if you look at their actual total change, these individuals over 5-6 years are losing anywhere from 15 to 25% of their total muscle volume. So if you have a patient who's 65 years old with prostate cancer, and then you're going to do a surgery on them, it's like you almost have to think of what they're going to be like in 3-4 years from now rather than what they are today, because they're going to lose a quarter of their bone and muscle by that time. In terms of looking at a sarcopenia assessment with the volumetric psoas muscle index at 30, almost everybody is, again, losing a very significant amount of their bone, like psoas volume, not bone volume, but psoas volume. And almost everybody at the end of this is trending towards, or if not already, sarcopenic. So a little ribbon plot on how these patients actually behave throughout the time point. I don't think the table itself explains everything, as the healthy group, or no osteoporosis, no sarcopenia group, is about 41% at the first time point. 4 or 5 years later, that group is less than 9% of the patient population. And if you look at the osteosarcopenia group, it goes from 17 to 46%. But it doesn't really tell the whole story, because the patients that are sarcopenic at baseline are not the same patients that are sarcopenic at the end. And they're all kind of trending towards that osteosarcopenic cohort at the end of their time point. So in summary, the metastatic prostate cancer patients are having a very significant decrease in their bone and muscle health over time, anywhere from 15 to 20% of their bone and muscle density and volume over that 4 or 5 years. So we have to really pay attention in this patient population because their osteosarcopenia prevalence is increasing. It's almost tripling, actually. The other benefit of this is that CT scans really provide that dual utility. It enables an opportunistic musculoskeletal assessment. It really just leverages these already captured cancer surveillance screens so that we can understand what is happening with the bone and muscle of these patients without having to do further invasive testing. Thanks.
Questions? And Dr. Akins?
Yeah, a great talk. Did you also consider the chemo treatment the people
the patients received because some chemo treatment have effects on bone. Did you consider that as well in your analysis?
So we haven't yet. We're going to. We do have all the treatment data available for these patients from when they're at Sunnybrook. We're trying to understand what happened to the patients before Sunnybrook. So a lot of these patients are referred to Sunnybrook as a quaternary center. So they've gotten treatments before they show up. So we're trying to standardize what happened to them before they showed up and then understand what happened with the different chemo treatments that they all received. But we do have that data and we're going to do that analysis, yeah.
Great talk. The pathophysiological mechanism for the sarcopenia, would that be the testosterone primarily? Are there any other factors that contribute to it?
That's what we think is the primary driver. It's a little bit outside the scope of what we're doing, but that's the proposed primary mechanism of the loss of bone and muscle health. I think there's a lot of confounding if you have a cancer population where you have a lot of people that are potentially more unwell than people that are in the same age group. So I think there's going to be a cancer itself as well as a activity level itself mechanism that's going to be playing a role as well. So I think it's multifactorial, but I definitely think that the treatments are a large part of it.
And given that, is there any role for prevention?
I think so. I definitely think that we should be able to get ahead of this. We should be able to give patients calcium, vitamin D, and potentially bisphosphonates earlier in their prostate cancer treatments, probably if they're receiving androgen deprivation therapy, as well as potentially, there is some evidence to suggest that physiotherapy and like resistance training helps prevent sarcopenia. There's not as much as I've seen in the cancer cohort, probably because their survival times are less than your average population, but I definitely think that's something that can be done early on in somebody's diagnosis to prevent a lot of this.
Okay, terrific. Awesome. Thanks so much.
Thank you.
So the next presentation was supposed to have been given by Dr. Armand Malhotra. However, there's been a sort of a last-minute family emergency, so not able to present today, but Dr. Hussein Shakil will provide a presentation in this time, focusing on opportunities related to AI and spinal trauma related to cervical region. Thank you.
Thanks very much. My name is Hussein. I'm a fourth-year resident here at the University of Toronto, and it's a pleasure to share here the development and validation of a CT-based AI tool that we've put together for triage and screening of cervical spine trauma. At the outset, I want to thank my co-investigator Zixuan Hu, who is a PhD in engineering, who helped with the design and development of the tool, as well as my supervisor, Dr. Chris Witu. So cervical spine trauma in Ontario is a growing problem, and annual incidence is about 65 cases per 100,000. When we looked at the epidemiology of this patient population, what we found was that in a previous study by Dr. Wilson was that there's really a growing population of patients due to an aging population of elderly folks who are sustaining hyperextension-related falls trauma. And really, there's a wide spectrum of patient phenotypes that can constitute a cervical spine trauma. So anything from an injury to the non-structural part of the spine, which can be treated conservatively, all the way to a life-altering condition such as a high cervical spinal cord injury. And really, subspecialty expertise is required for triage and assessment of which patients need transfer to an urgent center and which patients can be managed as an outpatient fashion. And so when a prior study has looked at the capacity of spine surgery within Ontario. This was done by Dr. Rampersad, and really there's only a fraction of Ontario hospitals that have the capacity to perform the procedures that are needed for this patient population. And a lot of these centers are really concentrated around urban centers and academic hospitals. And when we compare this to similar geographic regions within the United States, we see a far smaller fraction of Canadian hospitals have the capacity to do decompressions and instrumented fusions. So what this results to is an incredible triage challenge for patients that need care, and often the current state of practice is as shown in this picture, where spine surgeons with the expertise to make these decisions are having to take phone calls directly from primary care providers who have questions for their patients. And so what we looked at, when we looked more closely within the trauma centers across North America about the quality of triage that's being done today, we found that there's a significant amount of over-triage of these patients, whereby as much as 1 in 5 patients with a spine fracture that is transferred to a major trauma center is actually discharged within 48 hours without needing any kind of treatment. And this falls within the realm of what is described as over-triage, and some of this work, which was put together by Vince, one of our senior residents, is currently under review. And so what we wanted to do was see how we can make use of enabling technology such as AI, and this is some of our previous experience in the realm of traumatic brain injury, and apply it to the cervical spine. So in essence, what we wanted to do was develop and validate a deep learning screening tool on the basis of images to assess whether or not a patient would need surgery for their acute trauma to their spinal column or spinal cord. So we employed a single center study at St. Michael's Hospital by linking all the clinical records from the local trauma registry to CT DICOM files that were acquired from the hospital PACS system. And we identified all patients with an injury to any part of their spinal column on the basis of injury codes. And then we labeled patients who ultimately underwent surgery versus not on the basis of procedure codes, as well as operative report chart review. And then we tested 7 different deep learning AI models capable of video classification to identify whether or not the pattern of injury was indicative of something requiring surgery. And we selected the best model and parameters on the basis of sensitivity, as we were ultimately trying to develop a screening tool for these patients. So this is an overview of our development pipeline. We linked about 4,000 clinical records to CT scans, and then we identified a cohort that was treated between 2005 to 2023. We then allocated patients treated between 2021 to 2023 to a temporally distinct holdout validation set, and then the remainder of the scans and records were used to develop and train the model. So we then used, again, 7 different architectures for testing, and then selected the best model on the basis of performance based on sensitivity and accuracy. And then we looked at the different cases to see what the performance metrics were on the holdout test set, and then used the activation maps to look at whether the model was actually doing what we anticipated it to do. So this is a summary of our cohort. Again, about 3,000 cases, 400 of which were allocated to a temporally distinct holdout test set, the remainder of which for training. Within the cohort, about 12.5%, so about 300 cases were ultimately treated with surgery. Most common injuries were at the C6, C7 level. About 10% of cases had traumatic malalignment. And this is the results in terms of performance. So again, these results here represent on the holdout test set, so completely separate from training, and we had quite remarkable performance in terms of sensitivity and accuracy. So sensitivity about 91.5%, AUC 0.933. If you look at the actual breakdown of cases, the vast majority were true positives true negatives, and there were also some true positives. Where the model faltered were on the cases of false positives, which we were actually okay with because we were trying to develop a screening tool. And we looked a bit closer at these cases. These were actually fractures that you could have considered operative management for, but due to patient factors as well as surgeon preference, they opted for conservative management. So this is a bit of a proof of concept. So these were some of the true positives that we elicited from our model. And these are activation maps that shows the areas of the CT scan that the model was paying the most attention to predict likelihood of surgery. And you can see that our Assist-SCI model was capable of identifying both unilateral fractures, multi-level fractures, dislocation type injuries, as well as rare types of injuries such as ankylosing spondylitis type hyperextension injuries. So when we looked closer at the misclassified cases to see where there were areas where further training was needed and sort of weak points of the model, we found that patients who had pre-existing severe spondylosis, fracture mimics such as congenital non-unions, or really anything where there was a strong hyperintensity extending within the canal was an area where the model would be very sensitive and overcall this as a false positive. So in summary, there's still some work to be done, and we look forward to doing a retrospective external validation at an affiliated community site. But what I presented here today is what I hope to convince you that is a sensitive and accurate tool that is really needed for surgeons across Canada. And I look forward to discussing this tool further. Thanks very much.
work. I guess one of the caveats here, though, is that one of the most common serious missed injuries that I see relates to central cord injuries where there's not a fracture. And so I guess the cautionary note here would be that the absence of a fracture does not mean that there's serious cervical injury. And so how do you see kind of working around that? Because that's going to be the big caveat here.
Yeah, and it's a really good point, and it always comes up when I present this work. And I think the important point here is that this is really a decision support tool. Nothing will replace the decision making and the clinical exam from a primary care provider. So if you have a patient there that presents with a clinical syndrome indicative of central cord syndrome, I think the pretest probability that they'll need transfer is so high that regardless of what this tool says, I think they should be transferred. But where this really comes to play is I think it empowers the primary care providers who have maybe an intact patient who had maybe a minor fall and just a TP fracture to maybe say their likelihood of needing surgery is so low that maybe they can call the surgeon in the morning, or it helps empower some of the people that don't have the expertise that maybe some people in this room have.
Yeah, I think one of the points here that maybe would enhance this would be to kind of almost have kind of a two-step algorithm, one of which involves certain critical features in the imaging as you've done, but also extracting certain key features off of the history in the physical exam that are actually kind of true red flags, right?
Yeah.
And I think that maybe would be something to further kind of enhance this kind of an approach, because my concern always is that you have this and then it lulls people into a false sense of security. So
Yeah.
it's an adjunctive tool, but you still need the history
For sure,
in the physical exam.
Yeah, definitely. Nothing will replace a good physical exam.
I guess Dr. Hardesty and Dr. LaRouche.
Yeah, interesting stuff. So, yeah, you already spoke a little bit about how, like, the plans for multi-center. So I'm curious about how dependent do you think it is on the nature, the type of imaging that you have, and how is that going to change at different centers, and how will this affect generalizability? And I guess related to that, like, did you do any preconditioning with larger data sets that might help with generalization?
Yeah, it's a good point. Right now, it's been trained on sort of a thin-cut CT protocol that we have at St. Mike's, and there was a fair number of QAing to make sure that the field of view, and a lot of this work was done by myself to make sure that the field of view was captured, but sometimes you might not have, like, you know, a neuroradiologist in-house at a peripheral hospital, and maybe the imaging protocols are quite different, and I think that might be a larger discussion to have across the province about how do we standardize these things, maybe outside of this tool, but also just to make sure that we get good imaging for these patients for when they are transferred and ultimately need surgical support. Because from experience, oftentimes we're repeating imaging in-house, and maybe that's not the best use of resources. And I think probably we need to look towards getting more standardized protocols for imaging as well.
Kudos on a very cool project. Amazing to see the results you have. One of the things that made me think of was I was listening to cool podcasts, because I think that all of us who take in critical know that you cannot trust the emerge doctor on the other end. They'll tell you whatever you want to hear to send the patient to you, and they come to you and it's not there. So what I was thinking, it'd be really interesting to merge this. I'll find the podcast for you, but there's a chatbot triage tool being used in the US for some of the emerge centers, which basically prompts the questions and walks you through the ability to get exactly the data you want for the clinical assessment that Dr. Fehlings was talking about. And if you could marry that to the imaging analysis that you have, I think you would have one heck of a tool.
Yeah.
So that'd be a really interesting, that could be your own next company if you're an entrepreneur.
Thanks for I'll come over and figure out what that is. But I agree. I think multimodal sort of linking of clinical assessments and imaging is the next step for sure.
Yeah, so it's really terrific. I think this is obviously an emerging area, and I think the pearls I think you provided as the tool gets further developed and refined, and even I guess the regulatory aspects of what we do. I mean, part of this is medical legal as well, and the doctor needs to put a name to whatever clearing somebody in terms of their care, and so all of that needs to be sort of considered. And but this work is obviously clearly important and is aimed obviously to help improve efficiencies within our system. So thank you. Okay, so the next presentation will be given by Dr. Lauren Hatchin. She's completed her PhD as part of the Surgeon Scientist Training Program here at the University of Toronto, Division of Neurosurgery, and will provide an update to us on the multimodal approach and tracking endogenous stem cells in the adult spinal cord.
Thanks very much, Dr. Yi, and thank you to the organizing committee for the opportunity to present. And Dr. Wang, thank you for joining us. It really is an honor to have you here. Very much look forward to working with you here in Miami. So today I'll be talking about some of the work we've been doing, as Dr. Yi mentioned, throughout the PhD under the supervision of Dr. Tatter and Dr. Failings in the lab here. So we all know spinal cord injury is a devastating condition, and we've heard a lot over many years, of various regenerative approaches. And up until this point, while there have been promise in the field, there's still a lack of validated regenerative approaches. And we hear a lot about transplanting exogenous stem cells, even now the whole field of functional stimulation. All of these are exogenously being applied to the spinal cord. One of the questions across the board, though, is there are endogenous cells that remain, and all of these therapies are at some point going to be modulating those cells. So the question fundamentally at the root of all these therapies is what is happening to the endogenous cells that are there with our therapies, and how could we potentially harness this regenerative potential? So we know in the spinal cord, you can see the cartoon on the left and on the right is a cross-section of a transgenic mouse. In the center of the spinal cord, in the central canal, there's a population of ependymal cells. And these cells have been known actually in salamanders and amphibians. They're the reason that they can regenerate their spinal cord. When you go higher up in the phylogeny in humans, we still have these cells, but something's been lost in terms of their activation state and how we can harness them to the same degree in other animals. So as I mentioned here, in an uninjured setting, these cells are normally quiescent, and then after injury, there's this phenomenon where they become activated. They revert to a stem cell state, and it's very transient. It's generally within the first couple of days. They gain this stem cell potential. They are important for neuronal regeneration. They secrete trophic factors, but again, it's limited. So as I said, it's transient and insufficient for adequate regeneration, but this pool of cells is present. One of the main questions is what is, first of all, this acute injury mechanism that activates them, and then naturally, how can we use that mechanism to harness their regenerative potential in the subacute and chronic phases of injury? So a couple of questions that were posed throughout the work, and I'll go throughout the talk through each of them. First question is, which injury cue activates these cells? So we know spinal cord injury has a host of various deleterious mechanisms that lead to neuronal and glial cell loss. Glutamate excitotoxicity is one of the hallmarks of this early acute phase. And what we discovered early on was that this same toxic mediator that kills off neurons and glia paradoxically activates these endogenous cells. And this was all in vitro. So you can see on the bottom on the right, glutamate, many more live cells in green when these cells are cultured with glutamate, but fewer in the control setting. So we basically defined that, we call this the paradoxical glutamate response. This high levels of glutamate drive these cells. The second question is, what's the underlying mechanism of this? So this is work we've done more recently, basically, again in vitro, showing that off the glutamate receptors, the AMPA receptor is largely what's driving this mechanism. So through calcium signaling and a whole bunch of other downstream pathways, which I won't go through just for the sake of time, but essentially we found that calcium influx through these AMPA receptors from glutamate signaling drives these cells in vitro. So again, this is all an in vitro mechanism, which is artificial. The main question is, how can this translate in vivo in a spinal cord injury setting? So this is work which recently provisionally got accepted in Nature Neuroscience, and thank the whole team for everyone's work. And I'll talk a little bit more about this throughout the slide. But essentially, we wanted to prove this mechanism in vivo. So we collaborated with Karolinska, Dr. Jonas Friesen's lab, and Wei Liu at NIH, and essentially generated this new transgenic mouse line where basically on tamoxifen treatment, we're able to knock out AMPA receptors. So we can now prove whether this mechanism holds true in vivo. This was done in collaboration with the Valiente lab here at Krembil. And essentially what you can see on the top is that central canal, and in green is the one cell that we basically patch clamp and re-record. So we basically recorded these cells in normal and knockout mice, and what we find in the bottom graph right here is that in the normal animals, when we treat with glutamate, we get a large increase in the AMPA signal, and with our knockout, we lose that. So essentially, this is validating our tool. We have a tool that effectively knocks out AMPA receptors, so now we can see what happens after spinal cord injury. So this is the model. It's a clip contusion model, which mimics human spinal cord injury. What we can see here is in a normal setting, these ependymal cells labeled in red migrate out from the cord. And in our knockout mice, this is completely abolished. So we can see here, this average distance of migration and fraction of migratory ependymal cells has now been abolished in this knockout mice, essentially showing that AMPA receptors do indeed lead to the migratory capacity of these cells after injury. So this is all great from a mechanistic standpoint. The major question is how can we now use this to start to look at various therapies and responses to therapies in the setting of spinal cord injury. So this is essentially the paradigm. What we've known so far is that after injury there's an acute spike of glutamate, and this is paralleled by an acute proliferation of these cells in the first couple of days to hours of injury, and this dies down over time. We know that AMPA receptors play a large role in the activation acutely. So the question is, can we now use a drug that potentially modulates these receptors? There's this class of positive allosteric modulators. They essentially promote the AMPA downstream signaling. These drugs have previously been used in other settings, neurodegenerative conditions and stroke models, and now more recently, actually, a couple groups out of Florida are looking at using it for breathing and spinal cord injury and improving respiration. So the question here became, could we now use this AMPA-kind drug in subacute or chronic spinal cord injury to get another bout of regeneration? So we looked at here, this is the paradigm at the top. After 1 week of injury, we treated with this AMPA-kind treatment. And as we know, drugs are messy, so they act on various cell types. So we use various AI-based, machine learning-based transcriptomic analyses to kind of tease out a lot of the mechanisms that were at play with the drug. So basically, we had the 3 groups here: no injury, injury, and drug treatment. And this was our, we did single nucleus RNA sequencing on cords treated with this drug. And so these were the major populations of cells in the spinal cord. So we first use this machine learning-based cell prioritization. So basically, there's various cells in the spinal cord, and what this algorithm does out of Cortine's lab in Europe, basically prioritize cell types that are most perturbed by your treatment. So we're able to tease out a little bit more and focus in on the analysis. So what we found actually was that these ependymal cells were the top perturbed cell type, followed by astrocytes. When we looked at what these cells were doing, we could see that after 6 weeks of treatment, there was an increase in migration of these cells. So the fraction of cells that migrated was higher with this drug. So chronic AMPA modulation was driving these cells to migrate out. And when we knocked out our AMPA receptors, so we used our transgenic mice, that was lost. From both an academic standpoint and a commercialization standpoint, the question becomes, what actually is the mechanism of this? So what's at play when we see this effect? So when we looked at differential gene expression, we found most genes that were altered were related to cell migration. And when we looked at global gene networks and changes, we found that AMPA-kind treatment reversed the maturation state of these stem cells. So it kept them in an immature state for longer, which is essentially what we would want, because we want to modulate these stem cells. We then went on to look at interactions between ependymal cells and other cells. So this is another AI-based computational tool, essentially looking at, basically it predicts cell-cell communication. And what we had found, interestingly, was that ependymal cells treated with AMPA, or animals treated with AMPA-kind, were having an increase in connexin signaling. And we basically corroborated this on immunohistochemistry, so more connexin or gap junctions were increased with drug treatment. Again, this was blocked with knocking out the AMPA receptor. Now, the role of connexins has been a critical one in stem cells in development. So they basically couple cells with calcium signaling. And previously in our in vitro work, we saw that calcium through AMPA receptors were critical. So what this drug seems to be doing is allowing these cells to revert to their stem cell-like state for a longer period of time, allowing us to potentially modulate them for a longer period, basically couple them as we often see in development of stem cells. We then went on to look at astrocyte and ependymal cell connections. There's a lot of interest in glial cell interactions, and what we had found essentially was that, just turn your attention here, there was increased contacts between ependymal cells and glial cells. And if we look in the literature, what's known in development is that one of the fundamental steps of basically generation of the spinal cord and the brain is glial bridging. So astrocytes create bridges for neurons and neuroblasts to migrate. So one of the questions this work raises, is it possible that we can now recapitulate that developmental stage now in a subacute or chronic injury? We then went on to look at functional recovery. So this is work that we did looking at MEP recordings, and essentially just, it's a bit of a busy slide, but just to summarize on here, After spinal cord injury, there's a decrease in corticospinal tract excitability, and what this drug was doing was partially reversing these parameters. So stimulation intensity needed to reach half maximal amplitude was increased after spinal cord injury, and this drug was able to partially reverse that. This did translate to improved locomotor recovery on several metrics. So BMS, this is open locomotor field, and these are various metrics on catwalk as well. So there was improved functional recovery. This was also paralyzed by improved neuronal survival. So basically, in terms of conclusions, what this work shows is that essentially we started with a phenomenon that has been described in the literature for a long-standing period, looked at what mechanisms could potentially define this acute mechanism of activation, and then used that to start to develop therapies that could potentially harness the body's endogenous regenerative potential. At the same time, knowing, glutamate is the main excitatory neurotransmitter, when we look at, this whole influx of stimulation paradigms and rehabilitation-based approaches, it really opens the door to question, what do those therapies now have an effect on endogenous stem cells, knowing that glutamate is the main driver. So a lot of interest in looking at how this work will now translate to a lot of these clinical trials. Other major conclusions, really, this shows a multimodal and multi-team-based approach in terms of various modalities to really answer this question, and then, of course, provides mechanistic insights with translational relevance. I'd like to thank, it's probably the most important slide, everyone who was involved, Dr. Feelings, Dr. Tata for your ongoing mentorship and support, everyone in the lab who's helped, Dr. Valiente's lab here at Krembo for their help with the in vitro recordings, Karolinska, NIH, and our other partners there, and all of our funding sources. Thank you very much.
Okay, questions? Congratulations, really, on that large body of work and on your PhD. It's been great to hear the updates over the last several years. I guess with the glutamate, it's also been described and looked at in other areas as well, like cancer, pain perception, and things like that. And you sort of highlighted the early time point following injury that seems to occur. And so any other variables or factors that could be involved as it relates to glutamate pain and perhaps that aspect of traumatic injury?
Yeah, it's interesting. I guess 2 points that you mentioned. It's a really good question. In terms of the oncology world, there's work actually showing that glioblastoma stem cells have a similar response to excitotoxic injury. So I think Michelle Mongi's lab down in Stanford looking at this in terms of how neurotransmitters can modulate cancer stem cells. So there are some parallels with that work, and it could be more of a broad universal mechanism of stem cells and how they interact with neurotransmitters. In terms of the pain as well, it was on one of my slides, but I skipped through it for the sake of time, but these ampakine drugs have actually been looked at in terms of pain, modulating pain. They're not an agonist, so it's not actually stimulating, it's more so modulating that response. So there could potentially be an effect on them in terms of a pain post-anesthetic as well. So.
And I guess, this is the sort of holy grail part of things as we think about translation from, scale up to the human sort of scenario. And, I guess any thoughts on that part of it, or obviously the clinical application part of it, and any potential off-target effects of the drug therapy that we need to be aware of or consider?
Yeah, it's true. I think that's why, some of the message from the work is also, animal models obviously don't recapitulate what happens in the human, but looking at these more AI-based transcriptomic kind of studies can help us look a little bit of off-target effects. So there was a slide there looking at what effects it has on neurons. So potentially it was promoting survival of certain subtypes of neurons that are known to be involved in sensory gating. So both from a pain perspective and from that population of neurons has been shown to be important in locomotor and gait function. So yeah, I think when it's translated to humans, obviously there would need to be, not just efficacy studies, but also the safety trials. This class of drugs, ampakines, have been looked at previously. There have been early trials previously in like Alzheimer's and I think Parkinson's as well. And I think there are a couple companies, there's a lab down in Florida that's now looking at this for breathing after cervical spinal cord injury too. So I think they're early stages, but I think there is some appeal to use them in clinical trials.
Okay, terrific, very exciting. Thank you so much. Okay, I think at this time we're just going to segue directly to the best abstract presentations. And so many thanks again to all the faculty that have participated in adjudicating the abstracts as well as for the elevator pitches presented today. So the first presentation, first place tie is going to be provided by Andrew Frizzato, who basically will speak to us about transvertebral passive imaging of microbubble activity in the ex vivo human spinal canal, supervised by Dr. Megan O'Reilly. Thank you.
Well, thank you for the introduction, and thank you for having me speak here today. So this talk, a lot of jargon in the title, but it fits quite well with today's theme of minimally invasive surgery on the more less invasive of being completely non-invasive. So I'll provide a bit of context for why we want to do this, a bit of historical background on the technology, and then diving into some pretty technical engineering stuff that I'll try to make as accessible as possible. So our interest is actually to bypass the blood-spinal cord barrier strictly for like drug delivery applications for a variety of pathologies. And the blood-spinal cord barrier's main purpose is to construct and maintain the specialized microenvironment of the central nervous system. So I don't know where the laser is, but the barrier itself is constructed with specialized endothelial cells that are non-fenestrated, so they limit a lot of transcellular transport, and then the tight junctions that bind those adjacent cells together, which further inhibit paracellular transport. So the barrier itself, while it performs a lot of crucial function, it really limits our ability to deliver systemically administered drugs from the blood getting to their parenchymal targets. Obviously, this is a huge barrier in getting anything therapeutic to reach its target and doing any sort of effect. So we want to modulate that barrier. And this builds on some previous work from pioneers in the field. Kalervo Hinnanen showed in the early 2000s that you can precisely and transiently open this barrier using focused ultrasound and microbubbles. So this was again in the brain with the blood-brain barrier analog. But now this technology scaled its way up to clinical trials for, again, variety of indications. You may see this stuff in the news, but most recently they delivered immunoglobulin to ALS patients. So that was a world first, again, all at Sunnybrook. They use microbubble contrast agents off-label. So these agents, they do provide contrast in standard ultrasound imaging, but they also provide leverage when you're using focused ultrasound, and this lets you do delicate tasks of actually opening this barrier without causing any sort of blood cell extravasation or vascular damage to the surrounding endothelium. So I'll use the term cavitation here. Cavitation in this context just means microbubble activity. So when they're stimulated by ultrasound, they oscillate and undergo cavitation. Mind you, we can control that cavitation into a safe way. Shortly after the initial demonstrations in the brain, this was shown in the spinal cord using the same technology. So these are pre and post MRI images where you can see gadolinium contrast enhancement post-treatment, just showing that you actually did achieve the effect of opening the barrier, and it's precise and only in the region where you actually targeted it. So we have pre and post images, but what actually happens during the treatment when the microbubbles are actually undergoing cavitation, and that's where this project is situated. So the microbubbles, while they're inducing all those bioeffects on the surrounding vasculature and undergoing cavitation, they also emit or backscatter signals in a very characteristic and nonlinear way. And we can pick up those nonlinearities as in forms of treatment monitoring directly where the microbubbles are doing their treatments. So you can see here that as you increase in focal pressure, you get more and more interesting behaviors and interesting backscattered signal with initially at lower pressures, just integer multiples of the fundamental frequency known as harmonics, or step below, further higher pressure, you have half-order harmonics known as sub and ultra harmonics that really start to say, okay, we're doing some treatments to the barrier and it's likely that the barrier will be opened. And then if you keep ramping up pressure, you can get broadband emissions, and this can actually be indicative of damage to the surrounding tissue as those bubbles, they lose their integrity under the ultrasonic stress and they collapse, creating a near singularity, and that can induce a lot of violent effects, which we obviously want to avoid as this is a transient treatment. So we use those acoustic emissions to control exposure and pressure levels. And if you have enough ultrasound detectors picking up the same ultrasound events, you can start to do some imaging, and that's where this type of technology falls into place. So we sonicate with a focused ultrasound transducer in blue. They undergo cavitation, scatter those signals non-linearly, and then you pick it up with some sort of ultrasound detector array, which can use the phase differences due to the time of flight from these microbubble backscatters to construct an image. So now I'll kind of break down a lot of the jargon that was in my title. So transvertebral, we want to do this through the intact spine. Again, so if you have cancer patients who couldn't undergo, or cancer patients with severe metastatic disease who might not be eligible for treatments, you want to do this through their fully intact spine. Passive imaging, I'll talk about that right now, and then we're doing this at the clinical scale in the human spinal cord or spinal canal. So this is going to be ultrasound-guided, focused ultrasound therapy, and I'm developing the image guidance. And there's two kind of terms here thrown around as passive and active. Active ultrasound is what you're most familiar with. They provide those structural images of the body. So you send in a pulse, you wait for those echoes, which come from reflecting off, structures inside the body. We pick up those echoes and construct the image. And that's just a transverse slice of, ultrasound, just a spinal column ultrasound in the active form. And you can, of course, use contrast enhancement if you want to view certain structures, specifically vascular networks. Then passive ultrasound, the generated images just look like heat maps. It just tells you where acoustic signal is coming from in the body, and from those nonlinear scatterers, you can have good contrast for where those emissions are coming from. So the same picture I just showed you on the previous slide. We look at the microbubble emissions themselves for reconstructing, and we try to reconstruct those images, and obviously we're limited by just the wave nature of things. So in blue, that would be our sonicating, our focused ultrasound transducer. We've measured the acoustic field and placed microbubbles at the green X, and when we reconstruct the image, there's obviously a bit of positional shift, but we're able to localize within a millimeter or so where the actual emissions are coming from. So we want to do this, which was done in water, through the bones themselves, which obviously deteriorate image quality. And that is, again, just for monitoring cavitation and monitoring this type of treatment inside the intact spinal column. So we have done a lot of development of this technology in our lab at the clinical scale. We're one of the only groups in the world working on this currently. So that is an example of a spine-specific phased ultrasound array. So each of those are individual ultrasound transmitters. They're sonicating the spinal cord, which is shown in red there. And there's a couple of blue dots that show just the laminar faces and where some interesting physics happens. So here's a cross-sectional image trying to show you the acoustic fields or the acoustic beam paths of the way sound is traveling. We sonicate through the laminae just for the minimal amount of bone possible for this type of treatment. And we've got microbubbles inside the canal, inside that vasculature, and then inside the prelaminar tissue, which is musculature, connective tissue, etc. So sound goes on, it goes through the bones, obviously gets highly attenuated and aberrated and all this heterogeneous propagation, and it goes on to create a focus inside the canal. There's also reflection at the soft tissue and the bone interfaces. And due to the shape of the spinous and transverse processes, it gets refocused and collected back into the prelaminar region, exciting those bubbles as well. So this is just a simple demonstration, but the bubbles are driven by the ultrasound field. They get compressed and they rarefact under positive and negative pressures. They emit those emissions that we want to pick up and try to localize specifically the cavitation inside the spinal canal, the most delicate tissues, and try to understand what's happening in between. So yeah, we have another spine-specific array inside the transmission array just to do all this co-aligned image formation. So I've modeled this in simulations just to see what happens when you have cavitating sources both in the canal and outside the canal. And outside the canal, there are no intervening bone structures, so those emissions are going to be quite loud and overwhelming in images. But sometimes you can localize them all. You can localize both the prelaminar and canal sources. But again, due to that amplitude mismatch, you are unable to see the delicate tissue in the canal. This suffers from signal washout and a bleeding of the sources that occur in the prelaminar tissue. So this is obviously a detriment. We are unable to monitor this type of treatment, so we want to improve on that and figure out ways to see what's going on. So we looked at alternative reconstruction methods. Can we make these images in a slightly more sensitive way to see what's happening inside the canal on a more consistent and robust basis? So we did this in ex vivo with a spine-specific array prototype, which you can see there, which I had a part in building along with others in the lab. And we had microbubbles, or those ultrasound contrast agents, flowing in tube phantoms in the spinal canal from an ex vivo spine sample. And then we also modeled that prelaminar tissue with microbubbles in solution just floating in actually nitrile gloves. So I tied off the gloves, I inserted them in the prefocal tissue, and we did our experiments with some interference. And those are just the details of the array. So from what I showed previously with the emissions, we're monitoring at the second harmonic, and these are very low ultrasound frequencies. And this is all in efforts to get as much sound into the spinal cord, and then of course enough sound out that we can monitor. So these are ex vivo images. They're actually generated in 3D. They have over 500,000 pixels or voxels in them, and we're just looking at a projection in 2D right now. This vertebral overlay comes from a registration protocol that I've done, so that's not actually part of the image, it just provides reference. So you can see very noisy images, but you have an actual source appearing in the canal with some background noise, and this is using the gold standard reconstruction method that we tested previously that I had just shown on the previous slide. The alternative methods were using some nonlinear beamforming or nonlinear reconstruction, and this is to boost signal sensitivity in areas where it thinks there's an acoustic source. So this would provide a bit more sensitivity in the canal. And here they start multiplying the signals together as a fine detail. But most interestingly is this third option, which really leverages the spine-specific array. So this array is designed to go through both laminae, and the actual focus of each of those panels is the same. So it overlaps in the canal. And if we take images, one with one panel, one with another, and then superimpose those images through multiplication, we were hoping it would boost the mutual information seen from them, and then, again, improve image quality. Of note here are these side lobes. So beside the main lobe, that main streak, the side lobes, they come as a detriment. They can cause ambiguity, and they're obviously something we want to avoid, so that's why the third option looks nice. It's nice and painted over and smooth. But we use that as an image metric to kind of evaluate things here. So peak side lobe ratio is shown here, and these are crazy N numbers, over 20,000 actual individual emissions I analyzed here. When the peak side lobe ratio reaches 1, that's not great. That means there's multiple big lobes that you can't actually discern where this signal is coming from. We want it to be as low as possible, and as low as possible would make it a good frame, and we could have as many frames as we wanted. So we could just see the different beamformers improve upon the gold standard of delay and sum. Now for a subset of those, I looked at using aberration correction in these images, and what that does is it just corrects for the degrading effects of the bone. So if that bone is doing something, can we eliminate it? And we just show for one of the beamformers that when we use phase corrections to correct for phase, or phase and amplitude to correct for phase and the attenuation of the signals, then we get improvement across them both. Now, when we have those prefocal sources present, and that the big issue that it causes with regards to interference, this is a demonstration that when we do this ex vivo, we can actually see in some confidence level that there is cavitation occurring, but that confidence goes up with the change of the beamformer, which we initially were investigating. So that's just a demonstration ex vivo. And some of the key findings here, the alternative beamformers obviously outperform the gold standard. Aberration correction can improve upon image quality, and that can again provide more confidence to our images. This data suggests that clinical scale implementation is feasible, though this prefocal cavitation can still pose a big problem. So there's kind of this open question, as if we can't suppress it in images, can we eliminate it before they present themselves in images? So I just want to thank my lab and everyone who made this work possible, and happy to field questions.
Okay, terrific questions. It's very fascinating work, and I guess when we're sort of thinking about potential clinical application, this is sort of done with the intact lamina. Sometimes we're there at surgery, we've got an open lamina. So I guess I had questions about, I guess the potential different models. And then with the samples that you've been able to test, I guess how much variability or consistency was there in those human samples? The patient population that we treat, the bone density as an example can be extremely, extremely variable, and you've got everything from extremely sclerotic bone to very fragile, irregularly defined sort of bone structure, and how that may influence the success of the approach, I guess.
Yeah, great questions. So for your first question on when there's no lamina present or the posterior surface of the bones have been removed. So when this project was first taken on, we wanted to solve the most difficult problems first. So all this work was done in the thoracic spine, fully intact. You're limited to a fully posterior approach given the ribs and anterior organs. Sound will just not go through. So what we wanted to do was solve all the problems associated with the bones. Now, we do have pretty good understanding how ultrasound propagates in soft tissue and all those effects. So if we don't have the bone there, then in theory, this should be a simpler problem. You're not going to have the aberration caused from the bone. You can operate at lower levels because you don't have to get through that bone. So some of the interesting things that would happen without the bone there, we're kind of solving on the fly. But you're right, it's something that would definitely be possible given the right aperture choice, so given the right array. Now, with regards to your second question about the variability of patients, variability in bone density, geometry, all sorts of that, even given, you know, the weight of a patient, how much fat or other tissues are there between you and the spinal cord, that's something that needs to be taken account, obviously, in every treatment. And the treatment planning pipelines that we have right now are predominantly through simulation, and all this stuff can be picked up ideally on a preoperative CT. Through that preoperative CT, we take the Hounsfield units and assume or estimate the density of the bone, and then through that, there's another conversion factor that turns this all into acoustic property maps. And when we have the acoustic properties of that very specific patient, we get the geometry and the actual density, convert all the speed of sound and everything needed to do to run these treatment planning simulations. And when those are formed, then you can do a patient-specific approach, target-specific approach. If the lamina is there or not, you can obviously put that in the simulation and model that as well. So trying to be as flexible as possible while solving the most complex problems in the meantime.
Dr. LaRouche, you've got a lot of experience with
I'm very impressed with the
clinical.
accuracy that you demonstrate in your models. I'm thinking about this from a slightly different perspective, which one of the challenges we have is often imaging the spine in an accurate enough model to get navigation to be within that plus or minus 0.2 millimeters of accuracy. Would your transmitter array be suitable from a different perspective to do through the skin imaging of the spine for the purpose of obtaining a navigation registration, as opposed to what you're currently employed in, which is in vivo next to the lamina? So if I add that 3 to 6 inches of fat and tissue,
Yeah.
could you still give me that same accuracy in rendering without looking through the lamina, simply from a dorsal registration purpose?
Yeah, no, that is interesting. I mean, in the brain, they've tried to do the same thing. As again, this is all like MR guided for those pre and post stuff. So what they want to do is acoustically guide that and eliminate the need for MR for registration and navigation standpoint. So you can do it. There is methods to do pulse echoes and tracking those echoes just on the bone surfaces. Pretty difficult to implement with the low frequencies and stuff required, but you can, again, design specific apertures that have a high frequency component to do that as good as you possibly could. I'm just getting into in vivo stuff with a clinical scanner, so I can appreciate how difficult it is to do navigation by hand and landmarking and everything. So having those pulse echo specialized receivers for registration for doing this treatments in the future, to have like a static bed with the array in it and do all the navigation, all the planning, that's kind of like futuristic goals if we could actually realize it.
One of my other hats, full disclosure, is I work for GE, helping them with their ultrasound and spine technologies. And where the holy grail is, for example, is think of the number of biopsies, ablation, selective nerve root blocks, even a tough epidural injection. So the idea is that the majority of people in clinics don't have access to ionizing emitting C-arms if you're a pain physician. The technology you've demonstrated could be a huge bridge towards enabling a lot of the clinical activities we do in an environment that doesn't require radiation.
Yeah.
So if you've thought about it, or if you haven't thought about it, I'll put you in touch with some people.
Yeah, no, that's great. That's great stuff. Yeah, no, I appreciate it.
Terrific. Excellent. Thanks so
Great.
much. And
Thank you so much.
Okay, on the clinical abstract awards, we've got a first place tie, and first presentation will be given again by Dr. Shakil, talking about survival after spine metastasis surgery.
Thanks very much. I'd like to thank the organizers for SpineFEST for recognizing this work, and as well my supervisor, Jeff Wilson, for all the support during the development of this project. So I'll be presenting today the development and validation of a clinical prediction tool for estimating home time and survival after surgery for metastatic spine disease. So metastatic spine disease is typically a marker of advanced cancer and often is really a herald of end of life. And often patients who have this condition require multidisciplinary care that can be upwards of $500,000 per patient for the first 60 days of treatment. Treatment can involve a number of things, primarily for local control is surgery and radiation therapy. And when we looked at this patient population in Ontario, we found that it's really growing in the last 10 to 15 years by a rate of about 2% per year, so as much as 20% since 2015. So one of my motivations for working with this patient population was largely driven by an experience as a junior resident. I was really struck by the fact that the outcomes for patients with this disease really fell along a wide spectrum. So some patients right after surgery, as unfortunately within 2 weeks, would sustain a mortality, whereas others, were able to make it home and spend meaningful time with their families. And one thing that I found was that really a big challenge with this patient population is selection and counseling around surgery. And a previous study has actually shown that surgeons themselves often don't agree with each other in terms of estimating survival after treatment. So if you can imagine, if you expand the scope of care to oncologists as well as patients and their caregivers, you can really imagine as a patient, you're probably being bombarded with a number of different expectations for how you'll do after treatment. So a number of tools do exist for prognosticating after surgery, but a lot of these focus predominantly on survival. So I'm sure a number of you have heard of the Takahashi score, the Tomita score, or the SORG nomogram, and they do have pretty well validated accuracy for estimating survival. But the problem is that the goal of treatment typically is improving quality of life and not sort of the nominal value of the amount of time spent alive after surgery. So there is some work done by Nick Nader, a prior resident here at U of T, that has put together a really nice clinical prediction tool for predicting quality of life after surgery. And what she found was that she was able to predict with pretty good accuracy both survival and achievement of the MCID after the clinically meaningful improvements in a generic health quality of life outcome known as the EQ5D after treatment. But one of the challenges with the EQ5D is that sometimes it's not as interpretable for patients. It often requires physician-administered questionnaires. And I think there still is a case to be made for this endpoint known as home time. So home time has been a metric that's been used in the critical care population as a pragmatic and easily interpretable outcome to patients, and is really measured as the number of days spent at home after treatment. And we've been able to validate this outcome within this patient population as a patient-centered outcome that's internally valid and meets a lot of metrics for a construct endpoint that is meaningful for this patient population. So I think there's still a case to be made for looking at home time for patients with spine metastases. It's interpretable, easily measurable from generalizable data sets, and moreover, we validated it for patients with spine mets. So the tool the goal of this study was to develop and validate a clinical prediction tool that predicts home time as well as survival after surgery for spine mets. And we title this the Home Time and Overall Survival After Metastatic Spine Surgery Estimator, or also known as the HOME score. So to do this, we employed a provincial data linkage, a unique cohort of patients that were identified by linking the Ontario Cancer Registry with the Ontario Health Insurance Claims Database with Cancer Care Ontario activity level reporting to identify a cohort of patients, about 2,300 patients that were treated for spine metastases with surgery between 2005 to 2020. We allocated patients who were treated prior to 2019 to the training and development cohort, and then again we reserved a temporally distinct validation test set between 2019 and 2020, about 300 patients. So this is a description of our two cohorts, mean age about 64.4. Most common primaries were lung, myeloma, breast, prostate, and neurologic cancers. And most patients, as can be expected, were suffering from thoracolumbar metastases and were treated with a posterior laminectomy infusion. So in terms of how we developed the model, we essentially, again, we had two primary endpoints that we were hoping to predict. One was home time, which was treated as a dichotomous variable by identifying those who spent less than 3 months at home, and this could be either contiguous or non-contiguous, and then survival, which was treated as a time to event variable for mortality and modeled through a Cox proportional hazard model. A lot of our work was done to identify prognostic factors that would be incorporated in the model, and we included both demographic, comorbid factors as well as cancer and presentation-related factors. So there was a total of 27 candidate factors, including age, sex, home location, distance to cancer center, as well as factors predictive of how likely a patient would have perioperative risk, as well as markers that really give a sense of the advanced nature of their cancer, so the type of primary malignancy, the year since their diagnosis, the nature and types of prior adjuvant treatment received, as well as the types of systemic metastases that the patient had at the time of presentation. Finally, we incorporated presentation factors such as the presence of a prior ICU admission, the number of ED visits prior to presentation, the presence of paralysis or spinal cord injury. And then for our model development, we included or tested a number of different architectures, including general linear models, nonlinear models modeled using cubic splines, as well as gradient boosted and lasso methods. So to select the optimal model, we used what's known as a tenfold cross-validation, and then selected on the basis of the AUC for the home time model and the C-index for the survival model. And then we used standard calibration as well as performance metrics to evaluate the performance on of the model on the holdout test cohort. And then finally, to specify our model and share it with the general public, we implemented a pictorial nomogram as well as an online calculator which could be used. So this is a summary of the results. So the architecture that had the best performance in terms of AUC for the home time model was the lasso linear model. So this was AUC about 0.74 on our training cohort without significant loss in performance on the holdout test cohort. Similarly, for the survival model, we had a C-index about 0.70 on the training cohort without significant loss on the holdout test set. Similar architecture of a lasso linear model. So calibration was really shown to be well calibrated across a number of predicted probability estimates. And this is a pictorial depiction of our actual home score. So there were about 17 factors that were identified to be important for predicting home time and 24 factors for predicting survival. And this could be used as any normogram. So basically, with a patient in front of you, you could tally up the different components and then use that to translate to predicted survival as well as likelihood of surviving longer than 3 months. And of note, we mainly included factors that could be accessible by any clinician across the province. So this would be anything that you could gather from sort of a Connecting Ontario search or through assessment and chatting with the patient in front of you. So again, this is showing the translation between the home score and the predicted probabilities. And what we did is we looked at validating the different scores. And what we found is that, again, patients who were predicted to have less home time were in fact measured to have significantly lower time at home after treatment. And similarly, patients predicted to have shorter survival were in fact shown to be measured to have less survival after treatment. So proof of concept there. When we looked closer at the prognostic factors, what we found was that the three most important factors for predicting survival and home time after surgery were the type of primary malignancy, which was not very surprising, the presence of congestive heart failure, and the presence of significant paralysis or spinal cord injury at the time of presentation. And this, again, recapitulates that, showing that there are significant differences in the survival curve based on these 4 different factors. So in summary, I presented here a tool that we've put together for estimating home time and survival after surgery for spinal metastases. I think this is quite important as it helps incorporate a predictable and reliable metric for patients that can be interpreted both by primary care practitioners as well as caregivers at the time of counseling for surgery. I think some of the next steps is to integrate sort of patient performance metrics as well as molecular markers and radiographic biomarkers of instability and things of that nature to a multimodal kind of clinical prediction tool, but looking forward to that as close next steps. And I'd like to thank again my supervisor and all the collaborators for this work, and I look forward to discussing it further.
All right. So excellent work. I guess I had some questions, I guess, relating to as we think about the translational steps, and I think we all envision a not too distant future where a lot of this information is very relatively available in the EMR and can be automated. And I can't imagine a physician at 3 in the morning and patient showing up in the emerge having all that information readily available. And you call radiation oncology or med-onc, and you're unlikely to get the MRP of that patient to have that information. So I guess with the model itself, any opportunities to refine it, to reduce the number of items that may be required to still have a reasonable sense? And I guess your thoughts in terms of the practicalities of that implementation, recognizing yourself, treating these patients on call and so forth.
Yeah, we try to strike a balance between, recognizing the fact that it's a very heterogeneous population, so you don't want to parse it down too much. We try to use kind of statistical methods to balance what's known as basically the statistical accuracy and generalizability of the model versus the number of parameters so that it's not overfit. And we found that the number that we landed on was generally balanced between the two. I think that some of the points that you made is as things become more electronic, a lot of these variables can be easily ascertained from the medical record and probably could be automated, like in terms of filling out that questionnaire. And then I think part of that might help with some of the user challenges and some of that UX design in terms of implementation might help with that throughput. But I think a lot of this is to be used within like a more in-depth conversation with the patient about how much they do want to proceed with surgery or how much you might recommend it depending on what you expect. So hopefully that's happening in a more kind of well thought out conversation, and maybe these factors could be assessed at that in that kind of way.
Okay. If, no other, Dr. Hardesty.
Yeah, thanks. Interesting approach for sure. I'm wondering about, what do you think the bias in your data set is? So these are all like, so I think that, whenever you're creating a prediction tool, you should think about the data that it's come from, because you're kind of mirroring that. So I guess I was thinking like, these patients all decided to proceed to surgery.
Yeah.
Whereas presumably there's a cohort that got considered that didn't end up going into your scoring, and I wonder, how do you think that affects your result? How do you think that affects your translation?
Yeah, for sure. I think you raise a really good point that all these patients were ultimately actually treated with surgery, so there's probably some selection of appropriateness. I think we still had a reasonably large number of cases where the home time was quite short and the survival was quite short. So in terms of our case event number, we fell within our appropriate sample size for that. I think some of the strengths of this study is actually that it's from real-world clinical data, province-wide, not sort of specialized centers alone. But as you can imagine, I think it would be interesting to do a study within maybe patients prior to actually undergoing surgery, maybe prospectively evaluating them at the time of assessment, and then looking how the tool does after the fact, because this was, as you mentioned, done in a retrospective fashion.
Okay, thanks
very much.
Okay, the other first place tie in the clinical research category under Best Abstract will be given by Lauren Daunt, undergraduate student at the University of Toronto, supervised by Drs. Lewis and team, and she'll provide an update regarding adult spinal deformity patients and surgical intervention relating to social functioning in older patients. Thank you.
Thank you, Dr. Yee. Hi, everyone. First off, I want to say that it's an honor to be here with you all today and to have even been considered for this award. My name is Lauren, and I'm going into my 3rd year of undergrad at the University of Toronto in human biology, physiology, and immunology. and today I'm going to be sharing a bit about the work that my group and I have been doing with Dr. Lewis over the past year about how surgery improves the social function in older adult spinal deformity or ASD patients based on our PEDS database. So what exactly is social function? Well, social function is recognized as a domain of health-related quality of life, and it's defined as the ability of a patient to go out, to integrate into society, and to build relationships. Now, ASD impacts all domains, including social function, and although the effect of ASD and its treatment on physical and mental domains has been well described, there is very limited data on how social function is affected, especially regarding the elderly population. So we've recognized that this was less understood, as most studies typically emphasize the biomedical outcomes of surgery. So with ASD or scoliosis affecting patients every aspect of their lives, from their mental health to their self-image to the way they walk, interact, and ambulate, an important reason why they do seek surgical treatment in the first place is to return to their normal role in society and to have a normal social life. So with that, the objective of our study was to investigate the impact of surgery on the social function of ASD patients aged 60 years and older using patient-reported outcomes. And so with this, we hypothesized that ASD patients who do undergo surgery would experience improved social function at 24 months post-operatively compared to baseline. So just about the methods of our study, this was a prospective, multi-center, international, and observational study focused on patients aged 60 years and older from the PEDS database. And they were all undergoing primary spinal fusion surgery. Our primary outcome measures of interest were both the Oswestry Disability Index, so the ODI, question 9, and the Scoliosis Research Society questionnaire, questions 14 and 18, which I will explore further shortly. So here's just a bit about our methods. So from the SRS questionnaire, there are 5 domains. And so we went through each of the 5 domains and we identified the questions that we felt most pertained to social function. So that was from both the function domain and the self-image, questions 18 and 14. And question 18 essentially asked, does your back condition limit your going out with friends and family? While question 14 asked, do you feel that your back condition affects your personal relationships? So the answers range from very often to never for questions 18 and from severely to none for questions 14. And with our results, we visualized them using Sankey diagrams and our graphs. So we categorized if they answered very often to sometimes and severely to mildly as low social function. So here is a breakdown of the ODI. So there are 10 sections in the questionnaire with one specifically labeled social life. And what it asks is how much impact that pain would have on a patient's social life. So responses range from their social life being normal and causing no extra pain, all the way to them having no social life due to pain. So as for the demographics of our study, the variables that we collected include age, gender, BMI, work status, and ASA grade. The median age was 67.5 years, with 60.3% of patients retired. And along with that, we also collected the animal fluency score mean to assess their cognitive function, and that demonstrated that about 26% of patients were actually below normal cognitive function. So as for the results of our study, from SRS question 14, we can see that almost 60% of the cohort did have low social function related to personal relationships, and that changed to 29.4% at 2 years, and that's visualized in this graph here. So this trend does suggest that patients experience a reduced impact of their back condition on personal relationships following surgery. Next, for the capacity to go out, for the SRS question 18, we can see that regarding the capacity to go out, more than 75% of our cohort felt significantly limited in going out, and after surgery at 2 years, that proportion went down to 44.3%. And finally, for ODI question 9, 63% of patients felt that they were restricted in their social life before surgery, and that improved to just 25% of patients post-operatively. So we can see a similar trend among the 3 of these metrics. And next I'm going to go into the shift tables that we use to depict our results. So as you can see in the dark blue, that represents patients who stayed the same before and after surgery based on how they answered the questionnaire for the SRS question 14. The pink are patients who had improved outcomes, and the purple are patients who scored worse. So for this question, we can see if you look at the first row where it says 1, if we go to the far right, there were 33 patients pre-op that felt that their back condition very often affected their personal relationships. And after 2 years, we can see that 3 remained the same, so they answered 1. 8 answered 2, 4 answered 3, 6 answered 4, and 5 answered 5. So we saw that many of our patients did shift to 1 point or more higher than their original score. And if we look at this next table, we can see similar trends for SRS question 18. So when asked whether their back condition limited their going out, we saw that 61% of patients reported low social functioning, so they reported scores 1 to 3 before surgery, and this proportion was reduced to 32% at 24 months postoperatively. And finally, for ODI question 9, which assesses how much back pain affects patients' social life, only 34.7% of patients reported high social functioning or scores 0 to 2 before surgery, and this figure improved substantially to 58% at 24 months postoperatively. So meanwhile, we can also see that the proportion of patients who reported low social functioning, so scores 3 to 5, dropped from 63% to 26%. And this indicated a marked improvement in social participation after surgery. So we decided to visualize our data with this Sankey diagram, and this shows the shift in social function from pre-op to post-op based on ODI question 9. So on the left, we've grouped patients based on 2 categories, those with pre-op high social functioning at the top and those with pre-op low social functioning on the bottom. So on the right, you can see where these patients ended up 2 years later, and the width of these flows represents the number of patients in each of these transition pathways. So as you can see, the majority of patients who began with high social functioning remained in that state post-operatively, which is a very positive sign of stability. But more importantly, a substantial number of patients who started with low social function transitioned to high social function by 24 months. So this confirms that surgery doesn't just preserve patients' quality of life, but in many cases it actively restores their ability to engage socially and to live fuller lives. There were a few limitations that we identified in our study, the first being the retrospective nature of our analysis. Though it was based on a prospectively collected database, we didn't have a comparison group, so that might have introduced some bias. We also used measurement instruments that may not fully capture the entire social functioning phenomenon as affected by ASD, but it might rather focus on just pain-related limitations, which might oversimplify the changes that our patients experience. And these outcome forms weren't initially designed or validated to be used in isolation, as has been done in this study. And finally, we used a follow-up period of 2 years, and though it was adequate for our data, it might be short for understanding the long-term transitions in social functions after surgery. So ASD surgery has a significant positive impact on social functioning. We saw that more than half of low social functioning patients will shift to high social functioning. And conversely, there were a lower proportion of high social functioning patients that will shift to low, as we saw in our Sankey diagrams. So because the cohort of patients consisted of people from diverse regions worldwide, our results have enhanced external validity, applying to a broader sociocultural context. And we believe that the results of our study are important because social functioning is a fundamental aspect of health-related quality of life, and it's frequently overlooked by studies, which often emphasize more biomedical outcomes. And this data is useful in determining the expected outcomes following ASD surgery in older patients, and also attributes to the positive physical and mental benefits of these complex procedures. Thank you so much.
Lauren, this is really good work, and congratulations to you and your supervisor.
Thank you.
You know, I think that this kind of highlights the way we need to start thinking about outcomes, and this is kind of more reflective of the WHO ICF framework, right, where we look at not just something that we usually measure like neurological function, but we also look at the impact on participation in these types of issues. So I think this is kind of important, and I think this would actually probably help to frame the impact of surgery in even a more kind of positive way. My question here is that there are other things that will, of course, impact on social functioning, and I just was wondering if in your database you looked at metrics such as social demographic factors such as educational level, marital status, income status, because obviously these also will impact on this. Are those important variables here?
Yeah, for sure. I think with the study, we did collect all of that data because it was such a large study. It was a multi-center, I believe it was from 12 international centers or something to that effect. So I do believe those are very important, and those are factors that do affect social functioning. That was also a reason that we decided to look at cognitive impairment, because we saw that there are obviously complications and there's cognitive impairment that does affect the outcomes of surgery, but we saw that that wasn't associated with social functioning in our analysis. So yeah, great question. Thank you.
Dr.
Great
Madoli?
study, congratulations. Back to Dr. Failing's point, do you think, did you were able to match pain scores and self-image and how that might be driving their quality of life? Did you look at that in comparison? Their pain comes down and their image goes up, and then their quality of life gets better. Did you able to look at some of those factors?
Yeah, so with the SRS questionnaire, that was a really nice outcome measure that we used because we felt that it really integrated well together with all of the questions that were asked related to specifically function, mental health, and pain. Those were also really big ones. And we actually saw in our results that those were all independently associated as well. So it does also contribute to social functioning. That wasn't something we looked at specifically in our study, but when you look at the trend in the data, you could see that there were improvements across those measures as well.
Okay, terrific. Thank you so much.
Thank you.
Presentation. Okay, that's really been an enjoyable day, and I think we're headed towards the next terrific part of the program where Michael and I are able to sort of provide the awards to the audience. So many thanks to all the faculty for their engagement, their support, their mentorship of the students. Many thanks to all our trainees from both the clinical and fundamental streams. It's really great seeing the results of your dedication and your work, and I think a lot of synergies between actually the bench and the clinic in many instances, which is often very, it's really amazing and something I think we strategically try to promote and nurture. Many thanks, Professor Wang, for a very inspiring talk and continuing to challenge us on doing the best on behalf of our patients, and to continue to sort of strive to sort of advance the technical abilities of what we're able to do in a meaningful and strategic fashion so that we can enhance our patients' recovery and obviously try to support their spine health. And again, as I mentioned earlier, really value the opportunity to work with the program council and with Michael and the team within our office to support our educational efforts on behalf of our trainees and our faculty to provide that opportunity to engage and interact together.
Terrific. Well, it's been a wonderful day, and many thanks to Nadia Jabber for her superb organizational skills in putting this together. Many thanks to the volunteer team, to Jane and the program council and the whole team, in particular the trainees, and of course our fantastic Tatter Hall speaker, Professor Michael Wang. Michael, I wonder if you'd mind coming up. We have a few little gifts for you. Okay, so let's see. something for your office. Okay. The coveted University of Toronto
Oh, yes, tie.
tie.
Is that
yes.
DNA on there?
Yes.
This
Of
is-
course, yes.
Oh my God. It's like DNA.
a needle.
With a little needle there. In the
Yeah,
end.
I see it now, yeah.
Here, let's get a picture.
God.
Okay. All right. Okay, a couple of other things. A little book for your library.
Is it signed? It's signed?
Autographed, of
Okay,
course.
perfect.
And then, you know how they say check in the mail? Here, check can't deliver. Because I'm not sure we can rely on our postal services these days.
Thank you very
All
much.
right,
Thank
thanks.
you. Thank you.
Thanks so much.
Thank you, Albert. Thank you.
Great, and then we just have a number of certificates of recognition and appreciation, and a number of award winners. And really, I'd have to say that, it's sometimes a little bit arbitrary to choose the award winners. I think all of our trainees did just absolutely amazing, and I found it actually quite remarkable. The quality, in particular, of the very kind of brief elevator pitches, and I just want to compliment all of the speakers. So maybe a round of appreciation for all of our trainees.
Okay, so Andrew Frizzato, best paper, basic science, transvertebral passive imaging of microbubble activity in the ex vivo human spinal canal. Congratulations again.
Let's get a picture here. Yeah, my phone does that all the time too.
Awesome, thank you very much. Thank you.
And the next category is clinical, and best abstract tie, Lauren Daunt.
Very nice work.
And Dr. Hussein Shakil, best abstract tie, clinical on your home project.
Yeah, great job. Great job. You're a star.
Okay. In terms of our elevator pitches,
Two winners. So if we could ask Tiffany Lung to come on up. And Chris Lozano. Yeah, nice job. Nice job. And let's get a little picture.
okay, so terrific. So that sort of formally concludes our program for this afternoon. I guess for the clinical fellows and graduating trainees, we look forward to connecting soon in a few hours at the Sonesta Hotel. I think it's around 6 p.m., I believe. And we'll obviously have the more formal graduation ceremony for our graduating fellows at that time. Many thanks again. Safe travels. Be well. And really appreciate the support again for another successful SpineFEST meeting.